opportunities at centers of excellence overseas. We undertake science, technology, and innovation policy research to make recommendations for policy formulation. We conduct National Research Development and Innovation Survey annually, producing the Sri Lanka Science, Technology and Innovation Statistical Handbook. We maintain a database of S&T personnel, strategic research equipment and ongoing research, and investigates, collects and secures indigenous knowledge and practices in Sri Lanka. NSF publishes 2 international and indexed journals: Journal of National Science Foundation, Sri Lankan Journal of Social Science, attracting a rapidly increasing number of quality research papers. NSF also supports publishing in reputed journals, indexed in the Science Citation Index, Science Citation Index Expanded, and Social Science Citation Index to ensure greater visibility for Sri Lankan R&D activities. NSF rewards local scientists, engineers and technical personnel who have made outstanding contribution for the development of science and technology under different award schemes, including National Awards for Science and Technology Achievements, NSF Research Awards for Outstanding Research Performance, Support Scheme for Supervision of Research Degrees, the World Academy of Sciences National Science Foundation Young Scientist Award. Several special projects and programs are implemented by NSF to meet national needs. They include UNESCO Man and Biosphere Program, NSF Research Program on Health Science, and a special project on cinnamon in collaboration with the Ministry of Primary Industries. More and more strategic programs of the sort are lined up to achieve far-sighted goals set towards taking science and technology to the next level. NSF, with 5 decades of committed service, has contributed immensely towards economic growth and development of the nation, playing a significant role in the massive process of national development. NSF is committed as always towards exploring new avenues of development to pave the pathway of success for Sri Lanka by holding hands with scientists, engineers and technologists.
ශ්‍රී ලංකාව විශ්මිත අනාගතයක් කරා ගෙන යාමේ අභිලාෂය පෙරදරි කරගෙන විද්‍යාව හා තාක්ෂණය හරහා දේශයේ ආර්ථිකය සහ සමාජය ඉදිරියට ගෙන යාමට ජාතික විද්‍යා පදනම අඩ සියවසක් පුරා මහඟු කර්තව්‍යයක් ඉටු කරනවා. රටේ අනාගතය බහර ගැනීමට සිටින දැයේ දුවා දරුවන් වන ඔබව විද්‍යාව හා තාක්ෂණ දැනුමින් සන්නද්ධ කරමින් නවීන ලෝකයට දායාද කිරීම සඳහා අප විසින් විශේෂ වැඩසටහන් රැසක් ක්‍රියාත්මක කරනු ලබනවා. මෙම වැඩසටහන් සමග සම්බන්ධ වීමට ඔබට විද්‍යා සමාජ හරහා අවස්ථාව උදා කර තිබෙනවා. මේ වන විට දිවයින පුරා පිහිටි පාසල් 10කට අධික සංඛ්‍යාවක් හා විශ්වවිද්‍යාල විද්‍යා සමාජ 50ක් පමණ අපත් සමග ලියාපදිංචි වී සිටිනවා. ජාතික විද්‍යා පදනම මගින් ක්‍රියාත්මක කරන වැඩසටහන් පිළිබඳව කෙටි හැඳින්වීමක් ඔබ වෙත ගෙනීමට අප දැන් සූදානම්. විද්‍යා පර්යේෂණ ව්‍යාපෘති තරඟාවලිය ඔබ සඳහා සංවිධානය කරනු ලබන ප්‍රධාන වැඩසටහන් වලින් එකක්. පාසල් තුල පර්යේෂණ සංස්කෘතියක් ඇති කිරීම සහ ඔබ තුල නවෝත්පාදන චින්තනයක් ගොඩනැගීම මෙහි ප්‍රධානතම අරමුණු වෙනවා. මෙම තරඟාවලියට සහභාගී වීම මගින් ඔබට ජාතික මෙන්ම ජාත්‍යන්තර තලයට ගමන් කිරීමට මං පෙත් සැලසෙනවා. විද්‍යා පර්යේෂණ ව්‍යාපෘති තරඟාවලියේ ජයග්‍රාහකයන්ට ජාතික මට්ටමින් සංවිධානය කරනු ලබන ශ්‍රී ලංකා විද්‍යා හා ඉංජිනේරු සංදර්ශනයට සහභාගී වීමට අවස්ථාව උදාවන අතර එම තරඟයෙන් ජය ගැනීමෙන් ඇමරිකා එක්සත් ජනපදයේ පවත්වන ජාත්‍යන්තර විද්‍යා හා ඉංජිනේරු සංදර්ශනයට සහභාගී වීමට වරම් හිමි වෙනවා. අන්තර් පාඨශාලීය විද්‍යා සමාජ තරඟාවලිය ඔබ වෙනුවෙන් සංවිධානය කරන තවත් ප්‍රධාන වැඩසටහනක්. නොවැම්බර් 10 වන දිනට යෙදෙන ලෝක විද්‍යා දිනයට සමගාමීව තෝරාගත් විද්‍යාත්මක තේමාවක් යටතේ පාසල් විද්‍යා සංගම් අතර මෙම තරඟමාලාව පවත්වනු ලබනවා. කෙටි විද්‍යා නාට්‍ය, භූමිකා රංගන, විරිදු ගායනා, ගීත ගායනා, විද්‍යා රචනා හා ඩිජිටල් කතාන්දරකරණය ආදී තරඟ මගින් ඔබව විද්‍යාව වෙත ආකර්ෂණය කර ගැනීමට අප බලාපොරොත්තු වෙනවා. විද්‍යුත් හා මුද්‍රිත මාධ්‍ය ඔස්සේ ඔබගේ විද්‍යාත්මක දැනුම ඉහළ නැංවීමට මිහි මඩල වාර්තා වැඩසටහන හා විදුරාව විද්‍යා සංග්‍රාව අප ඔබ වෙත ගෙන එනවා. එදිනදා සමාජයට බලපාන ගැටලු පිළිබඳව විද්‍යාත්මක පසුබිම විමර්ශනයට ලක් කරමින් සිංහල, දෙමළ හා ඉංග්‍රීසි යන භාෂා ත්‍රිත්වයෙන් මිහි මඩල රූපවාහිනී වැඩසටහන විකාශනය කරනු ලබන අතර මෙම වැඩසටහන වසර ගණනාවක් මුළුල්ලේ ඔබ වෙත ගෙන ඒමට අපට හැකි වී තිබෙනවා. සිංහල, දෙමළ හා ඉංග්‍රීසි යන භාෂා ත්‍රිත්වයෙන් මුද්‍රණය වන විදුරාව විද්‍යා සංග්‍රාව පාසල් වෙත නොමිලේ බෙදාදීමට ජාතික විද්‍යා පදනම කටයුතු කරනවා. එමගින් විශාල සිසු දරුදැරියන් පිරිසක් වෙත නූතන ලෝකයේ විද්‍යාත්මක දැනුම ළඟා කරවීමට හැකියාව ලැබී තිබෙනවා. විදේශීය විද්‍යා අධ්‍යාපන මූල්‍ය යෝජනා ක්‍රමය මගින් විද්‍යා හා තාක්ෂණය පිළිබඳ නවීන දැනුම ලබා ගැනීමට හා විවිධ ජාත්‍යන්තර තරඟ සඳහා සහභාගී වීමට ඔබට අවශ්‍ය මූල්‍යමය දායකත්වය ලබා දීම අප විසින් කරනු ලබන තවත් වැදගත් සේවාවක්. මීට අමතරව විද්‍යා අධ්‍යාපන හා විද්‍යාව ප්‍රචලිත කිරීමේ මූල්‍ය යෝජනා ක්‍රමය මගින් පාසල් තුළ විද්‍යාව ප්‍රචලිත කිරීමේ වැඩසටහන් හා තරඟ පැවැත්වීමට අවශ්‍ය මූල්‍ය අනුග්‍රහය ලබා දෙනවා. විද්‍යාගාර යටිතල පහසුකම් වැඩිදියුණු කිරීමට හා විද්‍යා මධ්‍යස්ථාන හා අනෙකුත් විද්‍යා පහසුකම් ගොඩනැගීමට මූල්‍ය පහසුකම් සැපයීම මගින් ජාතික විද්‍යා පදනම ඔබට අවශ්‍ය පහසුකම් ඔබේ පාසල් තුළ ඇති කිරීමට කටයුතු සලසනවා. විද්‍යාව ප්‍රචලිත කිරීම වෙනුවෙන් පාසල් ගුරු භවතුන් පාසල් විද්‍යා සමාජ මෙන්ම විද්‍යාර්ථයින් ඇගයීමද ජාතික විද්‍යා පදනම මගින් සිදු කරනු ලබනවා. විද්‍යා විෂය ධාරාවේ ගුරුවරුන් ඇගයීමට ගුරු සම්මානද ජාතික විද්‍යා පදනමේ ලියාපදිංචි විද්‍යා සමාජවල ක්‍රියාකාරීත්වය ඇගයීමට තරු සම්මානද විද්‍යාව ප්‍රචලිත කිරීම වෙනුවෙන් ශ්‍රී ලාංකේය පුරවැසියන් කරනු ලබන සේවය අගයමින් මහාචාර්ය MTM ජිෆ්රි අනුස්මරණ සම්මානයේද විද්‍යාව ප්‍රචලිත කිරීම වෙනුවෙන් මාධ්‍යවේදීන් කරන සේවය අගයමින් මාධ්‍ය සම්මානද ලබා දීම සිදු කරනවා. මීට අමතරව විද්‍යා, තාක්ෂණ, ඉංජිනේරු හා ගණිතය යන විෂය ක්ෂේත්‍රයන් තුළ අධ්‍යාපන අමාත්‍යාංශය මගින් සිදු කරන ප්‍රතිපත්ති සකස් කිරීමට යෝජනා ඉදිරිපත් කිරීම මගින් අනාගත පරපුර දැනුම පදනම් කරගත් ආර්ථිකයක් කරා යොමු කිරීමට ජාතික විද්‍යා පදනම දායක වෙනවා. එබැවින් ඔබත් ඔබේ පාසලේ හෝ විශ්වවිද්‍යාලයේ විද්‍යා සමාජය අප සමග ලියාපදිංචි කර අප විසින් ක්‍රියාත්මක කරනු ලබන වැඩසටහන් වලට සහභාගී වී ජාතික හා ජාත්‍යන්තර මට්ටමින් අපේ රටට කීර්තියක් අත්කර දෙමින් විද්‍යා හා තාක්ෂණ ලෝකයේ ශ්‍රී ලාංකේය අනන්‍යතාව තහවුරු කිරීමට අපත් සමග අත්වැල් බැඳගන්න.
Sri Lanka, a tropical island with a heritage of a vibrant history, culture, and enchanting beauty, spread across nearly 65,000 square kilometers, with a multi-religious, multilingual, and multi-ethnic population of 21.4 million people. It is administratively divided into 9 provinces, 25 districts, which are divided into divisional secretariats. Each divisional secretariat is composed of several Grama-Niladhari divisions. Sri Lanka is prone to natural and man-made disasters, similar to other countries in the world, and susceptible to floods, droughts, landslides, cyclones, tornadoes, coastal erosion, biological hazards, animal attack, and storms. The catastrophic impact of the 2004 tsunami devastated 2/3 of the country's coastline. It took nearly 35,000 lives, orphaned 1,500 children, displaced over 1 million people, wiped out nearly 150,000 livelihoods, and damaged and destroyed over 100,000 houses. If Sri Lanka had a multi-hazard warning system in place, lives could have been saved. Due to the significant devastation of the tsunami, the government was compelled to set up a Parliament Select Committee in 2005 to review the country's disaster preparedness and response status, leading to enactment of the Sri Lanka Disaster Management Act, number 13 of 2005. Consequently, the National Council for Disaster Management, the Disaster Management Center, DMC, and the portfolio of the Ministry of Disaster Management were established. In 2005, Sri Lanka became a signatory to the Hyogo Framework for Action. A roadmap for disaster risk management was compiled to seek donor assistance for disaster risk reduction. The Ministry of Disaster Management has compiled policy instruments and plans to give direction to its work. The DMC is mandated with the responsibility of implementing and coordinating national and subnational level programs for reducing the risk of disasters with the participation of all relevant stakeholders. The DMC assisted the government authorities in encountering the challenges imposed by the greatest human disaster and public health emergency in the recent past, which is the COVID-19 global pandemic. Sri Lanka was able to contain the spread of this deadly virus with proactive and comprehensive system response. Disaster risk management has been devolved. A District Disaster Management Coordination Unit, DDMCU, at each district secretariat functions under the district secretary. It coordinates activities within the district by linking with divisional secretariats and Gramaniladari divisions. Lower down in the administrative hierarchy, officers of the National Disaster Relief Services Center are positioned at the district and divisional secretariats. A Central Emergency Operations Center, EOC, functions through 24 hours each day. At district level, emergency operations centers become active with early warning of probable hazard impact. The hotline 117 is accessible to the public to give and seek disaster-related information. The key activity of DMC is emergency operations and dissemination of early warning of disasters to vulnerable populations in the country with a view of mitigating risks. Multi-hazard early warning capacity has been built in collaboration with technical institutes for emergency response. Multi-hazard early warning towers have been positioned around the coastal belt. Community-level early warning has been enhanced. Evacuation drills are regularly conducted and camp management training has been provided to enhance safety of the internally displaced persons. Relevant capacity building has been carried out to prepare the communities to cope with hazard impact. The other main activities of the DMC are disaster mitigation, preparedness, and public awareness, and coordination of relief and post-disaster activities in collaboration with other key agencies. The DMC creates public awareness through competitions and the distribution of publicity material. The Desinventar database was launched to achieve the historical disaster profile, while the launching of Risk Info, Sri Lanka's risk information platforms, and Apada app, an online disaster reporting system, a very first in Sri Lanka. In 2015, Sri Lanka became a signatory to the Sendai Framework for Disaster Risk Reduction, SFDDR, the Paris Accord to combat climate change, and adopted the implementation of the Sustainable Development Goals. With the initiatives mooted by the DMC in creating a safer culture and sustainable development, Sri Lanka is focused upon mitigating and reducing losses and damages due to disasters by adopting proactive preparedness and response strategies. Therefore, Sri Lanka will be able to utilize the savings arising out of funds and resources allocated for disaster management for other economically viable and sustainable development activities, creating a prosperous nation.
Good morning, everyone. Welcome back to day 2 of the National Conference on COVID-19, Impact, Mitigation, Opportunities, and Building Resilience. Commencing the opening session for the day, I would like to cordially invite Chair, Senior Professor of Parasitology, Faculty of Medicine, University of Colombo, and Honorary Visiting Fellow, School of Public Health, Harvard University, USA, Professor Nadira Di Karunavira, to chair the opening session and to deliver the opening remarks.
Good morning, everyone. Very warm welcome to all of you to the morning session of day 2 of this conference. And we have 3 presentations in this session. And the first one will be from Dr. Stephen Hoffman, Scientific Director, Canadian Institute for Health Research. And he will be speaking on global perspectives on COVID-19. I believe the presentation will be made via Zoom. Over to you.
Yes, hello. Good morning. This is Professor Hoffman.
Good morning.
Yes. Good morning. Excellent. I'm glad that you can hear me.
Yes.
I just wanted to very much thank the National Science Foundation for this very kind invitation. Really quite excited to be here today with all of you. I also wanted to congratulate the foundation for hosting this very important conference. And I'm delighted just to be able to share a little bit about the global perspective on COVID-19, as well as that will then be complemented, I know, later with regional perspectives. The other thing that I wanted to make sure to say at the beginning of my presentation is that we owe quite a big thanks to the National Science Foundation of Sri Lanka for what I'll be presenting on. Because in my talk today, I will be presenting on the development of the UN research roadmap for the COVID-19 recovery. This is a project that was initiated upon the invitation of the UN Deputy Secretary General. And this was something that was done in collaboration with experts and research funders and institutions and UN agencies from around the world. But in particular, I wanted to make sure to recognize that the National Science Foundation of Sri Lanka was part of that effort. The international officer, Thilina Kumari, did an incredible job co-chairing one of our steering groups. And for that, I'm extremely grateful. So I know that the theme for today's meeting is focused on going from adversity to serendipity. And so I'm hoping in my presentation, in order to talk about not the immediate response to COVID-19, but very much focused on how do we get out of this and how do we get to a future that's better in light of an effective COVID-19 recovery. And indeed, that was the focus of this effort on which I'll be presenting today, the UN Research Roadmap for the COVID-19 Recovery, just published a couple of months ago. It's really about this idea that all of us together are going through a rather extraordinary experience. We're all affected. Of course, those who were already marginalized are affected even more, as unfortunately too often happens. But what we know about this is that there are going to be transformative changes that will need to happen both during and after this terrible pandemic. And as a result, this then presents an opportunity to be thinking about achieving the kind of changes that we need in order to achieve the goals that we aspire to. Most notably, in this case, the Sustainable Development Goals that were agreed to by all countries in the world through the United Nations. So with that, and I hope my slides are visible, let me just start with a bit of a background. So 2020, which was the first year of this ongoing pandemic, this was a terrible year when it comes, well, across every metric that I know of, and especially when it comes to human development. For example, in 2020, it was estimated that 71 million people were pushed into extreme poverty. We know that at some point at this time in 2020, 90% of students were at some point out of schools. Some countries have reported increases in domestic violence of increasing by 30%. And 60% of countries in the world have reported prison overcrowding, increasing the risk, of course, of spreading COVID-19 as well as other consequences. And so when we think about this, up until 2020, for a few decades, we had been continuously making progress across nearly every indicator of human development. Yet suddenly, this pandemic, which quite the disaster on a scale that we have not seen in a very long time, suddenly we then are forced to we're stepping backwards in the types of progress that we've been trying to achieve. And indeed, we weren't on track in 2019 to achieve the Sustainable Development Goals. But after 2020, we're even further away from achieving those targets that we wanted to achieve by 2030. And so with that, one of the things that the United Nations did as an act really of leadership in April 2020, early in this pandemic period, was it identified that, of course, this is a pandemic of a virus, but this is also a pandemic of inequities, and it's a pandemic of intense socioeconomic consequences for everyone, and particularly for those people who already face conditions of marginalization. And so as a result, the United Nations in April 2020 developed a framework for the immediate socioeconomic response to COVID-19. This framework was intended very much to unite the United Nations system in order for the UN to deliver for all of its member states as a single system. But it was also intended to identify the key areas that all governments and all societies around the world need to be thinking about in order to make sure that we not only address the immediate biological and medical and clinical needs presented by this pandemic, but also the social and economic and cultural devastation that this pandemic has also caused. And so in this framework, they articulated 5 for action. The first was on health services and systems, a second on social protection and basic services, a third on economic response and recovery, a fourth on macroeconomic response and multilateral collaboration, and fifth on social cohesion and community resilience. Now, shortly after the release of this socioeconomic recovery framework, the United Nations Deputy Secretary General, in her wisdom, reached out and realized that we needed to ensure that this approach to socioeconomic recovery was not only spurring action in all societies, we needed to make sure that those actions were informed by the best available research evidence, and as well to make sure that this recovery effort is a learning recovery effort, one whereby actions taken later in the recovery effort are informed by lessons learned from earlier in the recovery effort. And indeed, the UN Deputy Secretary General then invited the development of a UN research roadmap that would ideally transform this UN socioeconomic recovery framework into a rapid learning initiative. The goal, as I mentioned, was very much about trying to ensure that early efforts were informing later efforts, as well as we could make sure that the best available evidence was available for all countries when they needed it. I do notice that in the presentation that my slides don't seem to be changing, so I am going to reset this in the hope that you're able to see my slides before I continue. Oh. Great. I hope that is now will now work. Oh, I don't see. Let me try one more time, and then and then we will. I can give the presentation without the slides if needed. I hope that that might work. Whoop. Are the slides working?
Not yet, no.
Not yet? Okay. Oh no, let me try one more time. No.
Yeah, it was on the screen earlier.
Is it working now? No?
No.
Okay, I'm just going to, I guess I'll present without the slides. And I will encourage everyone who is listening in to maybe look at the UN Research Roadmap itself using just by Google or any search engine. If you search UN Research Roadmap for the COVID-19 recovery, that will allow for to look at the report itself. And I'd be happy to make the slides available to participants through the National Science Foundation afterwards. My apologies for the technical glitches, despite testing it in advance. So let me just say then, what we did is, upon the invitation of the UN Deputy Secretary General, we essentially developed a process whereby we would try to hone in from expertise from around the world, trying to figure out what is needed, what kind of knowledge is needed right now, and that we need to start answering right now, what questions, in order to inform a better recovery in the future. And so we convened 5 steering groups, one of which was chaired by the International Officer, Thilina Kumari, at the National Science Foundation of Sri Lanka, along with colleagues from 38 other funding agencies from around the world, representing 25 countries. We convened 270 experts, there were written submissions, there were virtual consultations, and we also commissioned 5 rapid scoping reviews, of which were basically intended to get us up to the leading edge of what knowledge is right now across each of the 5 pillars of the existing UN socioeconomic recovery framework. And so essentially what we wanted to do as part of this effort was we wanted to turn the recovery effort that will come into not adversity, but as this conference theme is, into serendipity, or into an opportunity for transformative change. And indeed, what we sought to do was identify this as a moment perhaps a generational opportunity whereby there could be transformative changes in order to achieve the Sustainable Development Goals and have those changes. And so if I was able to present my slide, which I can't do, there would be a slide highlighting that in 2020 and now in 2021, we have a choice in front of us. And that choice is either we go back to the way things were, or we try to go back to the way things were, and then we don't end up achieving what we want to achieve in the long term, or we try to go for a better future, one that, yes, requires transformational changes, but one that will get us to a more equitable, resilient, and sustainable future. And of course, the advantage of going back to the way things were is that we would be able to get there because we know how things were, we know how to do things, we did them before. And so we don't need new knowledge and new science. But of course, that's not very satisfying. And indeed, I don't think anyone would say that the world as it was before this pandemic was perfect. Indeed, as I mentioned, we weren't on track to achieve the Sustainable Development Goals by the 2030 deadline. So as a result, instead, I hope that everyone will agree that we need actually to strive for a better future, a more equitable, resilient, and sustainable future. But the challenge is we don't know how to get there. And that's where science comes in. That's where research of every kind comes in, because we need that research to inform what kind of policies, strategies, what kind of programs are needed for that better future. And without science, without being able to leverage the power of science, we're far less likely to be able to achieve those goals that we collectively aspire to achieve. And so this roadmap document, which I encourage everyone to look at for those who are joining by webcast or those who have access to computers nearby. In that roadmap document, we identify 25 research priorities. Essentially, we try to identify the top 5 knowledge needs within each of the 5 pillars of the UN's existing socioeconomic recovery framework. What we also sought to do in this research roadmap document was provide a framework for understanding the challenges, but also the opportunities that we have ahead. And third, we highlight 5 science strategies that are needed in all societies around the world in order to ensure that we can leverage the power of science for a better recovery. And so ultimately, I will mention very shortly the 25 top-level research priorities, but I wanted to first explain that as much as these priorities are unique, and each one is quite special and important, and yes, 5 of them are in each of the 5 socioeconomic recovery framework pillars, but there is a single unifying question that links up all 25 questions. And that singular question that we think is singularly important is around how can we ensure that the socioeconomic recovery efforts that will happen over the coming days, weeks, months, and years, how do we ensure those efforts not only achieve the direct benefit that they're trying to achieve, but simultaneously also stimulate co-benefits for equity, resilience, and sustainability. The key being, when we do something, let's make sure that we don't only achieve that one thing, but that we're simultaneously making all of our societies more equitable, making them more resilient to future threats of various kinds, and also more sustainable. In other words, living within planetary means and boundaries. Now, first, I'll quickly walk through the 25, particularly because I'm not able to show them to you in front of on the screen. So in terms of the health systems and services pillar, the first question was around how should health systems be designed so that they're responsive, adaptable, and accessible when needed. The second question is how can health systems eliminate discrimination in their service delivery and become drivers of equity in society? The third question within health systems and services is how can all parts of government be mobilized to promote health prevent disease, and prepare for future health emergencies. Recognizing, of course, that even something as traditionally health and medical as a pandemic, of course, when it happens as COVID-19 has happened, it does require indeed a mobilization of all parts of government in order to effectively respond. The fourth question is, how can global governance be reformed to support more coordinated and collective responses against those health threats that transcend national boundaries? And fifth, how can health systems engage communities, build trust, and support collective responses to emerging health threats? The next pillar, in terms of social protection and basic services, again, there were 5 top-level priorities. The first was around how can necessary social protections be made available to all people when they need them. The second was on how can social protections be implemented to tackle the underlying root causes of socioeconomic marginalization and inequities. Third, how can environments be built, shaped, and sustained in ways that allow all people to thrive? Fourth, how can exclusionary digital divides be prevented in an increasingly virtual world? Fifth, how can social protections and basic services help to promote population mental health? Of course, something that is discussed widely in all corners of the world. The third pillar on economic response and recovery programs also had 5 top-level priorities. The first was around how can economic recovery policies protect workers, ensure their well-being, and promote a resilient workforce. The second is how can strategies to support sectors and enterprises most impacted by the COVID-19 pandemic better prepare them for future shocks? Third, how can the global economy, with constant movement of people, goods, and capital, work for everyone and protect the planet? Fourth, how can policy solutions promote the well-being of informal workers and ensure their long-term economic equity? And finally, how have recent economic changes disproportionately impacted women? And how can recovery strategies be inclusive and gender transformative? The fourth pillar of the UN Socioeconomic Recovery Framework was macroeconomic policies and multilateral collaboration. And so indeed, this is also the fourth area where we have an additional 5 priorities in the UN Research Roadmap for the COVID-19 recovery. The first top-level priority is how can macroeconomic policy promote a more inclusive and sustainable recovery from COVID-19? Second, how can inequities in development opportunities be eliminated? Third, how can increased public expenditure that we're seeing around the world during COVID-19 be financed while ensuring an inclusive and sustainable recovery in all countries? Fourth, how have recent global shocks affected the functioning and legitimacy of international institutions? And fifth, how can multilateral collaboration and progress towards the Sustainable Development Goals be sustained in an increasingly polarized world? Finally, the 5th pillar around social cohesion and community resilience. The first top-level priority is trying to figure out how can communities be optimally engaged in decision-making processes during emergencies to strengthen social cohesion. The second is around how can governments most effectively communicate with local communities to build trust, forge consensus, and promote cooperation to achieve shared goals. Third, how can recovery efforts from emergencies help eliminate pre-existing social inequities in order to enhance the resilience of communities? Fourth, and second last, how can community spaces enhance social resilience and cohesion? And finally, how can digital technologies be harnessed to promote social cohesion while ensuring no one is excluded? I've gone through the 25 research priorities. If you do have a chance to look at the UN Research Roadmap for the COVID-19 recovery, in it, we additionally detail some important contextual factors for each of these priorities. We also identify additional sub-priorities, sub-questions in order to spur additional thinking and frankly encourage the entire scientific community and everyone who wants to make use of science in their decisions in order to think about what kind of knowledge do we need to generate now in order to make sure we're well prepared for the decisions that will be coming in the near future. And one of the things that we then emphasize after describing these top-level 25 priorities is to emphasize again that ideally by answering these questions, by getting this knowledge, we should be able to ensure that policies and programs and interventions that come during the pandemic and afterwards not only achieve their immediate goal, but additionally try to achieve a more equitable society, a more resilient society, and a more sustainable society as three important co-benefits that need to be achieved. In other words, how can we achieve a quadruple bottom line? So not just a single bottom line, not even just a double bottom line. If our actions are smart and strategic, how do we achieve several goals at the same time? And the concern, of course, is that if we don't achieve all of these additional efforts, then it just takes one additional pandemic, another type of natural disaster, something in the future in order to, again, set us back. And so again, if I had my slides, I would have today shown a tripod. And each leg of the tripod, if we think of equity, sustainability, and resilience as legs on that three-legged tripod, what we see would be if we have, let's say we have equity, which is great. Let's say we have sustainability, that's also great. If we don't also have resilience, then the whole stool is going to fall down when the next disaster strikes. And so ultimately, if we're serious about building up and strengthening science in all societies in order to leverage the power of science to inform decisions, we need to then also take a look at our own scientific systems within each country. And so for that, the research roadmap highlights 5 science strategies for a better recovery. The first, and I'll go through quickly as I approach the end of my presentation time, but the first is, of course, around data infrastructure. And of course, everyone knows this, without data, it becomes very difficult to make the right decision. But it's not just the data. We also have to, in all of our societies, think about the policies and the systems and technologies that are involved in the collection, the storage, the oversight management, privacy, protection of data to make sure that it can be useful for decision making. The second is the report hones in on implementation science. This is a growing area of science that recognizes that, yes, we might have, let's say, randomized control trials and other kinds of evidence of effectiveness for interventions, but those interventions are not necessarily going to work in every context in exactly the same way, and that we need to build a science around how do we appropriately implement various interventions in light of unique social, economic, and political contexts. Third science strategy highlighted in this report is about the need to develop rapid learning systems. How do we ensure that we don't have to wait 10 years in order to learn something from a major policy, but we're able to learn whether it's working and how it's working much earlier so that we can make tweaks and fine-tune as we go along. Fourth, knowledge mobilization. Of course, knowledge is only good if it's acted upon, which means we need to take systematic efforts to make sure it's useful. And fifth, and finally, we need to develop a science of science. In other words, if this research roadmap is all about informing and ensuring that science can inform future policies, science itself and science policy also needs to take a critical look and see how can we leverage the power of science in order to have better scientific systems. And so with that, I'll just emphasize as I conclude that this research roadmap is intended to very much be a call to action, first among researchers who are the ones who will be needed to answer those top level 25 research priorities. Second, of course, it's for research funding agencies in order to provide a framework and help set priorities that, of course, will need to be adapted for every unique jurisdictional context. But ideally, because there's this global framework adopted through the United Nations, the idea is that it will help research funding agencies from around the world to work together and ensure everybody is rowing in the same direction. And finally, of course, this research roadmap is intended to be a call to action from governments and civil society, businesses, and the members of the public who we need them to be asking for research. We need them to demand research. We need them to express the value of research. We need them to make use of research when it's available. And so with that, I just wanted to give just a deep expression of appreciation again to the National Science Foundation in Sri Lanka, both for its many contributions to the development of this important United Nations project, but also very much appreciate the opportunity to present to all of you today and to be part of this important conference. Thank you very much.
Thank you very much, Dr. Hoffman, for that very comprehensive presentation. It's just unfortunate that we couldn't see your slides, but I'm sure you'll make those available so that we can share with the audience later. Since we have a couple of minutes left, I'm sure there may be more questions from the audience as well that may have come to Q&A. But before that, can I quickly ask if there's it's very reassuring that there's a very clear-cut roadmap. Is there anything for progress monitoring, that kind of thing, in the post-COVID era?
Yeah, so thank you so much. It's such an important question because, of course, what doesn't get monitored and what doesn't get measured doesn't happen. And so I think there's a couple of things I can mention. The first is that the publication of the research roadmap was very much intended to be the starting point, in that we know that documents are only worth their all the effort that went into them if they're then taken up. And so one thing that we are doing is this Friday, we are hosting a meeting for research funders from around the world, including the National Science Foundation in Sri Lanka. And that's with the UN Deputy Secretary General herself. She's the honorary chair of this meeting. She'll be there giving remarks and reacting to an open dialogue about how research funders around the world can take up the UN research roadmap in order to make sure that researchers around the world are supported and funded to help answer these questions. Additionally, what we've been doing is the United Nations is working with different regional organizations to try to bring attention to this issue. And we're also trying to develop different new mechanisms to ensure that there's continued discussion between those who are leading science, whether it's at institutions or in communities around the world, with linking up with the United Nations, who both needs this to benefit from this research, but also would be able to help shape future directions for those who are particularly keen on helping to contribute to the Sustainable Development Goals. And finally, I'll just mention, when it comes to measurements and monitoring, we're very lucky that an organization called Glopidar, which is a consortium of different research funders, as well as the United Kingdom's Consortium on Research for Development, are jointly developing a tracker whereby they will be quantifying all the research funding that is going into projects, scientific studies related to COVID-19, and they'll be categorizing it according to the 25 top-level research priorities in this research roadmap. So essentially, 6 months from now, if we were looking at that tracker, which is publicly available online, you'll know exactly how much money has been invested according to each of those 25 questions. And hopefully, it'll be a lot, because of course those are important questions which definitely need answers. And to get answers, we need funding in order to support those projects. Thank you.
Thank you so much. We'll take up any other questions that have come through to the Q&A at the end. I'm sure if we have time, we'll be able to answer those as well. We'll put it across to you at the end of the session. Thank you.
Thank you.
To move on to the next speaker, it's Professor Raina McIntyre, who is the Professor of Global Biosecurity, NHMRC, Principal Research Fellow and Head of the Biosecurity Program at the Kirby Institute at New South Wales University, Australia. She will be talking on transmission of SARS-CoV-2 and implications for disease control. Over to you, Professor Raina. Thank you so much for joining us.
Thank you, and good morning to everyone. Just try to find my slides, share the screen. Okay, can you see the slides?
Yes, we can hear you and we can see the slides as well.
Okay, so I'm going to cover transmission of SARS-CoV-2 and what implications that has for disease control. Just starting with the assumption that we made at the beginning of last year that it was spread through droplets and contact. That was really an assumption from the outset, and it wasn't based on any data. We know now that the transmission is by the respiratory route through fecal aerosolization, possibly through fomites, also ocular. It's even been documented in the blood, and vertical transmission, although rare, has been documented as well. The sites which have the ACE receptors are the sites that can bind the virus, and you can see in the diagram there, they're quite widespread in the body. So in addition to the respiratory tract and the gastrointestinal tract, they're also in the central nervous system and in the liver and kidneys and other parts of the body. So where the virus is shed from the body informs transmission potential. One question is, how do you actually prove whether transmission is through contact or large droplets? The distance between two people when there is transmission doesn't actually prove whether it's droplet or aerosol. In fact, most research supports the idea that even at within 2 meters of distance, transmission is mostly due to aerosols rather than large droplets. So large droplets have a more of a ballistic impact. It's like you sneeze, large droplet comes out at a fast speed and lands on your eye or in your nose. That's large droplet spread, whereas aerosol spread, the aerosols are in the air for much longer. So if you're close to someone and both talking, you can be breathing in those contaminated aerosols. So there's basically 2 ways you can prove airborne transmission, and one is by looking at outbreaks where infections have occurred without close contact, and the second is detecting virus in air samples, and I'll cover some of the data from that. This is just to show, this is a meta-analysis on secondary attack rates inside households. We know that the vast majority of transmission happens inside households because that's where you have your closest contact with your family members. And in general, the household attack rate is close to 30%. Okay, so 1/3 of contacts there. You can see the summary odds ratio there and all the different studies measuring it. There are a couple of quite influential studies suggesting that super spreading is really important and that 80% of all transmissions are from super spreading events, and the other transmissions, that most people don't infect a lot of people. It's just a few people have this potential to super spread. But it's not actually consistent with what's been found in these household contact studies, which is that consistently about 30% of the household contacts get infected. So super spreading does happen, but it may not be the only or the major way of transmission. These graphs are from a study looking at viral load from different sites, and each graph is a different patient. The orange is the sputum sample, the yellow is the nose and throat swab, and the grey is the stool sample. And in general, for most patients, you can see that the viral load is higher for the sputum sample than for the other samples, except for a couple of cases where the gastrointestinal samples are higher. And that's been shown in multiple studies that in actual fact, the viral load is higher in the lower respiratory tract than the upper respiratory tract, and you can get more false positives by doing a throat swab than a deep nose and throat swab or a nasopharyngeal swab. So the site of sampling matters, and the studies which show the higher viral load in the lung are also consistent with airborne transmission, so that when you breathe out, the aerosols may have virus in them. The other factor which Professor Peiris mentioned yesterday is pre-symptomatic and asymptomatic transmission. Multiple studies confirm that when you go in to investigate an outbreak, at least 50% of all the infections at that time will be asymptomatic. Some of them will be pre-symptomatic, so they will go on to develop symptoms, but some of them will never develop symptoms. And 44% of transmissions are from people who are pre-symptomatic. 70% of transmissions are in the household before the infection is diagnosed in the index case. And several studies have shown that the viral load is actually the highest very early in the illness, and that was seen in the previous graph I showed as well. The viral load is highest in the first 48 hours before symptoms start and in the first 6 hours of symptoms. And this is not consistent across all studies, but some studies show that the viral load is similar in symptomatic and asymptomatic patients, and others show that it's lower in asymptomatic people. This study, the data from this study was shown to you yesterday by Dr. Peiris, and it's just comparing SARS on the right here, SARS in 2003, and essentially the blue graph there is the virus shedding, okay? And you can see that all the virus shedding in SARS occurs while they've got symptoms, which is why it was easier to control, because you can identify people who are infectious because they have symptoms. Influenza, we know, has some pre-symptomatic transmission, so that's harder to control. But with SARS-CoV-2, there's much greater pre-symptomatic and asymptomatic transmission, more than influenza. So that makes it very difficult to control. So I just want to talk a bit about droplet versus airborne transmission. This is a belief that only large droplets are emitted close to a patient with a disease, and small droplet nuclei are emitted at a greater distance, and this is the basis of the 1 to 2 metre or 3 to 6 feet rule, which is that is a safe distance of spatial separation, 1 to 2 metres. It's actually an artificial paradigm that's driven hospital infection control practice for more than 80 years, and it's based on very old data from experiments from aerobiologists from the 1940s using very blunt instruments. Newer research shows that both small and large droplets can be present close to the patient, and also that large droplets can travel further than 6 feet or 2 metres. The WHO classifies large droplets as those greater than 5 microns in diameter and airborne if they're less than 5 microns. But in actual fact, the aerosol science shows that 100 microns is a better separator of whether a droplet is going to remain airborne or not. So generally anything less than 100 microns can be an aerosol and stay suspended in the air. This 2 metre rule, the belief that if you stay 2 metres separated from someone, you're safe from large droplets, it's probably based on this study, which is a very old study by William Wells, who's one of the aerobiologists from the 1940s. And it was actually measuring the time taken for a droplet to fall 2 metres vertically. And I think somehow that's got lost in translation. There's really no evidence to support this 1 to 2 metre rule. We published this study looking at all the available studies, and this is it. You can see there's not a lot of studies that looked at horizontal distance travelled by large droplets, and the vast majority of them, and I've got the x-axis here in both feet and metres at the top, so you can see 2 metres is here. The majority of these studies show that the large droplets can travel further than 2 metres, even up to 8 metres, which is pretty much the size of a standard hospital room. So transmission of SARS-CoV-2 is really about the air we breathe. And aerosolization doesn't just happen when you intubate someone or do an aerosol generating procedure. Aerosolization happens when we breathe. And there's been studies that show that coronaviruses are more prone to being aerosolized than other viruses, and they come out in exhaled breath. And aerosolization also occurs with talking, with singing, with shouting, with coughing and sneezing, as we know, also toilet flushing, and I'll talk about that in a moment. Medical procedures, yes, they do cause aerosolization. And once droplets are aerosolized, they can be deposited on surfaces and then re-aerosolized by human activity. And the key to transmission of SARS-CoV-2 is that aerosols accumulate in closed settings. Transmission is very unlikely to be a one-hit ballistic event, where someone coughs in your face, a big droplet lands in your eye or in your nose or in your mouth, and you get infected. It's much more likely that two people are standing there talking and one person's infected, the other person is breathing in those infected aerosols repeatedly over a period of time. So it's much more likely that it's going to be cumulative inhalation exposure. And ventilation disperses aerosols very effectively. So breathing is an aerosol generating procedure. It's been estimated that 1 minute of loud speaking can produce thousands of oral droplets per second, and of these, at least 1,000 virus-containing droplet nuclei that can remain airborne for more than 8 minutes. And of course, when you think about being in a room with someone who's infected, whether you're a health worker or whether you're caring for someone in your house who's got the infection, breathing and speaking occur. Breathing occurs continually and speaking occurs very frequently, much, much more frequently than coughing or sneezing. So a single cough or a single sneeze is likely to be less important than the breathing and the speaking, because those are continual events that are leading to increase in dose of inhaled aerosols. And it's particularly important with asymptomatic cases because you may not know whether someone is infected. Here's a study that was done in school classrooms to look at the effect of air purifiers, which can be used if you haven't got a window that can be opened. So in a poorly ventilated school classroom, the red solid line shows the exhaled dose of virus when someone infected is present, and you can see it just increases linearly over time. So if you're in that room for 10 minutes, you're probably going to be okay. But if you're in that room for 1 hour or 2 hours, you're going to be at much greater risk because the dose of exposure is much higher. The dotted line is the inhaled dose. And then the blue line is when you have an air purifier, which is these portable purifiers that have a HEPA filter in them, and they just filter out the airborne particles. So it makes a dramatic difference. But opening some windows will also do that. So I think for Sri Lanka, in classrooms, a lot of classrooms I know are designed with good ventilation, but keep the windows open. So aerosol generating procedures as medical procedures, this term became popular after the 2003 SARS epidemic, when some studies found an association between transmission to health workers and the use of endotracheal intubation or non-invasive ventilation. This weak evidence has been misused to infer a causal link between procedural aerosols and infection. So it's not really based on a lot of evidence. And when you look at cumulative exposure, just the aerosol generating from speaking and breathing is more important. So then all of these things, breathing, speaking, shouting, coughing, sneezing, flushing, medical procedures, all can generate aerosols. And we've done some work to measure and quantitate aerosol generation. And I'll show you one of those videos in a minute. But one study here showed that coughing generates more aerosols than endotracheal intubation. They found that intubation even produced less aerosolization than extubation. So extubation was a more dangerous procedure, but coughing generated even more aerosols. This was a study we did a number of years ago now that looked at high-risk procedures, and what we defined as high-risk procedures were aerosol-generating procedures, and you definitely had a higher risk, 3 times as great a risk, if you did aerosol-generating procedures of influenza and other respiratory viruses. With all the studies with SARS-CoV-2, there's been extensive contamination of hospital rooms, even in areas quite far from the patient. In one study, SARS-CoV-2 particles with sizes greater than 4 microns and 1 to 4 microns, containing 1.8 to 3.4 viral copies per meter cube, were found in 2 isolation rooms, despite the rooms having 12 air changes an hour. Now, 12 air changes an hour is kind of the Rolls-Royce of ventilation in an ICU. So even with that number of air changes, they still found virus everywhere. The peak concentrations of SARS-CoV RNA in the air appear in 2 distinct size ranges, 0.25 to 1 micron and greater than 2.5 microns. This is another study and shows you all the different areas in a hospital room where the virus was identified. So everywhere, basically, the floor, the bed rails, the locker handles, the toilet seat, the chair, the electrical switch, the whole hospital room was contaminated. Here's a summary of some of the studies that have shown aerosolized SARS-CoV-2. The first 6 studies here were in hospitals, and they all showed virus on the air vents. Almost all of them detected viral RNA in the air. 2 of them detected viable replicating virus in the air, and 2 of them showed a distance of greater than 2 meters from the patient. One study showed that it was highest early in the illness. The other studies here, the Fears, Smithers, and Van Dormelen, were experimental studies in the laboratory, where they aerosolized the virus and then looked at how it behaved. And basically, they all detected viral RNA in the air, and 3 of them found viable replicating virus in the air up to 16 hours after the aerosolization event. So it means it can persist in the air a really long time. This one study in Italy was quite interesting because they found viral RNA in the air in an industrial area of Bergamo in Italy during that first wave of the pandemic last year. This is a study that's just been published in the last couple of months from Sweden, which is a hospital, and the blue, yellow, and red at the bottom are the floors that were treating SARS-CoV-2 patients. And they basically found SARS-CoV-2 in all the air vents, including right up here on the top floor of the building, which indicates that it's traveled up through the ventilation system and got impacted in the filters in that top floor. So really, they demonstrate a very long distance airborne dispersal of SARS-CoV-2 in the ward. In some of these studies, the way you sample the air matters. So in this study by Lednicki and others, they showed that their particular way of collecting virus samples was more likely to keep the virus viable. Some of the other methods are more likely to destroy the virus, so you'd only get a positive PCR. And they identified virus in air samples up to 4.5 meters from the patient without any aerosol generating procedures being conducted, which means it's coming from breathing and speaking. This is the electron microscopy of the viable virus from the study by Fears. And in this, they looked at the spray factor, which is sort of a indication of how aerosolized the virus is. The red is MERS coronavirus, the blue is SARS, and the dark green here is SARS-CoV-2. And you can see that the spray factor is higher for SARS-CoV-2. So it's more prone to aerosolization than MERS, which we accept as airborne. There's been a whole lot of outbreaks, many more than are in this table, which have documented very likely airborne transmission, including outbreaks in choirs. Singing is a really high-risk procedure in terms of generating aerosols in shopping malls, in prisons, in restaurants, on buses, where people who had no contact and were not within 2 meters of each other became infected. This outbreak on an aeroplane, the orange are where people had the COVID cases, and you can see they're dispersed all over the plane, whether that was airborne or whether the toilets, which are here in the galleys, were the risk factors unknown. There's another aircraft study that shows that the toilets were actually the high-risk zone, which probably accounted for transmission on that airplane. There's been a number of outbreaks in bus drivers as well, transporting travellers, returning international travellers. We've had a couple in Sydney, and these are the kind of buses that transport travellers. They don't have windows that can be opened, and if your air conditioning is set to recirculate, which is the cheapest way of running the air conditioning, then you're going to be just recirculating contagious air. To talk briefly about toilets, the role of fecal aerosols is important. Studies have shown that when you flush the toilet, there's actually massive upward transport of aerosol particles, and 40 to 60% of the particles rise above the toilet seat level, leading to large-scale spread indoors in bathrooms. There's been 2 studies now documenting transmission in buildings through the plumbing. And also another study showing that there's 4 times the risk of infection in household contacts if the index case has diarrhea. In another study, as I just mentioned, the aircraft toilet was documented as the main risk factor. So the takeaway message is flush with the toilet lid down, open the windows, turn on the bathroom vents, use disinfectant in the bathroom. This is that study of the high-rise building transmission of SARS-CoV-2, and essentially there was an infected family on the 15th floor of this building, and the infection went all the way up to the 27th floor. The apartment directly above this infected apartment on the 16th floor was vacant. They went in and they tested the bathroom, and there was widespread contamination in that vacant apartment. No human beings had been in there. They found the virus all over the bathroom. So it's gone up through the plumbing into the apartment above. And we saw an outbreak like this during SARS in 2003. You might remember the Amoy Gardens outbreak in Hong Kong, which was also very similar. In this study, the plausibility score for SARS-CoV-2 being airborne is very high. It's 8 out of 9, which is in the same range as tuberculosis. Ventilation is really important. If just opening a window will disperse the aerosols, being indoors is a much greater risk than being outdoors. If you can't open the windows, most air conditioners are set to recirculate the air, and some are not designed. General household air conditioners are not designed to bring fresh air in. They can't do it. Commercial buildings often can, but it's very expensive to do that because of the temperature maintenance. So opening the windows is the best thing, otherwise portable air purifiers. So airborne transmission of SARS-CoV-2 is real. The WHO kind of denied it through most of 2020, but modified its position to accept airborne transmission, particularly in indoor settings, in July last year. There's actually more evidence for airborne transmission than other modes of transmission, which I've just gone through all the evidence. But the combination of airborne transmission and asymptomatic transmission means that universal face mask use will reduce transmission because you don't know who's infected. You may not even know if you are infected. And of course, there's been high rates of infection documented in health workers wearing poor PPE. Transmission matters most for health workers and other people working at the front line who are likely to be exposed. We talk about this infection prevention control pyramid for occupational safety, and the traditional teaching is you have to eliminate, substitute, engineer administrative controls, and PPE is the last resort. But for health workers, elimination is not possible because the job is the hazard. If your job is to treat patients with COVID, you can't eliminate the risk. Same for substitution. So it really needs to be thought about a bit differently. So those occupational risk groups are health workers, particularly some subspecialties where a lot of aerosols are generated: ENT, ophthalmology, psychiatry, emergency ICU, gastroenterology, etc., anesthetics. And also non-clinical personnel, cleaning staff, ward clerks. Often they are the most affected because they don't get good PPE. Aged care workers, hotel quarantine staff, other first responders, international flight crew, and where there is community transmission, then retail and customer service staff. And, you know, the Perspex barriers won't do anything against airborne transmission. Amnesty International documented over 7,000 health worker deaths by the 3rd of September last year. In the NHS Trust, 2 studies found 1 in 5 health workers infected last year. There's been a lot of issues with shortages of personal protective equipment as well. That's made it very difficult. The other thing is when you've got a lot of community transmission, that other services in hospitals can be affected. So during the first wave in New York, this study looked at an obstetric service, an antenatal service, with mostly asymptomatic pregnant women coming in just for their antenatal care. They found that almost 15% were infected and most of those were asymptomatic. So in other areas of a hospital, if there's a lot of community transmission, you can expect that there will be infected people coming through. Countries that have had very precautionary PPE levels like Taiwan, China, Singapore have had very low rates of health worker infections. This just shows the rationale for universal masking, right? If the infected person is in red, the uninfected person is in blue. And if nobody's wearing a mask, then you've got full exposure. If the well person is wearing the mask, there's some reduction of risk. If the sick person is wearing a mask, again, there's some reduction of risk. But if both people are wearing the mask, there's a greater reduction in risk. This is some research we did that's published in Thorax, and it's basically showing you the difference between no mask, a single-layered cloth mask, a double-layered cloth mask, and a 3-layered surgical mask with speaking, coughing, and sneezing. These are the visualization techniques are showing you aerosols that will not be seen by the naked eye. You won't be able to see this normally. You can see it because we visualized it. And you can see that wearing a surgical mask is better than a 2-layered or 1-layered cloth mask. But even a 1-layered cloth mask gives you some protection. In terms of the evidence for personal protective equipment from COVID-19, there was a meta-analysis in the Lancet that showed surgical or good quality cloth masks are 67% effective against beta coronaviruses, N95s 96% effective, and they also showed that distancing of at least 1 meter is highly effective.
To disturb you, but in the interest of time, would you be able to?
Time's up, yeah. So just to summarize, respiratory transmission is the most important mode of transmission, and control strategies must be designed accordingly, which are masks, social distancing, and ventilation. And as you heard yesterday from Professor Pires, vaccination may or may not provide an exit strategy. I understand you'll be getting the AstraZeneca vaccine probably, which has much lower efficacy than the mRNA vaccine. So it probably will not prevent transmission. Thank you.
Thank you so very much for that very informative presentation. Since we are running out of time, we'll have to move on to the next speaker. But there might be questions in the Q&A box. You can have a look. And at the end of the session, we might have time so that we can go through the questions. So please stay with us until the end of the session. Thank you. The next presentation is by Mr. Nalaka Kaluweba. He will be speaking on how to build responsible, productive, and responsive media culture. He'll be joining us through online means. Over to you, Mr. Kaluweba.
Okay, thank you. Okay. I hope I can see you can see me now. The video is clear.
Yes, yes,
okay.
We can see you.
Okay, then now I'm trying to share my slides.
While he does that, Mr. Kalueva is the Director General, Department of Government Information, and we feel privileged to have him on board.
Thank you. Good morning, and thank you very much for inviting me for this very timely and important session and symposium. While the entire world is experiencing kind of a very different altogether experience, it is very good to analyze the experience what we are undergoing from academic perspective. So again, I congratulate the organizers for organizing this very timely seminar or symposium. During my next 10 or 20 minutes, I have been asked to talk with you, share my experience with regard to responsible journalism in pandemic situation like COVID-19. So as a Director General of Government Information, in my capacity, or my role is intermediate. I'm playing an intermediate role between India and the government, and through me, I'm trying to channel most of the official information. So I think I'm not, during my presentation, I'm not talking about very much theoretical aspects. I'm trying to share my experience especially during this COVID-19 or pandemic. What is my experience of handling media in Sri Lankan context? So with that little introduction, let me give kind of a very short theoretical overview about what actually responsible journalism mean. There can be different theoretical explanations for the term responsible journalism. There can be a lot of literature on this. However, in very much practical sense, there are 4 main elements of responsible journalism. This is the most simplest way to explain what is the responsible journalism is. First, if we concentrate about the main principles which behind this the term, the first thing is the truth telling. We all agree with that. If there is no truth telling, there is no responsible journalism. That is very obvious. Then the journalists should be independent. That means they are not influenced with different ideologies. They are with their independent mindset. And minimizing harm. Because of the journalism or media reporting, there can't be harm for anybody, society, or any party. And at the same time, accountability is another very much important consideration. Whatever they publish or report, the journalist should accountable, or the media organization should accountable for their reporting. So these are the 4 main theoretical or the principles which behind or define responsible journalism. So if a journalist or media outlet follow these principles, it is believed that it generate the trust among the general public about the media organization and about the information what they deliver. And then it also uplifts the credibility. And it, more importantly, this kind of responsible journalism leads to change the mindset of people. So especially during pandemic like this or like COVID, the ideal expected role of media is different. So if I identify few of the expectations or ideal role of media, especially during a pandemic like COVID, dissemination of correct information is a must. Everybody expects that media disseminate correct information. There cannot be any misinterpretations. And at the same time, there cannot be stigmatization of the society. That is, we call destigmatization must be there. And myth busting is also kind of an expected role of media. Even nowadays, we very frequently observe some myths spreading around the society. So that can be very harmful for the combat against pandemic like COVID. So myth busting is one of the main expectation of media, and objective reporting is very much important, that to give complete picture, and advocacy, that is the main and most strength of the media, because without the media you can't educate the public. Therefore, advocacy is very much important. That is the expected role, and the positive health behaviors and the positive health behaviors needs to, educate. Media needs to educate about the positive health behaviors. The general public get the information mainly from media, and at the same time, they are having media having the responsibility to select only confirmed or verified news from authorities. That is where we or the Department of Government Information play the role, because we are having responsibility to issue only the confirmed or verified news items, especially with regard to the COVID, the pandemic. And the social cohesion and social solidarity is also the responsibility of the media. If the media fail to protect the social cohesion and social solidarity, that can lead to another disaster. So they have to be very careful, especially during the pandemic like COVID. So not only, when we talk about the responsible journalism, there are some journalists should have some core competencies to perform their duty in more professional way. So first of all, they should have ability to objective reporting, as I explained earlier. And all journalists must approach, their approach must be very professional. Once we say professional, it covers a wide area of subjects and skills. So they have to approach in very professional way. And the subject knowledge is very much important. They must have the awareness, the full awareness about the what is going on and the current knowledge. And if they only confine to the knowledge what they have, that can be a disastrous situation, because the society also getting the very limited knowledge in that scenario. So they must be well aware what is going on, the new knowledge, and avoid the information. If obscure information, they have to avoid obscure information. And comprehensive and follow-up reporting is also very much important. And this is they must have the, when the media deal with a pandemic like COVID, they must understand what are the responsibilities of all stakeholders. As we all know, in Sri Lankan experience at the moment, COVID-19, we are combating with COVID-19 as a kind of a multi-sectoral attempt. There are different sectors. Health play the major role. Military, civil sector, all the stakeholders are having different responsibilities. And because of that, if the journalist or the media outlets must have a very clear kind of understanding about different responsibilities of different stakeholders. Otherwise, there can be a conflict of interest when they start to report different aspects. And protecting privacy of the public is very much important. I will touch that topic later. This is one of the most discussed topic in recent past, protecting the privacy of the public especially during the pandemic like COVID, and avoid panic reporting is also very much important. And then they have to journalists look after their own safety to avoid to become the carrier of this disease, or to get themselves. So with that, let me a little bit explain, especially with regard, especially for our international audience, let me little bit explain the media landscape in Sri Lanka, just to understand, just to make you aware what kind of influence the media can make on the society like Sri Lanka. The Sri Lankan population is, as you know, all know, that 21 million, and we are having 5.4 million households in Sri Lanka, and out of these 5.4 households, we are having around 4.8 million households with television stations. That means we are having very wider reach of any media. And we are having 24 TV channels, 50 radio stations, and 70 newspapers. And we are having, in Sri Lanka, we are having 7.13 internet users. However, and also we are having 6.2 social media users. But during this presentation, I'm not very much touched about talking about social media, because once we start to talk about social media, it is very difficult to kind of confine or concentrate on responsibilities. I mean that the social media is not for that. And I mean, if we are talking about responsible journalism in theoretical perspective, we have to think, or we have to confine only about the mainstream media. So according to this penetration, we are having a very high reach, especially with 90% literacy rate, and even the mobile phone connection, we are having 149% mobile phone connection. That means we are having more mobile phone connections than our population. So that means, and we are having some special characteristic also that. So the Sri Lankan media landscape, we are having some special characteristics which can be used, which can be used to especially used in a pandemic like this. Not only that, even in any other natural disaster, we are having very good infrastructure altogether. Say, for example, Department of Government Information, where I'm heading, is 70 years, old. Also, we are in existence for 70 years. That means for any kind of a disaster or any kind of a disaster communication, we are having a very good infrastructure. So through that infrastructure, and we can reach even the very grassroots level, and within seconds, we can carry any message to each and every corner of the society or the country. So that is the kind of strength what we are having. And from the centralized location, we can control this information flow. That is the one of the advantage what Sri Lanka is having. And so we have to capitalize that advantage, especially during a pandemic like COVID. And at the moment, even we are doing it. So with that background, if I ask the question, does media in Sri Lanka behave in responsible way during the last 1.5 years, with the last few months, during especially with this pandemic, we have undergone few kind of waves. This at the moment. Commonly we say that we are now in the second wave of this COVID. So during that period, what is the behavior of Sri Lankan media? Are we satisfied with it? And is it responsible and responsible way they behave? I mean, this is a question we all can ask, but I'm very much sure that there is no clear answer for that. But depending on your experience, you will give different answers. But I'm very much sure that most of you will say that the Sri Lanka media is not that much responsible from different perspective. But before come to that kind of a conclusion, it is better to understand how really Sri Lankan media really behave during last few months, especially during this COVID pandemic. So I would like to analyze this from my observation. I like to categorize the media behavior into 3 phases. First phase is the pre-pandemic era, which I'm referring the era, before the first patient report in Sri Lanka, the COVID patient report in Sri Lanka, during that period, the society is very much unaware about the all these kind of information. Say for example, even the society is unaware about the symptoms, even what are the basic health practices need to be followed, and the contact points if there is in incident, and quarantine process. Everything is new to the society. During that period, the media played a major role to disseminate information, and they sacrifice most of their airtime to educate public by all means. I think the Sri Lankan population, the Sri Lankan public, they are having experience what kind of information they get from the media, and because of their commitment and involvement. At the moment, everybody knows, even the small child knows what are the symptoms and to whom they have to contact, and everybody knows about in and out about this COVID. So that means during the pre-pandemic era, the media played considerable role, and they, according to my understanding and my analysis, they played a very vital role, and they play in a very responsible way also. And the first wave of the pandemic, that means once we start reporting start reporting the patients, and during that period, the media start to report the incident reporting, and then this become the novel experience for media also, and this is highly enthusiastic for them, and this starts the breaking news. That is they start to the breaking news also, and then time to time they start to overreact also. That is where the problems began, and although they start with a very good in a controlled way and with a very useful manner, time to come they start to little bit overreact. That is where the invading the privacy become obvious. So during the second phase or the first phase of the pandemic, we observe some kind of a little bit irresponsible media reporting, and people start to kind of criticize media during this period. And then the second wave, now what we are undergoing now, during that period, there are some features like this now for the media also. This is not the new kind of experience. This becomes a very monotonous affair, and because of that, they are trying to create some news value using some unwanted or unexpected or unethical practices. That is where the people get panic, and sometimes it went to the extent of because of the behavior of the information which or the media, sometimes it led even the infected people to hide from the authorities, and it sometimes the media sometimes can create some kind of a panic situation, and also it gives publicity for unscientific cures and medicines. And
Mr. Kaleva, I'm sorry to disturb you. You have 2 minutes more to wrap up, please.
Okay. So I'll pass. So this mainly about what are the main claims against media. So during this scenario, this mainly about the false and misleading news, and especially unethical behaviors and panic behavior, as I explained, and stigmatization and exclusion. All these are the claims against media. So what are the reasons for this kind of, if we explain this as a lack of professionalism, what are the reasons for this lack of professionalism? So first thing, in Sri Lankan context, non-availability of code of ethics. That is, this is very sad to say, but in Sri Lankan context, we don't have the code of ethics for all the media. That it doesn't mean that media outlets they are having some media code of ethics, but in general terms, there is no all accepted code of ethics. Lack of guidelines, we are also responsible for that. Then when government and all authorities must provide guidelines, and competition. I think this is the main reason for lack of professionalism and breaking news. And media professionals are lack of education and experience, especially with regard to reporting this kind of pandemic situation. If I miss some factors here, and what is the conclusion I can arrive out of that? I argue that media played a vital role in combating COVID-19, and according to my observation, in relative terms, media act in responsible way in most instances. And I also point out that media cannot be isolated from society. If the society is in panic mode, it's very difficult to avoid media also getting into that same panic mode. So, and also the people's expectation. If the people expect different aspects from the media, it is very difficult to control, or having a very professional media if the people's expectation are not in par with in highest expectations. And media culture is very much important, especially the information culture and the institutional culture. The information culture means all the time if there is no proper mechanism to verify or confirm news or information, then there can be much chaos in a media. So all these are the kind of aspects we need to take into consideration. And at the moment, the Sri Lanka media is mostly follow the theory, according to my observation, demand and supply. If society requests something, media is ready to provide that. Because of that, that is where the media lose the professionalism and responsibilities. And way forward, if we try to rectify the situation, or if we need more professional approach, definitely all the stakeholders like media outlets, politicians, and citizens must get together, and they have to pressurize for very much paradigm shift of the media culture. So that is my kind of observation. Thank you very much for this opportunity.
Thank you very much, Mr. Kalwewa, for sharing that information with us and your expertise. We have a question from the audience, just one, because of the time. That is to Dr. Raina. Professor Raina, are there any socioeconomic differences between symptomatic and asymptomatic patients in your analysis? If it's going to take time to come up, then I would suggest that the answer is sent through online means. Professor Raina? Okay, I think that's going to take time. So let's move on. Thank you very much, everyone, for joining this first session. And now we'll hand this over to the next chairperson to continue the second session of this morning. Over to you, Professor Jayasinghe.
Thank you, Professor Karunavira, for chairing the session. Ladies and gentlemen, you are cordially invited. Ladies and gentlemen, let us now move on to the third plenary session of the National Conference on COVID-19. The theme of this session is Importance of Indigenous Medicine in Combating COVID-19. This session will be chaired by Professor Saroj Jayasinghe, who is the Chair Professor of Medicine, Faculty of Medicine, University of Colombo. I would now like to invite Professor Jayasinghe to chair this session.
Thank you very much. I am standing for Dr. Senaka Pilapitiya today, and it's a pleasure to share this plenary session 3. We have 2 presentations. The first presentation is on prospects of containing COVID-19 through indigenous medicine. And the speaker will be Dr. Kamal Pereira, Senior Lecturer in Ayurveda, Institute of Indigenous Medicine, University of Colombo, and honorary consultant physician in Ayurveda National Teaching Hospital in Sri Lanka. Over to you, Kamal.
Yeah, I'm going directly to my business due to time constraints. So today's topic is prospects of containing COVID-19 through indigenous medicine. I thought that is much related topic nowadays. So to begin these are the key points that I am addressing today. Do indigenous medicine community approach effective in COVID management? Then what is the indigenous medicine integrated in disease management? Then what are the available indigenous medicine tools for COVID-19 management? Then finally, what are the strategies for conducting research? These are the more suitable points that actually I focus on this, my topic. So as you know that when it comes to Sri Lanka, all the Sri Lankan indigenous medicine community approach governed by the Department of Ayurveda. It's come under Ministry of Health. You can see the strength of indigenous systems of medicine here. You know that it's top to bottom. If you go there, you can go. It's very easily penetrate to the that ground level within this system. So it's strengthily built these systems in Sri Lanka. So I just brought up here that some sort of Sri Lankan Ayurvedic community medicine approaches, because you know that when it comes to community medicine in respect of especially indigenous sector, so they all are involved in do some sort of works on mitigating this COVID-19 pandemic in Sri Lanka. So I would like to respect them. Then again, recently that the COVID management center developed in Ayurveda Hospital Pallekele. Actually, this is still it's new to comment about this. So we'll see the that outcomes in future. So when it comes to the indigenous medicine sector, you can see the available tools and opportunities when it comes to this pandemic era, especially when it comes to Sri Lankan indigenous foods habits, preventive and curative indigenous medical practices. Actually, I call it indigenous health vaccine. As you know, when it comes to the country, we all use these habits, preventive measures, and some sort of curative medical practices. So then again, when it comes to immunomodulating remedies with indigenous knowledge, this is actually the available tools in these aspects that this actually leads to the innovations of some sort of herbal products. It's also towards the health tourism in future. So you can see that these are the stakeholders involved in this indigenous sector, especially the consumers. You know that when it comes to the globe, also these are much health conscious with natural medications. Also, it's related to the aging population when it comes to the indigenous sector. So then healthcare professionals, especially that as us that will like to do some sort of discoveries through this sector. Then again, industry retailers, they all are searching for growth opportunities through this. Then the government, they are having a special set of guidelines, regulatory frameworks. Then again, that's a good remedy for the rising healthcare cost, these systems. So as you know that when it comes to global herbal medicine market revenue, this is the world map. It's a billion business, that US dollar billion business. So these opportunities that when it comes to that even this pandemic era. So as you know that these are the lessons we learn in both systems, maybe indigenous and allopathic. What is that? It's a drug emergency. We need more drugs. When it comes to the indigenous system that you can see here, we can do some sort of product developments and innovations through the reverse pharmacologically. So this is the way forward in most of countries nowadays in the globe. So then again, I want to say that when it comes to common perceptions about these traditional systems of medicine, they think that they had developed over time by trial and error. Now are time tested. That's part of cultural heritage. Sometimes this may be that is misperceptions to lead into a vacuum of scientific evidences. So because that when it comes to research and developing, this perspective is very much important. So in my opinion, these systems, most of these systems are well-established systems. many indigenous systems medicines are not results of adaptation or practices by trial and error, especially that such systems are built on strong and logical fundamentals, so they may be beyond different set of paradigms. For example, in Sri Lankan Ayurveda, you can see here they manage this COVID-19 pandemic. They have logical pathways. You know that when it comes to the disease management, they are following some sort of idiopathogenesis when they are developing drugs, when they are treating patients. So, you know, that is much logical practices in these systems. So again, the therapeutic approaches is the same. Then when it comes to research methodologies, especially that I want to focus in, this is because of this National Science Foundation. So methodologies for research and evaluation of TM should be based on following basic principles, especially when it comes to methodologies, should guarantee the safety and efficacy of herbal medicines and traditional procedures-based therapies, especially when you are doing clinical trials. This is very much important to guarantee the safety and efficacy of herbal products before going to the patients. Then understanding the economic incommensurability of traditional medicine and providing room to incorporate the fundamental approaches is very much needed in research planning, protocol developments, and reviewing research. So then again, when it comes to this pandemic scenario, that herbs and traditional medicines for COVID-19, the herbs natural compounds which antiviral activity and that caused inhibition blockade of COVID host protein pathways are potential therapeutic candidates. These are some sort of assumptions actually that's when it comes to that, especially the SARS-CoV-1 era. So it's much, you know, that there's a homology between SARS-CoV-1 and SARS-CoV-2. It's around 80%. You know, that is globe think that especially when you are using some herbs in SARS-CoV-2, herbs compound for the former would like to be beneficial for the later, also depending on the target protein similarities between the viruses. This is some sort of global pattern when you are developing herbal drugs towards the COVID. So especially I want to emphasize here that when it comes to the clinical product innovation process, you know that there are some guidelines laid by the globe, especially the ICH guidelines. When it comes to the traditional medicines, drug development, this is mammoth process. Anyhow, we can adhere some sort of points in here in this triangle. But in my case, I'm thinking we can go for a WHO guidelines. It's very much related to us because these are very high-end, you know, that practical innovation processes. So again, I want to emphasize here that, and then this is a special case from Japan, how they develop their drugs, especially that they use pharmaceutical GMP and traditional medicine GMP together when they are developing drugs. This system is good for us when we are developing our, you know, that these indigenous medicines, especially that innovative medicines. So likewise, again, that we have to adhere some guidelines, especially that PICS guidelines. Actually, we have to get some sort of affiliations of these organizations, especially if you are targeting the export market. So then these are the WHO guidelines. I will just show you these guidelines, safety, efficacy, and quality of herbal medicines. We have to adhere these guidelines before go for a clinical trial, especially drug development process. So this is all about the clinical development nowadays because it's very much needed if you're targeting the export market. So before starting any sort of clinical trial, this is must. You have to achieve the good manufacturing practices in your products. You have to use good laboratory practices. Not only that, when you are doing clinical trials, you have to do the good clinical practices and good clinical laboratory practices. You know that these four criteria are essential when you are developing these drugs, not only the Western drugs. Nowadays, it's also the indigenous systems of medicines. Then again, it's the protocol. It is very much needed to follow the country laws and regulations, then ethical standards, then good clinical practices. So these are the very much essential points that when it comes to these systems. Then again, there are some guidelines laid by WHO and some other organizations. We can follow these guidelines. It gives some sort of sense that when you are developing clinical trials, there are, you know, that they'll laid that how we can conduct these trials. So anyhow, these systems, we need a standard product, especially that when you are developing these drugs to the market. Then we need to get the ethical clearance. Then your trial should be registered. Then conducting trial, that data management should be there. Then again, the product registration and publication, you have to think about the intellectual property rights issues in here. Then again, not only that, after you put in the drugs into the market, you have to think about the pharmacovigilance safety studies. This is overall the system. Sometimes we think that these are the traditional systems of medicine. We don't need these things. But we're not targeting, especially the export market. You need this. That we have to come to this cycle again. So these are the real examples in this pandemic era. You can see here India, when it comes to clinical trial registries, especially the WHO accepted clinical trial registries, then 63 records we can found in Ayurvedic medicine. So they are much forward in. Then again, exceptionally well in China, they found that 132 the trials when this COVID pandemic era. So then again, at the very beginning, the China, they implemented this guidance for coronavirus and disease in 2019. Within this guidance that they implemented, how this traditional system should be involved in this process. Within that, that time to time they revise according to the research aspects. Then you can see here, TCM is effective in preventing COVID-19. That's the recent publication. And medical staff can prevent heterogenic infection by taking decoction made made based on the principles of TCM. So this is very much important, right? Then again, as of March 13, 2020, new cases of COVID-19 in China have decreased in number to single digits. So TCM curative effects was outstanding with a national participation rate for over 90%. It's very much important to us also. So then again, you can see another recent publication, they said that TCM herbal medicines at the forefront battle against COVID-19 with their clinical experience and scientific basis. That is very much important, the scientific basis. So then again, they found that how the mechanisms of this. That's why, that when it comes to these medicines, nowadays it's very easy to do trials because we know that behind scenario, what's happening there. So you can see here these pictures. I'm not much talk about these things. That then again, you can see the compound, that antiviral coronavirus host protein pathways inhibiting properties of herbs and natural compounds, additional weapons in the fight against COVID-19 pandemic. So these are the way forward, especially in indigenous systems of medicine. Another real thing that I put here, they have done that efficacy of Shenshi, the drop-in pills and in-house Chinwan granules in the treatment of COVID-19, a randomized control trial. If you go through this, they found that these systems are very much effective. So there are thousands of formulas we are having that. We need to trial these things, not only one or two. So we have to put in this pipeline in our medicines also to that gain this type of achievements. So not only China, you can see the Thai medicines. Right? They recently introduced that Androcapis paniculator. In Sri Lanka, we call it Heen Bing Komba. This is a very famous drug in Sri Lankan Ayurveda and traditional systems of medicine. So likewise, that you can see there are some other plant materials pop up here. You can see that all are available in Sri Lanka. Right? We need to do some more research in this actually when it comes to our systems of medicine. So then again, you can see the novel involvement, especially that nanoparticles based therapies. That these systems nowadays changing, evolving, and developing. So in the world, so we have to adhere those way of doing in Sri Lanka, right? in scientific manner. So I want to tell you that some sort of that success stories when it comes to reverse pharmacology approaches in our research areas. You can see that we conducting this trial, that efficacy and safety of 2 Ayurvedic dosage forms of allergic rhinitis, study protocol for an open label randomized control trial. Actually, I include this in here, that if your mind is in good manner, right, you can develop our traditional systems like in this type of formats. So it's good for the that Sri Lanka when it comes economically. These are the the ticket, right, to future developments of economy in Sri Lanka. So then again, another one. This is actually very famous, that Sudarshana suspension. We did in around 2014, 15 somewhere there. This is not for the COVID actually. Now we are changing this pattern and we are putting another pipeline to see whether this product is good for COVID management or not. So likewise, when you are doing even preventive medicines, you need to do some sort of clinical trials before it's included in the market. So finally, I want to indigenous medicine in Sri Lanka. You need a policy developments, especially that we don't have the policy for the indigenous systems of medicine in Sri Lanka. Then other standards in actually you can see here. So if you overcome this, actually we can develop a little bit more fast manner our systems of indigenous systems of medicine. So as a further readings, I put these two research works which I involved in. So thank you very much again giving me this opportunity for the NSF. Thank you again.
Thank you very much, Hamal. I think we'll take the questions later on because we are running behind time. It's my pleasure now to invite Dr. G.A.S. Premakumara, from the chairman of the Industrial Technology Institute, formerly the CISR, and he will speak to us on phytochemical and pharmacological aspects of indigenous medicine. Over to you.
Good morning to all of you, and thank you very much for inviting me for this important conference. And my topic is phytochemical and pharmacological aspects of indigenous medicine. So as you all know, the plant kingdom is the largest nature's repository of chemicals in the world. And it is estimated to harbor about 200,000 different phytochemicals in a single given plant. And the largest single source for bioactive molecules. And as you all know, we have not studied even 10% of this remarkable natural resource for potential applications. Therefore, we consider this plant kingdom as a sleeping giant with over 750,000 different plant species in the world. Since it carries a lot of pharmacologically active molecules, we consider this kingdom as the nature's pharmacy. And also, it is the single source for herbal-based medicines. And also, the source for about 50% of allopathic medicines. And it is the largest source for aroma compounds. So if you look at the Western pharmacopoeia, the most important drugs that are available in the Western pharmacopoeias are derived from the plant kingdom. And good example is morphine, which was isolated in 1806 and marketed as a drug somewhere in 1825-26, but still the only painkiller available for Western medicine for management of pain. So likewise, almost all antibiotics are from nature, and also some anti-cancer compounds that are available for treatments of various different cancers. And these are the formulations that are available in the Western pharmacopoeia, in the pharmacies, from these natural compounds that are derived from the plant kingdom. So if you look at allopathic or the Western medicine, they mainly depend on isolated natural products or synthetic single active ingredient. And if you look at the drugs that are approved during the 1981 to 2014, there were 1,562 drugs approved. And out of that, 67 are straight from natural products. 320 are from natural products derivatives. 61 are from natural product pharmacophores. And 334 are natural product mimics. 9 botanicals, and 250 are biologicals. And if you take traditional indigenous medicine. They mainly depend on the plant kingdom and use polyherbal formulations or many plant parts, plants are there in those formulations, and expecting synergism, complementary actions. And also it corrects the root cause rather than symptomatic treatment with less or no side effects. And there are 28,187 medicinal plants used in the herbal medicines in the world. And we have 1,414 medicinal plants in Sri Lanka. And we are using about 200 medicinal plants for herbal drugs or indigenous medicine. And about 50 species are heavily used. So if you take the plant families, the family Moraceae has 22.5% number of species used in the traditional medical systems. And the other families like Apiaceae, Laminaceae, and so on, Solanaceae, of course, from 11% to 14%. If you look at the anti-cancer drug vincristine and vinblastine, which are derived from the Madagascar periwinkle or Catharanthus roseus in scientific terms, and in Sri Lanka we call it Minimal, is from the family Apocynaceae. And if you look at the blood thinning drug warfarin, which is derived from a coumarin compound isolated from sweet clover, and it's from the Fabaceae family. So there are plant families that are very common in traditional systems of medicines. So these are some of the bioactive compounds that are available in Western pharmacopoeia that are mostly are from the family called alkaloid family. And if you take like tropane and nicotine alkaloids, they are mainly from the family Solanaceae. And we are using about 21 different species from this family in indigenous medicines in Sri Lanka. And if you take amyloidaceae alkaloids, a very important compound I have given here is galantamine, which is used for treatment of Alzheimer's disease, and it is available as Residine in the Western pharmacopoeia. So the pharmacological uses of this group of alkaloids are a potent inhibition of acetylcholine esterase, cytotoxicity, antibacterial, antiviral, anti-inflammatory, anti-parasitic, antihistaminic, and so on. So, and also the pharmaceutical potential of these alkaloids recognized by the galantamine as an Alzheimer drug due to its potent and selective anticholinesterase activity. Then if you look at the terpene indole alkaloids, the camptothecin is one of the important compounds that was isolated from Camptothecea acuminata, the Datkatia, what is available in Sri Lanka. And this is a very strong anti-cancer agent which can inhibit DNA topoisomerase in cancer cells. And also camptothecin inhibits retroviruses such as HIV and the equine infections anemia virus, and also has also shown good activity against parasitic trypanosomas and leishmania. So with those interesting compounds that are present in the plant kingdom, and Sri Lanka being hotspots, biodiversity hotspots in the world, and having 1,114 medicinal plants available, we also are very lucky with having a wealth of traditional knowledge which are documented and available in folklore as well as with some tacit knowledge. So Sri Lanka is a country full of indigenous medicinal knowledge. And we report the world first Ayurvedic hospital, and also a range of different medicinal formulations, plants, both in documented form as well as in the folklore knowledge. So scientific explanation to traditional knowledge is possible now with all this advancement of different sciences. So there are some interesting examples that have validated this traditional knowledge through modern science. Certain factors are beyond the knowledge of modern science. Specific health benefits of a specific plant species is proven now to be due to the presence of specific phytochemicals that can prevent or cure disease. These phytochemicals are working even at a level of regulation of the genes of an individual. So I have some examples from my own work on sesame lignans on hepatic lipid metabolism. So study of sesame oil on hepatic lipid metabolism has proved that specific phytochemicals in sesame oil, that is sesamine and episesamine, regulate liver enzymes by regulating liver genes responsible for fat metabolism. So this shows that, the phytochemicals that are found in your medicinal plants are capable of correcting any changes that may have occurred in your genetic makeup. So another interesting research that we conducted proved an explanation given in the 3,000-year-old medicinal text Susruta Samhita on a process that caused vitiligo in man. Now, according to the description given in the text, a rat bite can lead to vitiligo, and that rat should be sexually active at the time of the bite, and rat sukra, the semen, has to enter the human body through that bite. So we conducted a well-controlled experiment at the Department of Zoology, University of Colombo, using sexually active Vista rat, and we proved that sexually active rats do have semen in their mouth. So during a bite, rat semen can enter man's circulation, and this semen possibly act as an antigen, forming antibodies that identify and destroy melanocytes causing vitiligo. Then another interesting part of these traditional systems of medicine is that the collection of their medicinal raw materials, so they have a prescription for that as well. So you have to collect the material in certain time of the day, certain period of the year, and so on. So the migration of phytochemicals in plant from one area to another and enrichment with beneficial phytochemicals based on the environmental dynamics is well established in current plant sciences. So our ancestors used these dynamics to manipulate biosynthesis of interested phytochemistry, maybe for better taste, aroma, and to enrich nutritive components in their food plants and to enrich bioactive phytochemicals in their medicinal plants. So these recent findings explain the vast knowledge base available in traditional biodynamic-based cultivation practices, harvesting practices, post-harvest management, and post-harvest preparation techniques for our food and medicinal plants. Yeah, if one wishes to harvest a plant part for a medicine that should enrich with phytochemicals produced through photosensitive biosynthesis, one needs to harvest the plant part in the morning from the side of the plant facing the rising sun. So studies on these the phytochemical changes due to photoperiod is given here. I'm not going to go into detail. So by changing the photoperiod, you will be able to change the phytochemistry of your plant. Not only the light intensity, the light quality, the temperature, the soil moisture, soil fertility, and so on is matters for this production of phytochemistry in these plants. So let me give you a very interesting example of for the scientific explanation of indigenous knowledge. The knowledge on selection of specific plant parts and use of specific quantity from that part into the medicinal recipe ensures the required dose of the active ingredients in the formulation in order to give ultimate efficacy of the treatment. So our work on antidiabetic plant Kothala hibutu or Salacia reticulata showed all plant parts contain glucosidase inhibitory activity, but at various different levels. So these are the plant parts that we studied: flower, fruit, the leaf at different maturity stage, stem bark, the roots, and so on. So as you can see from these the graphs given here, You can see the IC50 values for glucosidase inhibition and anti-glycation activity. You can see that the leaves has very less activity, whereas the root and the stem has a very high activity. So in a formulation in Ayurveda, it says that, okay, take about this much of quantity from root. So that quantity, if you take from a leaf or a stem, will not have the efficacy that you expect at the end of the formulation. And also, if you look at this interesting plant, the use of root of this plant in indigenous formulations for diabetic is a remarkable example to explain the richness of our traditional knowledge on our indigenous medicine system. The scientific findings have evidence position of a multitude of diabetic control mechanisms within this single plant. Kothalimutu decoction extract controls blood sugar by inhibiting starch breakdown enzymes in the gut, thereby preventing release of glucose from starchy foods in the gut. It is well proved now the plant extract control blood sugar by blocking the activity of enzymes alpha glucosidase, beta glucosidase, and alpha amylase in the gut. Not only that, the Kothalimutu has the ability to block gluconeogenesis in the liver, the process that converts amino acids into glucose, by inhibiting the gene for gluconeogenesis rate determining enzyme in the liver. And interestingly, this remarkable plant is also able to control blood sugar by inhibiting conversion of glycogen to glucose in the liver. Diabetic complications or pathology is mainly due to protein glycation in diabetics, leading to the formation of advanced glycated end products in vital organs and the cardiovascular system. So uncontrolled diabetics results in high glucose levels in the blood circulation, and this glucose tends to go into reaction with proteins and lipids and deposits, especially in the vital organs. And Kothalimutu demonstrates its ability to block AGE formation and also its remarkable ability to reverse the ability of breaking crosslinks of already formed AGEs. This is a very interesting graph experiment that conducted by Professor Joji Yamahara in Japan. He tested the water-soluble fraction or water extract that we drink and the isolated compound, the salicynol, in sucrose challenge test. As you can see, you don't see much different from the water-soluble fraction, the activity of water-soluble fraction, and the isolated single compound here. And we also experiments on phytochemicals of Sri Lankan medicinal plants. We determined all Sri Lankan natural products published from medicinal plants during the last 2 decades. From our database, over 480 different compounds were screened in silico for selected drug targets. And several potential drug leads were identified for further development, such as ACE inhibitors, aldose reductase inhibitors, and renin inhibitors. And interestingly, when searched for the origin of the active compounds, the compounds retrospectively correlates with the medicinal plants that are given for hypertension, dyslipidemia, hyperglycemia, and cardiovascular problems in our traditional medical systems. So let us look at the indigenous knowledge of infectious diseases, which is very important and the topic of today's symposium. So there is a wealth of knowledge in the country on the management of infectious diseases that are coming from the traditional knowledge, indigenous medicine, Ayurveda, and folklore. And it looks, the methods available are very rational when we look at the amount of antibacterial, antifungal, antiviral, immunomodulatory, anti-inflammatory, and other anti-infectious properties reporting from medicinal herbs and indigenous medicinal preparations. So we all know that the antibiotics are all from the nature, and we are now facing the antibiotic resistance, and we still rely on the plant kingdom for next revolution of antibiotics. And these are the antibiotics that are known for us and available in Western pharmacopoeia. And a lot of different antibiotics and antiviral compounds have been reported and available in the Western pharmacopoeia for treatments. So these are 2 compounds that are originated from Sri Lanka, lancomycin and lancashidine. Now these 2 compounds are tried for methicillin-resistant Staphylococcus aureus infection, the deadly disease. by Professor Ada Ionata, the Nobel laureate in Israel, and that's me with her in that picture. And maybe that these two compounds will be available as a drug in the future. So a lot of antiviral compounds are there in this plant kingdom, and I have listed out this, and I have no time to go through individually, but you have antiviral compounds from all different classes of compounds that are found in the plant kingdom. So use of polyherbal formulations to treat infectious diseases in indigenous systems of medicine, therefore scientifically very rational. And the other approach in indigenous system is the enhancement of immunity. So you see a lot of different formulations. We know it and available in the market to increase your immunity. If you take the Ayurvedic department, the Suvadarani, it carries 4 medicinal plants, that is Kottamalli, Venivelgata, Viyalinguru, and Heenaratta. So Kottamalli, that is Coriandrum sativum, Venivelgata, Cocinium fenestratum, Viyalinguru, Inguru, Sinjiba officinale, and Heenaratta, Alpinia calcarata. So we all know that we drink Kottamalli, Venivelgata when you feel like, getting some kind of cold. So we drink this, it's a common household remedy for these infectious diseases. So we tried this combination, and we experimented, and we proved that this combination or the concoction is capable of increasing both humoral and cell-mediated immunity. And we also showed that the Alpinia calcarata, the other compound, the Heenaratta, that is there, is also possess anti-inflammatory activity. So let me show you at the very last, maybe few slides, that on our work on COVID-19. So we screened this 480 compounds that we determined for the main protease enzyme of SARS-CoV-2, mFRO, which plays a pivotal role in mediating viral replication and transcription. So we are very happy to disclose that we got 3 compounds with strong binding energy for above key enzyme mFRO. So we are working on these 3 compounds further, but I cannot tell you from where we got this, and I can tell you that this is from one of the very common food ingredients that we use in our day-to-day life. So we screened a range of compounds, and we got 3 important compounds for the mFRO inhibition, and we are working on that. And we also screened these compounds for ACE1 inhibitory activity, and we are working on ACE2 inhibitory activity as well. So you see now there are natural flavonoids and other compounds that have been tested and proved that it's capable of inhibiting the anti-SARS-CoV-2 ACE2 entry point. So I would like to bring your attention to this correspondence in the Lancet Infectious Disease 2020, published in April 2020. So what is given there is a plea for multi-targeted intervention for severe COVID-19. So it says that severe coronavirus disease 2019 is not just a serious respiratory viral disease as influenza is, but rather a systemic multi-organ viral invasion. It is quite frequently frequently complicated by overwhelming immunological reactions with overactivation of T cells, leading to acute respiratory distress syndrome and multi-organ failure secondary to immunopathological processes. The viral load of severe acute respiratory syndrome coronavirus 2 is not correlated with worsening symptoms, but it is the host inflammatory response that is a major cause of lung damage and subsequent mortality. So hyperinflammatory response in patients with COVID-19 are associated with a cytokine storm that is characterized by an increase in pro-inflammatory cytokines, including tumor necrosis factor, interleukin 1 beta, IL-6, and other chemokines in serum. So most clinical trials to date have evaluated various strategies of antivirals, immunomodulators, host-target drugs, immune-based therapies, or immunosuppressive drugs, including steroids, IL-6, IL-1, antagonists, and so on, all have assessed as single drugs with a clinical endpoint using the WHO 7-point ordinal scale. So although some of these drugs might have a clinically meaningful effects on viral burden or some of the immune-related signs, it is highly improbable that a single drug will be enough to control and improve the most severe forms of COVID-19. Without studying combinations and their potential synergies or additive effects, potentially useful agents could be disregarded. In the absence of synergistic combinations, single drugs might cause more harm. For example, mass killing of the virus might enhance inflammatory responses. So because of the urgency of the current situation, and so far an absence of clear evidence of a clinically meaningful effect of any monotherapy strategy, investigators should join their efforts in proposing rather than adaptive or sequential studies of a single strategy, combine approaches through meaningful designs. Therefore, the plea for multi-targeted interventions for severe COVID-19. So if you take the multifunctional phytochemicals with synergistic and active effects, additive effects available in polyherbal formulations, as you can see in this diagram, plant drug analysis, those bands what you show are the compounds that are present in these plants. As I told you, about 200,000 per plant. And any one of those compound can be antiviral, and it can be anti-inflammatory. It can be immuno-enhancing, immunomodulatory. It can be, inhibit the viral replication. It may kill the viral. So you have a range of different, the weapons to attack your enemy. So for good example is curcumin. You have, you can control your cytokine storm easily. So given to the facts that I have shared with you all, it is very pertinent and rational to test indigenous medicines for management of COVID-19 pandemic. Thank you.
Very much, Dr. Premakumara, for your presentation. I think the time is up, so I think we have to get on with the next session. And there are international people who are linking through the international Zoom, so I think we have to get on. Yes, please. Yeah.
Thank you very much, Professor Jayasinghe, for chairing this session. We shall now proceed to plenary session 4 on combating COVID-19, lessons learned and insights from North America. This session too shall be shared by Professor Jayasinghe, Professor and Head, Department of Clinical Medicine, Faculty of Medicine, University of Colombo. Over to you, sir.
Thank you very much. And once again, thank you to the two speakers of the plenary session 3. Now we get on to plenary session 4, which is on combating COVID-19, lessons and insights from North America. And we have a paper. There are 4 authors: Professor Dilantha Fernando, Dean, University of Manitoba in Canada; Professor Suranjit Senaviratne, Consultant and Clinical Immunology and Allergy Institute of Immunity and Transplantation in London, UK; Professor Deepthi Jayasekara, American Board Certified Infectious Disease Consultant, working in Western University, California; and Dr. Gerard Fernando, Director of Addiction Services and General Psychiatrist, Psychiatric Wellness Center in California. It's indeed a pleasure to chair this session of colleagues from Sri Lanka, and some of them my former pupils. So may I now request you to start your presentations. Thank you.
Thank you, Dr. Jayasinghe. My name is Dilanta Fernando, and it's a great pleasure to address this august audience. Thank you, Professor Senaratne, for inviting me and my team to give this presentation. You will quickly see why it's a team approach. And also, as Dr. Jayasinghe mentioned, Professor Deepthi Jayasekara and Professor Suranjit Senaratne are both students of Professor Jayasinghe. So it's a great pleasure to see that you are chairing this session. So I'm going to go into the share screen and get my presentation. Okay. So I hope you can see my screen. Can you see the screen?
Yes.
Yes. Okay. So what National Science Foundation had asked me and our team is to give a perspective of the North American situation. So I think it's a great opportunity to talk about North America and COVID, mainly because you can look at it from all different angles. In the third slide, you will quickly see why I say that. But before that, I just wanted to mention the team approach. So I will talk about the epidemiology, the economy, and the mitigation of this disease. Professor Jayasekara, who is a clinical professor from California, one of the worst affected states in the United States, who works with patients daily, will address you on that basis. Professor Suranjit Senaratne, who is from Oxford University and dealing with the knowledge of vaccine development and the differences in vaccines, will talk about that. And Dr. Iru Fernando, also from California, a psychiatrist, will talk about the ever important mental health due to COVID and wellness and recovery. So, as I said, why do I call North America to be that important? It is because there's the good, the bad, and the ugly. So the good is the two promising vaccines that have been developed so far in North America has come from the United States. That's the Pfizer-BioNTech vaccine, the Moderna vaccine. There's one more that's coming to be available, at least as emergency registration in February. That's from Johnson & Johnson. And there is also, just 2 days ago, there was an announcement in Canada that there is a nasal spray. Now, this is not a vaccine, but it's a nasal spray that with nitric oxide that could kill the virus. And that's now in clinical trials in UK and Canada. Now, the bad is that the two new variants from the UK and Africa are now here in both the United States and Canada. First, there were suspicions of the South African variant to be here. Now it has been confirmed. So with the knowledge that there are a number of more mutations and it can be more contagious, very recently they are also thinking that it could be more deadly. So there are certain implications with the new variants now in Canada and the United States. The ugly part, as I said, is that the United States has the highest COVID infections and deaths in the world. So 39 million cases in the Americas, that is Canada and in United States, and also the central part of America and Southern America, South America, from a total of 98 million in the world. Now, I was in Sri Lanka giving another presentation at the National Institute of Fundamental Studies in Hantana Kandy to commemorate a great scientist, Professor Cyril Ponnamperuma's 25th death anniversary, when I first came to know that there had been a COVID outbreak in China. And that was in the early part of January that it was announced, but people got excited about it and came to know about it only through the pictures that we saw, what was happening in China. And after that, we came to know slowly that the pathogen was moving, and the pathogen was now moving to other continents. And by early January, or sorry, I should say January 23rd, both Canada and the United States reported their first cases. So if you look at the map at that time, just 1 year ago, I was enjoying my time in Sri Lanka at that time. And you can easily see these days that there was a surge in the numbers of COVID cases in mainland China, but in the rest of the world, it was far less. But today, all this has been mitigated, and the world is still suffering with the COVID. So getting back to the numbers in North America, you will see that Canada has, this is as of January 21st, Canada has 728,000 cases, 642,000 have recovered, and there were 18,508 deaths. Now, compare that with the United States. It has 24.5 million cases. Now, in the United States, I could not find the number of recoveries. Now, Professor Jayasekara or Dr. Fernando can let me know why United States generally doesn't report the number of recoveries, because I think it's an important fact to know, because most of the people do recover, but they report the numbers of cases as well as the number of deaths. But you can see that the numbers of casualties has been extremely high. Now, if you now put it into some perspective of per capita, looking at the numbers, you see that still United States has about 7.4% cases, 1.23% deaths, compared to Canada, which is much lower. I also wanted to put Sri Lanka here, just to give you some perspective as to how Sri Lanka has done. And I commend the efforts. This is a non-political statement. We have to be proud what Sri Lanka has done as Sri Lankans. And the percent is very low compared to the developed and resource-rich countries. Now, looking at the epidemiology in the United States, we can see that there are now more deaths due to COVID-19 than the total number of deaths of Americans during World War II. That's really alarming and true. So 1 in 13 Americans are infected by COVID-19. That's the stats that was presented in the ABC News on January 21st. There's 10% of those who recover who are termed long haulers, as they continue to suffer from fatigue, depression, and other symptoms long after recovering from COVID. So I think this is where some of the things that Dr. Fernando in his presentation may address, the mental fatigue that comes with it as well, with the depression and all that comes after somebody has been infected by COVID. And nearly 16 million Americans are now collecting benefits from government and other organizations due to loss of employment. That's a huge number to be on benefits. As of today, that's January 7th, USA joined Canada, January 21st, USA joined Canada, who had made it mandatory to have a COVID negative result when entering Canada. Now, this has been implemented in other countries, especially in China, for a long, long time. But Canada and the United States were late to do that, but at least I'm happy that they have done that now. One of the other statistics that is generally alarming, and to the Sri Lankan audience might be very interesting to know, is that if you look at it from a race ethnicity platform, you see that the blacks, the Hispanics, and the Asians can be infected much more than the Caucasians. So that's something for us to think about, especially if you are an Asian and you are living in the United States or Canada, and the Hispanics and the blacks. Actually, it's 3 times more. So it's alarming to know that. Now, there are many factors. It's not just the genetics. There are many other factors, social and economic factors that play into this. And other scientists can talk to you about those later. So the question that I would like to ask, and I'm pretty sure Sri Lankans are doing pretty well, is are we in this together? Because we see on one side people adhering to the mask wearing, and Professor Raina made it very clear that how important the wearing of masks, showing the droplets and how it moves. And then on the left-hand side here, you see a lady who is fighting for her freedom and saying that she's not going to wear a mask. So my question is, what's your excuse for not wearing a mask? That has not come out from the people who are talking about freedom. I think responsibility comes before freedom in this pandemic. Now, that is very clear when you see this slide, when you see that you can, without protective measures, how easily daily numbers of cases can increase, whereas with protective measure, the numbers can be reduced, and also the healthcare system capacity is modulated to be on an easy level, so that the medical system can go on doing what they should be doing with hospitalizations and all. So just to give you some perspective in the North American context to my Sri Lankan friends, so what led to the stark differences in numbers between these countries? Look at Sri Lanka or Canada or the United States. So I think most of these countries like China, Sri Lanka are used to following regulations because we have a different system. And here, there's much more freedom, and we highly value freedom. And that's not a bad thing. But due to a pandemic, if we are only looking at freedom, then there's a problem. So that's where I think we went wrong. And also the wearing of masks was delayed here, both in Canada and the United States. And airports have been open and with no restrictions whatsoever for a long, long time. And no testing was done. And there were no need of reports. So as you can see, it's only in 2021 that United States and Canada are now putting a negative COVID test result to board a plane. So these were not in place for a full year. And looking at the mandatory quarantine versus self-quarantine. In Sri Lanka, you do the mandatory quarantine. In China, you do the mandatory quarantine. In Canada and the United States, it's called the self-quarantine. So it's a lax system. Some may do it very well, some may not. The initial focus in a resource-rich country like Canada was first to help the people. And that's nothing wrong with it. But once the focus was slightly different from what Sri Lanka would have taken, then there was a shift in the diseases and how it would go. And that's part of the reason that we initially got, and as you know, in epidemiology, once the disease has got out and established itself, it's much easier to progress and get to other areas very easily because people do travel and people can take that disease along with it. So another important thing that I said I will touch is the economy. And you can see that there was a sharp rise in unemployment, stress on supply chains, decrease in government income, collapse of the travel, tourism, and hospitality industry. It's reeling right now. And reduced consumer activity. All that has played a huge role in the market's instability due to the lockdown. And Canada's unemployment reached a high of 13.5 in May. Since then, it has come down. There have been more job opportunities, both in Canada and the United States. It has recovered. And actually, even the stock market has recovered extremely well. So we are doing pretty well in North America on that side of things, even though people are still suffering. People are without jobs, people are without houses. And again, Dr. Fernando will be able to touch on those, on how that is affecting the mental instability of patients. So if you look at this, you can easily see that another aspect that Professor Raina mentioned of the social distancing, how it flattens the curve. So that's an important factor. And if somebody tells you to make that social distance, especially if you're not wearing a mask, please do that, because you can easily see from science and published literature that social distancing works, and it works even better with the mask wearing. Now, to end my presentation and give it over to Professor Jayasekara, I just wanted to give you a good example of what happens when you do the right thing. So I'm in the province of Manitoba, and this is what we went through in the first phase. We did perfect. We were so proud. We were proud Manitobans at that time. And then something happened, and we got laxed with our ways of doing things, and the disease, the phase 2, was really playing a major role in our COVID situations in Manitoba. Immediately, the government of Manitoba put restrictions, and look at what happened. Within a month, it has been brought down. And if I took more data until today, it would be even more decreased. Now, another good news that I wanted to share with you before I finish is that Manitoba has come up with a plan. This is hot news, breaking news. Today, it was put out by the Premier of Manitoba. So you can see that there's a plan. And again, I'm putting this for my Sri Lankan colleagues. And if there are officials, government officials who are listening, it is high time you plan out the process, because it's so important. Now that the vaccines are coming, that's very good news to Sri Lanka. And I hope everybody will be vaccinated, but there has to be a strategy. If there's no strategy, it will be a failure. So we have a strategy. First, the healthcare workers, then the most vulnerable from age up going down. So that's the way that we will be vaccinated. And Manitobans hope that we can finish all the vaccinations by August 31st. So that's a very good hope. Hope we can do that. And finally, I wanted to bring this up because yesterday, Professor G.L. Pires was talking about school openings. And this, again, was just 1 hour ago. I was listening to CNN, and this was in the news that rise in student suicides raises concerns about the cost of keeping schools closed. So this is something to think about when people fight about things. There's other sides to a story, and the mental aspect of students has to be taken into account. So finally, the take-home message is we are all in this together, whether you are a Sri Lankan in Sri Lanka, or whether you are a Sri Lankan in Canada or the United States or the UK, we are all in this together. A collective need to do the right thing. So reasons for spread we have known now that by not wearing a mask or not doing the right social distancing. So let's do the right thing to bring this disease down and the spread to be curtailed. So just to bring everything together, wearing masks, social distancing, and the right quarantine practices will help. Rejuvenating the economy with stimulus packages and reopening of establishments is so important. The vaccine development in different countries and rapid production, we have to really be happy that COVID really brought about vaccine development to a really rapid level. And again, Professor Suranjit might address some of that. And the global approach to vaccinate all is so important. And again, I just saw in the news that I think today or tomorrow, Sri Lanka is getting the first batch of the COVID vaccine. So with that, I would ask everyone to get your vaccine when you can and make your country safe and the world safer. If you need to contact me, that's my email address. So thank you, everyone. And I will now hand it over to Professor Chayasekara to continue from here.
All right, I'm trying to share my screen. It won't let me. Good morning, good afternoon, good evening to all the viewers from all around the world. There you go. I think I'm good here, and I'm sharing my slides. I'm beginning to share my slides with you. I'm truly honored to have my Professor of Medicine as the co-chair of this plenary session. But for tonight, this morning, I will call him Saroj. And it's for Delanta, I had to tell you, it's a hard act to follow. That was an excellent talk. I learned so much from you. So I'm an infectious disease specialist, board certified, American board certified in internal medicine and infectious diseases. I'm a bedside clinician and a clinical professor, with a team of medical students, junior doctors, and also I give talks and lectures to the doctors. I will actually try to do this. There you go. And when we talk about this particular virus, this is a beautiful and a spectacular schematic of this virus. But this virus is a ruthless virus. How beautiful the schematics are. And it's a viral that's going viral all over the world, raging across the world still with a second wave. And I don't have to tell you what the features of this virus. It's a single-stranded RNA virus with a envelope, spherical envelope, and it's found only in birds and mammals. There are two main groups, two alphas and two betas. About 30% of common colds are caused by commonly found coronaviruses. But the three most virulent coronaviruses, SARS, MERS, and novel coronavirus, COVID-19 virus, are beta. Three beta belong to beta genera. Pathogenesis, I think we discussed that a lot. This is not just a respiratory virus. I'm sorry about my American pronunciation. This is not just a respiratory virus, but it's a systemic virus, and it attaches to the cell through a ACE2 receptor. So as we all know, we get it. We are all sick and tired of this quarantine process, right? There's no question about it. You wash your hands about 57 times in one day. This is what happens. You will have the robotic hand. And then, of course, you go through these stages of quarantine and see what happened to Mona Lisa. So bottom line, we talked about this. How do we prevent this COVID-19? This is a concept that I borrowed from Sri Lanka. Distancing dream concept. That's a formula that I use in my hospital chain. DREAM, which is distancing, respiratory etiquettes, aseptic technique, which is hand washing and sanitization, and mass. I've added some more M's, which are mRNA vaccines, Pfizer and Moderna. Of course, there are more vaccines to come, Johnson & Johnson and Oxford, AstraZeneca. And then I've added a sixth one, which we're going to go into details later on, monoclonal antibody cocktail. So the future, there's a paucity of therapeutics for COVID-19. Therefore, we have found a bridge called monoclonal antibody between prevention and treatment. How do we return to normalcy? By closing down countries, closing down airports, we cannot return to normalcy. So we have to understand that COVID-19, even in a country like United States, the death rate or the case fatality rate is hovering around 1. In Sri Lanka, they have done extremely well. So I would say, when you talk about quarantine measures, we were overdoing things in the first wave and the surge in between. But when it comes to second wave and beyond, we need to be very realistic about the quarantine requirements. Typically, once you are exposed to somebody who had COVID-19, you're required to quarantine for 7 days, not 14 days. So 7 days with a test done on day number 5. That is all that's required per CDC guidelines, proven by many studies. If you don't have means to do a test, your duration of quarantine is 10 days. Again, mitigation pearls, hand hygiene, social distancing, mask, that's not going to go away for a few more years. Surveillance testing, very important. We have 2 types of tests now. We have rapid antigen tests, we have PCR tests. Most of the hospitals, we do both, right? On admission, we do the rapid PCR. We have in-house PCR machines that we get the results within 1 hour. So rapid PCRs are mostly, produced by many companies, but mostly gene expert type of rapid PCRs we use. Regular PCR will take about 3 to 5 days, as you know. But rapid antigen tests, especially by good companies like Abbott, are equally good, I would say, about 90% accuracy. In general, rapid antigen test accuracy is less than PCR. Now, when it comes to contact tracing and quarantine, again, we talked about it, quarantine for 7 days. That's good enough. Somebody comes in from another country, right, and you got a negative test before you board the plane. So within the 72 hours. And then you test that person on 0 days, and then you test that person on day number 5. And that's good enough for you to discontinue quarantine. So I would propose, especially for folks who are vaccinated like me, for 7 days of quarantine is enough, with a PCR test done on day 0 and day 5. Day 12 concept is not a very good concept because 99.99% of the infections happen within those 7 days. Safeguards in workplaces, very, very important. Sanitization, plexiglass barriers, telework from home, vaccine. We're not talking about just a COVID-19 vaccine, other respiratory vaccines such as influenza and pneumococcal. So this is how we return to normalcy. When a patient comes to the hospital, these are the priorities we have. Recognize and prioritize patients with severe COVID-19. In other words, all kinds of patients will come in through fear, through anxiety, through paranoia to the hospital. They also have to realize that hospitals are inundated at this point. We are swamped with patients, especially in California, in the United States. We have had basically all the major hospitals are overcapacitated with these patients. So we have told them, and actually we do that from ER itself. We do the testing, we get the results within 1 hour. If the patients are not hypoxic, we send them home. Now, before we send them home, we give a monoclonal antibody cocktail, but that is because we do have it. It costs about $1,000 for an infusion. It's an intravenous infusion, only for high-risk patients. Regular patients, they go home with some antibiotic like doxycycline or azithromycin, and vitamin C, vitamin D3, and zinc sulfate. And we also give a prescription for either inhaler, steroid inhaler, or albuterol inhaler. Sometimes we give dexamethasone prescription. So we ask them, please go home and quarantine yourself for 14 days. Unfortunately, there's no way for us to police this because it's a self-quarantine process. But majority of our patients are behaving that way, the way we ask. So 14 days for patients who go home, and then implement strategies for the patients who come in. Infection prevention and control are very, very important. Our protocols are hardwired into hospital protocols. CDC protocols are hardwired into hospital protocols. We have separate, every hospital has, at least I would say 10 to 20 isolation rooms with negative air pressure and HEPA filters. And most of the hospitals, including some of my hospitals, we have opened up big floors into COVID ICUs and COVID floors. So those, and we have a dedicated group of people who are taking care of infection. We call them infection prevention nurses or infection preventionists. They help us with their team effort because this is a multidisciplinary approach. Provide early supportive care and monitoring, extremely important, and then we come to the treatment. So when it comes to the treatment, we need to understand the stages of COVID-19. Stage 1 is viremic stage. Within the first 7 days, you have the fevers, the body aches and pains, and then some diarrhea, some loss of taste, loss of smell, early infection. Majority of us, 80% of us, will go home or actually will have a mild situation like this. Stage 2, pulmonary phase, that's where we start feeling hypoxic, breathless, especially when you take a couple of steps. So at that stage, you have to stay in bed. That's the most important. You have to stay in bed and only go to the bathroom, right? If you try to overdo things, then only you get in trouble. Stage 3 is where your immune system is in overdrive, hyperimmune phase. Basically, this is the stage where cytokine storm happens and shock, cardiopulmonary collapse, and ARDS, multi-system organ failure happens. Stage 4 is the post-COVID stages. Post-COVID, if the patients don't go home within the 7 days, a lot of those patients end up in nosocomial infections, secondary gram-negative bacterial pneumonia, and fungal pneumonias. Staphylococcus aureus, somebody mentioned Staph aureus. Yes, we do have MRSA pneumonias. And then post-COVID long hauler syndromes, we have manifestations of myocarditis, other viral, other vasculitis situations like atypical Kawasaki, especially in children, and then of course the other scenarios that we can, and those can go on and on and on for 6 to 12 months. So in order to treat, we remember this. In order to remember the steps in the treatment protocols, we have come up with this protocol or formula called DRAPE, D-R-A-P-E. D for dexamethasone, R for remdesivir, A for anticoagulants and antibody cocktails, as well as antibiotics. Antibiotics are given because COVID-19 patients can potentially have secondary superimposed bacterial pneumonia. And then P for plasma, convalescent plasma, and then also for proning. I'll show you a picture of proning. And E for etc. Etc. could be vitamin C, vitamin D3, zinc sulfate, melatonin, and so on. So when you try to understand the therapeutics that we have used in COVID-19, these are the ones that we focus on. The specific ones of significance are immune modulators and antivirals. So we're going to go into details later on. Supportive care is a very, very significant part of COVID-19. Now, 20% will need ICU care, 7% will develop ARDS with 50% mortality. Early intubation, not recommended anymore. Like the first wave, we did a lot of early intubation. Now we found out those critical care protocols are not relevant, in fact, harmful to the patients. We use a lot of high flow oxygen with oxygen flow being pressurized to achieve 20 liters, 30 liters, 40 liters of oxygen per minute. And then we use high flow oxygen nasal cannula or high flow oxygen with non-rebreather mask. Dexamethasone is the standard of care. We're going to go into details of that. Standard of care since June because of the recovery trial by Oxford University. Dexamethasone or steroids are given only for hypoxic patients. If you use it before the patient becomes breathless, that could work against the patient because it's a virus. It's a viremic situation. You can enhance the viremia by giving steroids because it's an immune suppressor. It's going to suppress your own immunity. High dose vitamin C, vitamin D3, and zinc sulfate are extremely important. Convalescent plasma will boost your antibody response. For mild to moderate cases, we only give 1 to 2 units of convalescent plasma with some antibiotics, either macrolide like azithromycin or doxycycline. And then we give an antiviral medication called ivermectin. Ivermectin is a repurposed antiviral medication. It's an antiparasitic agent that we use commonly in river blindness and other things in Africa, and also scabies and other parasitic infestations in this country. So ivermectin has been shown over and over again to have in vitro suppression of the viral load by about 4,000, 5,000 times, which is a great thing. But the studies are still ongoing. It's a very cheap, very tolerable medication. But for severe illnesses, you're going to go to antivirals. Antiviral, the only FDA antiviral that we use is remdesivir. Remdesivir is a RNA-dependent RNA polymerase inhibitor. So it's a polymerase inhibitor. So, but it's a relatively weak antiviral, but it's still good. It's something is better than nothing, that concept. So remdesivir is used as standard of care in most of the hospitalized patients for severe infections with or without baricitinib. Baricitinib is a immune modulator that we use. So the recent NIH studies have shown that when you use remdesivir and baricitinib, your recovery time is faster from day number 15 to 11. So it's a faster recovery time. So that means less complications, less death, but there are no direct mortality benefits from remdesivir. That's why we need new therapy. There's a paucity of these antivirals, unfortunately. We use Kaletra in combination with favipiravir or Tamiflu or baloxavir, but because of all these studies going on, we stopped using these things. Favipiravir is not FDA approved in this country for whatever reason. Anticoagulation is the standard of treatment. Now, there are so many studies, but most recently, one of the recovery studies from Oxford and also active studies, ACTIV4 studies showed that especially in non-ICU patients, using therapeutic dosing of heparin and low molecular weight heparin saves lives. So, and then last but not least, critical care protocols such as prone positioning and ECMO, and of course, IL-1 and IL-6 inhibitors like anakinra and tocilizumab. This is a usual sight that when I walk into the hospital, most of the nurses are wearing a face shield with N95 mask. On top of that, there's a surgical mask, and then a gown and gloves, and they try to prone the patient. So this has been proven effective even in H1N1 days or before that to minimizing or mitigating the mortality. So sleeping on the belly or sleeping on the sides will save lives because it opens up a lot of free space in the lungs to breathe. And then steroids from recovery trial, we talked about this. I'm going to go through the next few slides very fast. Steroids from recovery trial came out. The results came out in June 2020. Even before that, in the United States and other Western countries, we used low-dose steroids, either methylprednisone or even hydrocortisone, low dose. Hydroxychloroquine is a different story, but dexamethasone is a life-saving drug. It actually was shown to have 30% mortality benefit in ICU patients and 20% in non-ICU patients. Duration of treatment is 10 days, 6 milligrams dexamethasone once a day for 10 days, and the cost is minimum. Remdesivir, again, it's an antiviral used in SARS and Ebola, and it inhibits the RNA polymerase, just like favipiravir and ribavirin. The side effects are renal failure, elevated liver enzymes, and thrombocytopenia. And of course, we talked about the NIH trial, which was published in May of New England Journal of Medicine, faster recovery time by 30%. It's administered in intravenous form, a 200 milligram loading dose day 1, and then day number 2, 3, 4, and 5, we give 100 milligrams daily. We do not give 10 days of treatment anymore because obviously there's no viremia beyond the first 7 days or so. It was studied in combination with JAK1, latinidase kinase 1 and 2, which are immune modulators, and we use that as our standard of care now in the hospitals, which is a biologic agent. So tocilizumab is used in most of the countries, including India, to mitigate the cytokine storm. And this was further proven effective by a recent study called IMPACTA study. It's a RCT randomized clinical trial published in December of 2020 New England Journal of Medicine, recommended for the patients who are very severe patients who are likely to progress to cytokine storm. Mitigate cytokine storm used in cytokine release syndromes, even before that, CAR T cell therapy, and also severe rheumatoid arthritis and temporal arthritis. IL-6, it is an IL-6 receptor. It's a cytokine blocker. It's IL-6 receptor blocker, and administered as a single dose, 400 milligrams, and we can repeat that in another 12 hours with another dose. Toxicities are liver enzyme elevation, and increased risk of TB and invasive fungal infections if you use it again and again and again. So it's a life-saving medication that is very expensive, even in this resource-rich settings. Anticoagulants that we talked about, active 4 trials, further reiterated the importance of, so when you discharge a patient home, you're supposed to give at least about 10 to 14 days of either simple anticoagulant should be okay, like aspirin, but we use apixaban here when patients are discharged with clear mortality benefits. Convalescent plasma, I don't think I have time to go through the convalescent plasma, has been used historically over and over again, especially against H5N1 influenza epidemic, and has been shown proven effective, but the data still not showing that I think it's not effective enough in this situation. I think the reason is because we're not getting donations from antibody-rich people, and you have to have a high titer of at least 32,000, 1 to 32,000 in order for that plasma to be effective. So jumping into monoclonal antibody, this is the bridging treatment I was talking about. So we are in a situation where we don't want all those patients to come into the hospital. The hospitals are inundated and swamped with these patients. So we actually order monoclonal antibody cocktail, either from Eli Lilly called bamlanimab or Regeneron home. We order it through a CVS pharmacy, where the infusion service of that pharmacy take it to their houses and give it to 1 hour, monitor them for another 1 hour, and then they come back. So that's how we prevent hospitalization. Going forward, this is going to be very, very important. There'll be 2 more companies who will be approved to give monoclonal antibody cocktails. So these cocktails are given in ERs or urgent care also to prevent hospitalization in high-risk patients. So specific categories, mild to moderate disease, not the severe disease, mild to moderate disease with high risk profile. Thank you so much for your time. Over to you, Dilan.
Thank you, Professor Jayasekara. So over to you, Professor Suranjit Sinivaratna. Suranjit, it's breaking up. We cannot hear you correctly.
Is it okay?
Yeah.
For the invitation, and hello, Prof. Aroj. It's lovely to have you sharing that former professor of medicine who taught us when we were in med school. Now, what I'll do in this 15 minutes is talk to you about I'll talk to you about COVID. A paper that sort of review of the more details about the COVID-19 landscape and the aspect with regards to this pandemic, as things have really changed every week, every day. Sometimes you have to keep updating yourself.
Professor, your PowerPoint can't be seen to us.
Hello?
Your PowerPoint cannot be seen, Suranjit. You may need to double click. There might be another share button that you have to click on the side.
Can you hear me?
Yes.
We can't see the slides.
I've given a copy of my.
Yeah, you can send me a copy if you like, then I can quickly put it on the screen.
What we can do is we can share the screen and after that you can say us to change the slides. All right, there we go.
Oh, yeah. Now it's fine. I think Suranjit, you are.
And can please come next. Can you go ahead with?
I'm sorry, I was having a hard time hearing. Would you like me to go next?
And with my yeah, and
Yeah, maybe Suranjit, you can send me the presentation, and then Iru can do his presentation now, and we'll switch. Okay.
Exactly.
And maybe your earphones might be having an impact as well, because it's always breaking up.
Oh.
So maybe without the earphones might work well. Maybe
okay.
You can go ahead just to save time.
Hi, everyone. I want to thank you so much for giving me this opportunity to present to my home country, where I was born. I didn't get much time to spend there, but I have been able to live between Canada and United States. I am now a general and addiction psychiatrist practicing in Bakersfield, California. And I have the honor to really talk about what's really important to me, and that's mental health. So what I would really like to talk about specifically, obviously, is how COVID-19 has affected all of us mentally. And I'll be using a lot of the data that's happened here in United States, but I'm pretty certain that it's applicable to everywhere, including Sri Lanka as well. And so there's two different things that I want to talk about. First one is about how COVID-19 has directly impacted mental health. I don't think this is really talked about in our society too much, but you may be more familiar about how indirectly COVID-19 has affected us. My Delanta Fernando has talked a little bit more about that as well. So I'll be touching on these topics. But more importantly, I will be talking about how I think we can all survive this deadly pandemic and the isolation that it brings all of us. So firstly, let's talk about how directly COVID-19 can affect the brain. So actually, there's a lot of people who have been affected by COVID-19. Unfortunately, a lot of them have had what is known as a cerebrovascular event, about 62% of them. And so the majority of those individuals have had a stroke because of their infection with COVID-19. A smaller percentage of those, about 12%, have had brain bleed. But the other 30% of individuals have had what is known as altered mental status, meaning it's more of a psychiatric presentation due to having COVID-19. 23% of these individuals had unspecified brain disease, but also 18% of these individuals have had an inflammation in the brain. However, the 60% of those individuals have had a psychiatric diagnosis that has happened, again, strictly because of COVID-19. A huge amount of these people, 40% of these individuals have had what is known as psychosis. Now, psychosis involves having more paranoia, feeling like people are out to get you, that you might be hearing voices, maybe even seeing things that are not actually there. So COVID-19 in itself could be causing this. And as they say here, 43% of those people had new onset, meaning that they've never had psychosis before, but this is the very first time they had it, again, strictly from COVID-19. Other people, about 25%, have had what's known as the neurocognitive, more like a dementia, so a lot more forgetfulness, fogginess, associated with COVID-19, and then 17% have what is known as an affective disorder. So that can involve depression, anxiety as well. For the individuals that have had the altered mental status or more of the psychiatric presentation, it's about split. 50% of those individuals were below the age of 60, whereas 50% were older. However, if you're going to be having one of these cerebrovascular events, that's usually the vast majority of those people are over the age of 60 years old. Now, I'm going to talk mostly about the indirect causes of COVID-19. And what has been very easily seen, not only from the data, but even from what I see on a daily basis with all my patients, is there is absolutely an increase in mental health issues, substance use, and suicidal thoughts. And this was as early as June 2020 in the United States. We see huge increases in anxiety. So anxiety is where you have these feelings that of uncertainty, really feeling heightened, having a hard time sleeping. Depression was 4 times more than normal. So depression is when you feel a lot more sad, you have issues with sleep, you may have less appetite, you don't have that same kind of motivation to do things that you enjoy, that you usually do in life. And 1 in 10 people said that they increased their substance use, meaning that they were using more substances such as alcohol or other drugs because of the isolation of COVID-19. One of the more scary ones is that we have increase in suicidal thoughts twice as much as the year before. And one thing that just came out and was also talked about briefly from Delonta Fernando was that the 5th largest school district in the United States, this happened in Nevada, United States, they plan to go back to in-person teaching due to a rise in student suicides. In fact, 18 children have died from suicide since the lockdown occurred, and more than 3,000, again, 3,000 people have been flagged from alerts from students because of potential suicide risks. So this is something that I see across the board. I treat not only a lot of teenage people, but also the parents who are now having more suicidal thoughts and depression, having to take care of their kids who are suffering, and also at work, trying to maintain everything. It is across the board very difficult, including for teachers, who I also treat a lot of. And a lot of teachers are struggling because they know they're not giving that same quality of teaching that they're used to giving. And they know that they're not giving that same kind of education to the children that is needed at this time. Some other really heartbreaking statistics is that domestic violence rose quite a bit. And the point that people, and mostly females, were coming to the emergency rooms because of domestic violence that was happening at home. And as you can imagine, it's much harder for people to get to shelters because of all the COVID restrictions as well. So they have very limited resources to get away from this abusive environment. And perhaps the most sad of all is that child sex abuse also increased, apparently by a high of 22% in monthly calls. And apparently this was the first for that agency. One thing that's really important to know about child sex abuse is that the vast majority, including in this situation, 80% of those who had child sex abuse were living with the perpetrator. So it's very common for it to happen with individuals that are known to the victim. So in looking in the grand scheme, how does this happen? The main thing is we have to realize that COVID-19 has brought a totally uncertain pandemic. People don't know when it's going to end. People don't know what kind of financial issues they're going to have. And it's a lot that are happening because of COVID-19. And more than anything, people are isolated. We are human beings that like to be connected with each other. And across the board, I have seen individuals really struggling without that lack of community that is so important for human beings to be alive and to really feel happiness. And so people who have psychiatric issues, people who are in high COVID areas, and most importantly, people who have experienced the loss of a family member or friend that has died from COVID. What a devastating thing to be happening, especially since people a lot of times can't even go even to the funerals of those individuals. So this exacerbates all the issues: depression, anxiety, addiction, and ultimately what it ends up being for many people, unfortunately, is the thought of suicide. And so young individuals, minorities, essential workers, unpaid caregivers for adults specifically are the highest risk of these kind of issues during COVID. Specifically, those individuals that are taking care of people with pre-existing medical conditions, the amount of stress that's being put on them during this time, I cannot describe it. Again, I've seen many patients of mine, and it's very hard to see them in that, because they have very little resource and very little ways to even have that kind of support that they had before to deal with such difficult situations in their life. So here is my solution to all of you on how we can combat not only suicide, but take care of our own mental health during this very, very difficult time in our lives. So the main thing that we need to realize that it is a universal approach. We're all human beings, so it doesn't matter what country we're in. We all have the same approach to make sure that we are going to be okay, and our friends and our family are going to be okay as well. So the real question that we have to ask ourselves: how do we decrease stress? How do we decrease anxiety and loneliness in our population? So on a broader scale, we can see that we can have more traditional and social media campaigns to really help our mental health and reduce stress. Again, I can't emphasize how important it is for us to stay connected with the people that we love. So make sure to pick up that phone and call people. Texting is okay, but calling and hearing that person's voice, or even better, doing what we're doing right now over a video call, so much better. Make sure you have that human connection, especially with those people that you haven't heard of from in a while. The thing with depression and anxiety is it causes people to isolate. And so if you are that person that reaches out, tells that person, I care about you, I love you, that could make all the difference in that individual's life. And if we're able to make sure that we deliver community support, and also if we have ways to screen for anxiety and depression, specifically in the medical community, especially if you're in primary care, you're first line in making sure that your individuals are not suffering mentally as well. Another thing that we can also be looking at is that community organizers, such as the clergy, first responders, geriatric caregivers, school employees, we are more attuned and making sure that we're identifying those at risk, making sure that they get enough of their evaluation and treatment as well. I'm not sure if this exists in Sri Lanka. I would be so happy if it does, but if we have suicide prevention hotlines, that is something that is so needed and utilized by those who are higher at risk for suicide. Again, as I said, if primary care doctors can really make sure that they take care and utilize mental health, that would be incredible during this period of time. And as Delenta Fernando talked about, if governments give more stimulus and more financial aid and support this, making sure that the individual and families don't have this financial burden on their backs, makes a huge difference. One of the most common reasons for anxiety and depression that I hear is economic burden. And a lot of people are being hurt by COVID-19 right now. And lastly, as long as we make sure that we really target those individuals who are highest at risk, COVID-19 survivors, frontline healthcare professionals are extremely at risk with all the extra burden that's coming their way, all the extra uncertainty. It is extremely hard, and there's a big suicide issue within doctors and medical professionals. So it's very important to be talking about that as well. Of course, elderly individuals are high risk as well. As I said, telemedicine is vital for us to be able to stay connected. That's how I do all my appointments now, is through telepsychiatry. I'm so grateful to be living in a time where we have this kind of technology. And in a sense, we're extremely lucky that we have this technology during this time so that we can continue to deliver healthcare in a good way. Lastly, one of my favorite things to tell people, doesn't matter if you're a patient of mine or just a friend, limit how much news that you're taking and how much social media that you're consuming. There's a lot of negativity out there, unfortunately, and a lot of people do get depressed in seeing a lot of the world events that happen. So I think it's important that we really focus on what's important, the people that we love, the family that we love, and really making sure that we understand the simple things in life. And that's about making sure that we're there to love and care for our families and friends. Lastly, I just wanted to talk about something that is, again, very near and dear to my heart, and that's reducing stigma in mental health. And so I think we haven't been really taught the best way to respond to individuals who are having mental health issues. A lot of times we try to convince them that it's not so bad. You think about the poor people in Africa. You look fine. You don't seem that bad to me. You just have to smile. These are not helpful. What is helpful is just simply being there for the individual, hearing what they have to say and the pain that they have, and just telling them that you're there for them and that you wish that you can help them in whatever way possible. And sometimes that might mean getting therapy, just being around more people, exercising, eating well. But there is no shame whatsoever in getting psychiatric help from your doctor as well. There is absolutely nothing wrong with an individual for being depressed, anxious, or suicidal. It is part of the human condition, in my opinion. And for anyone that is watching today, I really urge you, especially if you're struggling out there, or if you know someone else who's struggling, please go and get help. We need to try our best to really reduce the stigma so we can all live a much better, healthy lives for each other, especially during this extremely hard time during COVID-19. Thank you so much. I really appreciate this opportunity.
Thank you. Thank you, Dr. Fernando. I'll let Dr. Jayasinghe take over again.
Thank you very much. So shall we have Suranjit?
Yes.
Suranjit, are you
Yes.
on? Yes.
Can you hear me? Yeah. So I'll knock off my video and I'll just speak to with only the audio, right? And okay, can you put my slides, please? Thank you very much. Sorry about that mix up.
Okay. So the chair, Dr. Jayasinghe, can you ask them to allow me to share the screen?
No, I think the organizers are doing that. Okay, excellent.
Oh, okay.
Excellent. Thank you, Dadila. I sent a copy before that. Right. So next slide, please. Right. So if we put it into context, I think that's a very important thing about cases and deaths of COVID-19 and SARS-CoV-2 infections. You could see that, I think Dilantha touched that. The world, there are 100 million. We just reached that amount, and with 2.2 million deaths. UK and the US levels are shown in the slide, and you can see that in Sri Lanka, in one way we are blessed that the numbers of cases and deaths have been low compared to many, many countries with similar population. So that is a big positive, that whatever has been done in Sri Lanka, that has kept things under control. And we have to persist with that going on. And the important thing, my talk is about vaccines, but vaccines alone is not sufficient. It has to be a combination of vaccines plus other things, which will get this under control. You cannot only think that you get the vaccines and that's it. We don't have to take any social precautions such as social distancing or mask. Next slide, please. So I would quickly talk to you about these 4 areas in this next sort of 12 minutes. Next slide, please. And we all know that the immune system, you have the innate immune system and the adaptive. So why I put this slide is the immune system is does not consist only of antibodies. That's a very important thing. Everybody talks about antibodies. Vaccines producing antibodies. Let's test for antibodies. If it's okay, we give a sort of a green certificate, etc. But there are white cells also, lymphocytes, that are important. And if it does not, so you have to make those sufficient amounts of antibodies and white cells for the immune system to work. And there is something called memory, immune memory. That is when you get an infection the second time, your immune system, if it's already primed, it can protect you. And that's exactly what we're trying to do with vaccines. Next slide, please. So you have different types of cells. I said you have cells called B cells, which produce antibodies through plasma cells, and you have T cells, which are very important for fighting and killing viruses. Next slide, please. So these cells get together, T cells, B cells, and antigen-presenting cells produce antibodies, produce cytokines, chemicals that are important for immune cells to talk to each other to get rid of the virus. Next slide. And we know that this has been described by Deepti. You have the spike protein on the surface, but you have several other proteins. That's a very important thing. The vaccines so far have been targeted against spike proteins. It's a surface protein, but other components would also come into focus in later vaccines that have been developed. So you have envelope, you have membrane, you have nuclear protein, and you have a mRNA. You have the RNA, because it's RNA virus that is there. Next slide, please. And these are the different components of the spike protein. You have the receptor binding domain, which is extremely important when it comes to these variants, the different changes that are occurring and the mutation that occur in the virus, which is known to occur, which I will talk to you in a few seconds. So you have different components of the spike protein, which antibodies will be formed with vaccination or normal infection against different segments of the spike protein. It's not only one segment. Next slide, please. Next slide. So everyone has been talking about new variants recently with the UK, the South African, Brazilian. They're now coming into some new variant has been found in California. So the important thing to remember is that viruses do mutate. I mean, the mRNA viruses would mutate more. The RNA viruses would mutate more than DNA viruses. And they do change, but most of those changes do not have any important effects. So it doesn't have any clinical effect. But sometimes if the number of changes are sufficiently high, or if it affects an important region, that's the important aspect to consider, because it could potentially have effects with regards to vaccine responses, which we're trying to vaccinate, or else other treatment options. Next slide, please. So the 5 things we look in with potential effects of mutation: can it affect spread? Can it affect disease severity, diagnostic tests, therapeutic agents, and the vaccine? So those are the 5 things we would consider: spread, disease severity, diagnostic tests, therapeutic agents, and the vaccine. Next slide, please. So we know that there was a massive uptick in London and in Kent, southeast of England, in November. And when they looked at it, they found that a lot of those patients were having a new variant called the UK variant. Next slide, please. And these are the different mutations that are found in the UK variant, up to 23. And it is some of them are in the spike protein, while the others are in other types of other proteins in the virus. So that is an important thing to remember. Some of them are in the spike protein. Next slide, please. Then came the South African variant, very, very soon after the UK variant was reported. And there were 2 of one of the mutations was similar, but there was another few mutations that were different in the South African variant as opposed to the UK variant. And then we have the Brazilian variant that has come in after that were found in Brazil and in 2 people who went to Japan. Next slide, please. So as I said, increased number of cases from around November, but when they really traced it, they found that the first cases were occurring around September. And by that time, it had gone around the world. There are more than 50 countries that have this new UK variant at the moment. So it has gone around the world, and it is expected because people are traveling, etc. And it is accounting for a major proportion of the cases in the UK at the moment. Next slide, please. So what does it do? As I said, the 5 things that we look for: spread, severity, diagnostic test, therapeutic and agents, and vaccine. Next slide, please. As at today, now this slide was different when I presented about 2 weeks ago. What it is known for the UK variant is a significant and substantial increase in transmission. That is known. That has been known for a long period of time. Epidemiologically, they said 50 to 70%. Recently, they said it may cause more severe disease and hospitalization. That was a new development a few days ago. no evidence at the moment that it affects the COVID-19 treatment or vaccine response. Moderna just came out with their data yesterday saying that the Moderna vaccine is also not affected, is effective against the UK variant and the South African variant. Next slide, please. So then it comes to the South African variant. You know that there is a change. It's more than 20 countries that have the South African variant. There is a bit of a critical variant there, that is the E484K, which is an important variant because when in addition to increasing transmissibility, it can alter the structure so that the vaccines may not be as effective. We still do not know that definitely, but studies have been done. And the Brazilian variant, those are the two dangerous variants that we are looking at carefully when it comes to vaccine responses. And that is why Moderna has come in with a booster dose of a vaccine, of a variant sort of a formulation. So they give two vaccines, the two vaccines that they give, but they may have to give another booster dose, and that is in development. Next slide, please. So next slide, please. Next we go into showing that there is a whole lot of immune responses in COVID, as I've shown in the slide. Neutrophil, lymphocyte, platelet can be changed, etc. And there is a whole slew of these responses, including cytokines and increased cytokine, which Deepti beautifully described as being as a target of neutralization in treatment. Next slide, please. Antibody responses occur. You know, IgM occurs before, IgG occurs, and this is a sort of schematic that happens. The top slide shows the antibody response, and the bottom slide shows the cellular responses. And the important thing to remember is that we want memory response. That's what we are looking for, because if we, with vaccine or with infection, if we have good memory responses that last for a long time, then we know that we would have, when we get the next infection, it would be, the body will be able to handle that rather than finding it difficult to manage that. Next slide, please. Problem is antibody responses seem to be waning. So so far the studies show that in about 4 to 6 months, some of the antibody response post natural infection seem to be waning. We still do not know what it is with regards to the vaccine because we have not followed them up sufficiently long, a sufficiently large number of patients for a long period of time to tell you that answer. But antibody responses could wane off, and that could be expected. And next slide, the important thing to remember is, next slide. Yeah, that's it. The next thing, the important thing to remember, in addition to the antibodies, you have different types of cells, T cells, CD4 cells, CD8 cells against different parts of the virus, which are important in keeping the virus under control. So sometimes, even though the antibody response are reduced, still if you have cell responses, that is important. And that is exactly the reason we tell immune deficient patients to get the vaccine, where they may not make an antibody response, but they could make a cellular response. So very important concept to be kept in mind. Next slide, please. Next slide. So finally, I'll come on to, we know the vaccine landscape, everyone is talking about it. It takes generally about 10 to 15 years to produce a vaccine. With SARS-CoV-2, it took about 9 months. It was not because they took shortcuts, it was because the different vaccine development phases were telescoped. They were done in parallel, not serially. So because of that, when phase 1 was occurring, you found that people working on phase 3. So it was done parallelly, and that is why we were able to get a vaccine. In June, there was no hope. There was little hope that a vaccine may come through. So it was around April, because HIV, dengue, TB, etc., we don't have good vaccines, and we just did not know whether this will come through when it comes to SARS-CoV. And getting 95% was wonderful when it came, when the results were first produced. Next slide, please. So you can see this is a schematic of the different vaccines that are available. There are 5 types. Basically, there is you can take the virus and it can disable it. That's a live attenuated. We don't have much development in that field so far in SARS-CoV-2. You have the kill vaccine, where you take and disable the virus and kill it. So that is second one. These are the methods we use for most of the vaccines that we developed previously. Then you have 3 new methods. One is the subunit vaccine, which you have used. That is the Novavax, which is being trialed at the moment. And then the 2 that we are using at the moment are the 2 novel methods, that is the mRNA vaccine and the viral vector vaccine. So the mRNA vaccine are the Pfizer and the Moderna vaccine, which had been approved in the UK and several countries in the US, and it has been used in many millions of people. The mRNA goes into the cell and it instructs the cell to produce the protein so that the immune system recognizes the protein and makes an immune response. Next is the viral vector vaccine, which is the AstraZeneca Oxford vaccine, and there are several other people also working on this, like Johnson & Johnson, the Gamaleya vaccine, and one of the Chinese vaccines. There are 3 Chinese vaccines. Of them, one of those is a viral vector vaccine. And they use a chimpanzee adenovirus. That's an important thing. It's not a human adenovirus. It's a chimpanzee adenovirus. And they put a part of the SARS-CoV gene into that, so that the protein is, again, it is injected, the protein is produced in the body, and it stimulates the immune system to make the immune system to make the antibodies and the T cells. So there are 5 types, 5 types, namely mRNA, viral vector vaccines, subunit vaccines, live attenuated and kill vaccines. Of these, the mRNA vaccines and the one of the viral vector vaccines have been approved for use, and it's been used in several countries around the world. In the UK, 7 million people have already been vaccinated. I know in Sri Lanka, the AstraZeneca vaccine has just come in. Next slide, please. So this is some comparison of the advantage and disadvantage of different vaccine constructs. I won't go into detail because of time limits, but each one has positive and negative aspect, and that must be remembered. You cannot get 100% protection with a vaccine. It was wonderful to have 95%. With the mRNA vaccines, the Oxford vaccine was 62% in the standard formulation. So, next slide, please. And this is a schematic just to show you what happens with the mRNA vaccine. It goes into the cell. It does not integrate into the DNA. Very important. People get confused about that, thinking that it goes and binds to the host DNA. It does not do that. It will go into the cell. It will produce the protein, and then it will just get destroyed. While the DNA vaccine, we have to be careful. It has still not it has not been approved. That may have a potential of integrating. Next slide. And here you can see that, again, the viral vector vaccine, different types of viral vector vaccine, the Oxford vaccine, it comes into the cell and produces the protein, which is recognized by the immune system. Next slide. So in summary, if I put this summary slide, these are the sort of vaccines that have been approved so far, the top 3 in some countries. The Pfizer and Moderna was the first vaccine. It was first approved in the UK on the 8th of December, and quite a few people have got the vaccine. AstraZeneca was approved on the 30th of December, and then you have the Russian and the Chinese vaccines also into the mix. 2 vaccines are to be given in all these constructs so far. It's only the Johnson & Johnson that it's a single vaccine, and that's why we're looking at it very carefully. And the difference in temperature, the important thing of -70 and -20 for the mRNA vaccines, which could be difficult in different parts of the world, as opposed to the AstraZeneca, which is 4 to 8 degrees, but it has a lower efficacy rate as opposed to the DNA vaccines. And it's importantly, the AstraZeneca vaccine is cheaper than the mRNA vaccines because it is only $3. Next slide, please. So quickly going through, the UK has changed, just a few more slides. UK has changed their dosing schedule. The Pfizer was 3 weekly and the Moderna was 4 weekly, AstraZeneca 4 weekly from December end of December, they changed it and they delayed the second dose up to 12 weeks. It's a public health reason, because the idea is to vaccinate more people with the first dose rather than trying to give a few both doses. That is because the massive vaccine shortage. You know the big problems at the moment between the UK and the European countries, because there are not enough vaccines going around. There's a lot of vaccine hoarding. There's a vaccine shortage, and the idea was to give one vaccine. The US does not believe that, and they are not going down that. But Germany and Denmark are also considering this option. These are the protection that has been shown with a single dose of vaccine, and people are following that very, very carefully. So one vaccine rather than two one dose, and then delaying the second dose. Again, there has been EMA are suggesting the European Medicine Agency is suggesting give it to 6 weeks. It should not go beyond 6 weeks. So that is a developing field which people have to look into detail. Next slide, please. Right. So important thing is after you get the vaccine, what about testing? Antibody testing. If you do antibody testing, you must use antibody if for testing, it should or not only look at the spike protein, it should look at other proteins, because otherwise you're going to get false results. So that's an important technical message to be known by labs, because on the clinicians, because otherwise it can get confused if you use the wrong kit. Next slide, please. With regards to allergies, you know that this has been something that we discussed with the Pfizer vaccine and the Moderna vaccine. The rate is about 11 per million as opposed to 1 per million with other vaccines. So it's a bit higher than before. The previous NMRA, that is the UK advice, was anyone with severe anaphylaxis to food, drugs or vaccines not be given this vaccine. It has been toned down a little bit now, and because there are not enough vaccines to go around, and that reflection has come down as opposed to the prior advice that was given. And the important thing to remember is the patient should be kept for 15 minutes or 30 minutes, because the allergic responses tend to occur at the early stage. And there has been some nice data produced by different groups around the world. Next slide, please. So what I've done in this quick talk here about vaccines was telling you that vaccines alone are not the ultimate thing. Without general social distancing, wearing masks, etc., you have to, because the vaccines take time. The Deepti spoke about the monoclonal antibodies. The problem is expensive, but it's important in certain circumstances where you want to prevent people going into a hospital. You have to remember that a lot of research has been done to see if the vaccines are effective against all the variants. There will be variants coming as herd immunity comes into place. There will be more variants that are developing, and these will have to be looked at, and the vaccine formulation may have to change. We do not know how many vaccines would be needed. At the moment, it's 2. Do we have to give a booster in 6 months, in 1 year, in 1.5 years? We still don't know that. That's why we have to keep up with the information. It produces both antibody responses and cellular responses. That is why even immunodeficient patients, they cannot develop SARS-CoV-2 from a vaccine. That is, the vaccine can't give them the disease. So therefore, we would even vaccinate immune deficient patients. Thanks a lot. Next slide.
Thank you very much, Suranjit. We don't have time for question and answer sessions because we are running late. So once again, on behalf of the NSF and all the participants, let me thank Professor Dilantha Fernando, Professor Suranjit Senaviratne, Professor Deepti Jayasekara, and Dr. Gerard Fernando. Thank you very, very much. See you. Bye.
Thank you. Thank you.
So we close this session, and may I now request the NSF to take over. Thank you.
Next in the agenda, ladies and gentlemen, is the technical session 3. Similar to yesterday, this will be conducted as 3 parallel sessions. Theme 4 on environment and Theme 6 on research, invention and innovation are already underway online. Theme 5 on society will continue here. This theme will be co-chaired by Emeritus Professor Siri Hettige, Emeritus Professor of Sociology at the University of Colombo, and Dr. Nishara Fernando, Head of Department of Sociology, University of Colombo. I now hand over to the co-chairs to conduct this session.
Okay, let me welcome all those who are present here in this room. This session is on society-related themes. We have 7 presentations lined up. Dr. Nishara Fernando, who is my co-chair, sorry about that. Dr. Nishara Fernando, who is my co-chair, will conduct the session because I also have a presentation towards the end of this particular session. Therefore, Nishara Fernando will do the housekeeping and also, of course, manage the session in terms of the lineup of presentations and so on. I'm not going to say very much except to make the point that we have 7 papers that deal with various social aspects of the pandemic, and we will probably have some important issues arising out of these presentations, and I don't think that we will have very much time to discuss. But nevertheless, I hope that these presentations will cover some of the important areas that we have to pay attention to. But I also want to say that under social impact and also, of course, economic impact, there are so many structural and other issues that need attention, but these 7 presentations cover only part of this landscape. But nevertheless, I'm sure that we will have many important points raised during these presentations. I think towards the end, we would be able to really pick up the most important issues and of course conclusions that these papers bring out on the themes that they deal with. So let me now ask my co-chair, Dr. Nishara Fernando, to conduct this session.
Right. Thank you, sir. Let me invite the presenters. The first presentation is on innovations in teaching and learning in distance mode during COVID-19 in Sri Lanka and Bangladesh. I think Gamage, SN and the team will do the presentation. Thank you.
Iborn. My topic today is innovations in teaching and learning in distance mode during COVID-19 in Sri Lanka and Bangladesh. My name is Sujata Gamage. I'm from Learn Asia as well as from Education Forum Sri Lanka. My co-author Moin Ruzaber is from United Nations University and University of Dhaka in Bangladesh. The context, of course, is COVID-19. Schools closed on March 13, 2020 in Sri Lanka due to COVID, and officials and teachers had to adapt overnight to provide distance education to the 4 million plus school children. Online education or internet-based education was the only option seen at that time. And similarly in Bangladesh, if you take the infrastructure, 48% of households with school-age children own a smartphone or a computer, but only 34% access the internet in 2018. This Learn Asia were published in 2020. In Bangladesh, the respective percentages are only 21% and 11%. So you can see that in these countries, the internet access by households with children is less than 50%, way less than 50%. So how did they do in 2020? That's the objective of our study. We want to see what is the latest in 2020, how many children were contacted online, what are the good practices and what can we learn from those and go on. And the methodology is a survey method technology. I'm not going to give the details, they're on the slides, you can read them later. We use 2 surveys, parent survey for qualitative results from 5 districts in Sri Lanka, but teacher surveys from teachers in all 25 districts. It's a purposive sample. We pick teachers who would have made a good faith effort to reach out to their students. The idea was then that what the numbers we get are optimal, the maximum, not the minimum. So that was idea. In Bangladesh, we looked at teacher survey, but we used a convenient sample of teachers in better endowed private schools in Bangladesh. So the idea here was to find the optimum in optimum conditions. But we want to benchmark ICT use in education, in distance education. We could have picked elite schools, well-endowed schools in Sri Lanka, but we did not. We thought it's good to get a flavor for Bangladesh as well. Findings are, it's only the last few rows are the results. First few rows are about country statistics. All we want to know is that Bangladesh is about 8 to 17 times as big as Sri Lanka in terms of population, number of schools, students, etc. We talked about infrastructure already. The sample is I've given in red. In Sri Lanka, we surveyed 86 teachers in 86 schools, and they talked about 2,500 to 82 students in their classes, in their respective classes. And in Bangladesh, we surveyed 7 schools, 30 teachers from 7 schools. Results, I will just give here only the statistics. We found that in Sri Lanka, teachers reached out to 45% of the students only using WhatsApp, Viber, Teams, Zoom kind of technologies. And of course, Zoom technology was used only by 10% of those, or less than 5%. The rest used WhatsApp technology on smartphone. And government had offered TV broadcast soon after lockdown. To their credit, they did that, but they were improving them all the time. But when we asked, only 28% of the students had watched that, according to their teachers. So conclusions: one, this glass is half full in Sri Lanka, and we look at it in terms of several dimensions. First, content, devices, and low-tech connectivity. Content. All children in grades 6 to 11 are provided textbooks, and lessons on video are now available for all subjects from grades 6 to 11 with a choice of state and non-state providers. The government TV lessons are all uploaded on YouTube as well. Devices, we know that the devices only 20% or so would own a computer or laptop, but 91% own TVs. We don't know how many of these are digital TVs, but we know digital TVs where you can use a USB device can be purchased for about rupees 30,000. And government has indeed allocated money in the 2021 budget, rupees 3 billion, for purchasing TVs for schools. And we think it's 100,000 TVs. And also if you target the marginalized schools and the families, you can, of course, provide each family, help them update their TV, and each school have a number of TVs they need. So the glass is full that way. And also low-tech connectivity. We realize or we forget, about these technologies. A mobile is owned by 96% of households with school-age children. And you can have technologies without smartphones where you can do a conference call. Say a teacher can join with about 40 students. This is demonstrated by Dialog Exiata, a telecom provider, to what they call the 1377 service. So you don't have to have smartphones to connect with students in conference, and you can always call up a student. And here we find that human resources is the biggest gift we have in Sri Lanka. We have teachers for schools at the average of a teacher for 16.4 students. And if you take the least endowed schools where the school size is small because nobody wants to come to those schools, if you take those schools have a STR of 6.3, that is a teacher for every 6.3 students. And these are the schools that are reached least by internet technologies. So we are asking, should not these schools deploy their teachers to contact students by phone or bring children to school in these schools serving very small communities which are isolated anyway? The second one is changes to curriculum and examination are on the agenda of the government. Presidential Task Force on Education also proposed some even before then. Reforms are on the way, but they're not for implementation till 2013. Blended learning solutions possible. Using these resources, Sri Lankan teachers have suggested, and we learned from Bangladesh teachers in better endowed schools, that flipped classroom is actually possible with this, and some have tried in Bangladesh, and in Sri Lanka they have envisioned. What is this? Give an example. Link each lesson to a digital content. The teacher's going to teach something today. Okay, there's a TV lesson, a video tied to that. So the children watch the video beforehand or even in school while the teacher's helping some weaker students. And then teacher follow up with the students. If they're in school face-to-face in a discussion class, what did we learn? What did you not learn? Or help children having difficulties. And if the school is closed, teacher can have a conversation on the phone, mobile phone with those mobile phones, conference call, or those have with smartphones, WhatsApp. So it is possible to blended learning solutions with these existing technologies. So what we're saying, blended learning is the way forward for inclusive access. Online is not viable when 50% is offline. Broadcast TV is not viable. 91% have TVs, but signals are poor, and broadcast TV timetables don't really serve, students and teachers who have their own lesson plans. So only problems we see is in devices, and we discuss how devices can be given. And the other one is teacher guides and exams. Our teachers, the government really should do the policy of releasing the teachers, giving them the freedom to innovate and reduce the exams. Exams are real tied teachers' hands. Too many exams. So what are the implications for India, Sri Lanka, countries in Asia? As you can see from the graphic, they all have under the colored part of the graphic, so they are all under 50% internet access. So they can indeed think about ways of using this technology for blended learning. Thank you.
Thank you. Let me invite the next presenter, Bandaranayake R from, I think, Learn Asia, Sri Lanka. And they are going to present on risk communication and building trust, lessons from COVID-19. Over to you.
Thank you all for listening. Effective pandemic control requires the general public to change their behaviors and follow preventative measures. It's not practical to keep tabs on each and every citizen to make sure they're following health guidelines in their everyday life. Therefore, voluntary uptake of such behaviors would be needed. For voluntary uptake, people need to trust the government's recommendations so that they follow them of their own accord. And one way of building this trust is via good risk communication with the public. These are some findings from the literature. Of note, it's that people react to risk as they perceive it not so much as the risk actually is. And they are more likely to act if they believe they are vulnerable to the risk, can take actions that will lower their vulnerability, and that the advantages of these actions exceed possible disadvantages. One of the key guidelines on risk communication are these guidelines released by the World Health Organization in 2017, communicating risk in public health emergencies. These guidelines are based on a systematic review directed by an expert group of both published literature and grey literature by multiple organizations. The languages include English and the other UN languages, and the study incorporates both quantitative and qualitative work. We return to these guidelines later on. The objectives of our study are to broadly study some aspects of the Sri Lanka government's risk communications activities during COVID-19. We first outline some of the activities that have been taken place, then conduct an in-depth analysis of some of the televised disseminations of information through the lens of the aforementioned WHO guidelines. To be noted, we focus on the first wave of COVID-19 in Sri Lanka, which we may consider roughly January to May 2020, and we do not touch on the events since October 2020, which might be called the second wave. These are some activities that were undertaken apart from television. So websites such as the NOC PCO's website, the Health Promotion Bureau Situation Update Dashboard, social media use, for example, the use of Viber channels by the Health Promotion Bureau and the Department of Government Information, and the Department of Government Information's regular press releases, including situation updates on COVID-19. So let's move now to the specific area focusing on television. We chose to focus on television because it has extensive reach in Sri Lanka and it's consumed both offline and online. We chose the time period of 1st February to 31st March 2020 because this was the period where COVID-19 patients increased significantly within Sri Lanka, and it also coincided with the first declaration of curfew by the government. We chose the TV channels TV Derana and ITN, which both function in Sinhala, because TV Derana has the largest audience share among Sri Lanka's privately owned channels, and ITN has the largest audience share among the state-owned channels. We used the TV Derana news telecast at 6:55 p.m. and ITN news at 6:30 p.m. and monitored them daily on weekdays because these are the primetime news evening segments of the two channels. These are the categories of government actors that we monitored: politicians in the government, health officials, police personnel, military officials, and others who did not fit into the above four categories. Then for our analysis, we excerpted the following guidelines from the aforementioned WHO guidelines. It's not possible for us to use all the WHO guidelines. So we excerpted these guidelines from the trust category and the category on communicating uncertainty. And based on those, we derived 5 categories for analysis. So the first category captured self-efficacy, and the objective of this news was to encourage or instruct members of the public on what they can do in their individual capacities to prevent disease spread, such as wearing masks, encouraging people to social distance, the importance of respecting health guidelines. Then in category 2, the kinds of news we looked for were news that informed the public of facilities and services that were available, unavailable, or limited during the pandemic. So how to access medicine, how to access a curfew permit if you need it, and the facilities available for treating COVID-19 patients. In category 3, we looked for information that the government communicated that they knew about the nature of the virus and its spread. For example, the characteristics of the virus and how it was spread, the known characteristics, the symptoms displayed by patients, and the number of people within the country who have contracted COVID-19. In category 4, we looked at what information the government communicated that was unknown with certainty about the nature of the virus and the spread. So for example, if there were uncertainties about the number of people who might have COVID-19, or if the government was unsure about anything related to the nature or spread of the virus. Then in category 5, we tried to capture whether this information was conveyed in a manner that was easy to understand. And we analyzed the information we picked in categories 1 and 3 with this in mind as well. 2 limitations: we did not consider how editing decisions made by the TV stations might have altered the message. And furthermore, sometimes a message could fit 2 categories or more than 1 category. And if that was the case, we tried to look for the predominant category or the main purpose of the message. In terms of the findings, on many occasions, both channels featured the same message delivered by the specific actor on a certain occasion. So to avoid considering duplicates, we analyzed the message entries separately. We had 163 from TV Dharana and 88 from ITN. So as we see here, out of the categories of actors that were featured, it's mostly been health officials. After that, politicians, the military, police, and other actors. And in terms of the message types, we see that most of the messages are about self-efficacy, followed by links to services and information that is known, and very little communication on information that is unknown. In category 5, we observed in general that the messages did not contain a lot of technical jargon and were therefore considered easier to understand. In terms of what this means, we have some results from a survey conducted in late March 2020 by Vanguard Survey Private Limited and Verity Research, which found that 95.7% of the respondents were very satisfied or somewhat satisfied regarding how the government is trying to control COVID-19 in Sri Lanka. This gives us some evidence that the Sri Lankan public had high trust in the government's ability to control COVID in this period. Of course, we cannot draw causal links between the communications activities and this trust explicitly. Like, that's not empirically possible in the study. But this does give us some evidence that it was a period of high trust in the Sri Lankan government, of the Sri Lankan public in the government's ability to control COVID during that period. So as we have seen, health officials were the most featured category of officials. And there's some evidence in the literature to show that health authorities are rated as trustworthy authorities regarding matters such as infectious disease. And then in terms of message types, there was a high emphasis on self-efficacy, and that's in keeping with observations in the literature that risk communication should make people feel empowered to act. However, based on the entries we studied, very little emphasis seems to have been placed on communicating unknowns. The one entry we found for this category was on the 23rd of March 2020, when Lieutenant General Shavendra Silva noted that there may be some COVID-19 cases that were not known to the government, and therefore the curfew was necessary to prevent the virus being spread by possible unknown cases. So in general, the communication of uncertainty is considered important because during an outbreak of a novel pathogen, there are likely to be many unknowns since knowledge of the pathogen's characteristics and how it spreads are in the process of being discovered. And as a result, the knowledge is likely to change and evolve over time. It has also been noted that openly acknowledging uncertainty can increase public trust, and acknowledging uncertainty is also noted to be better than communicating certainty and then being found to be mistaken, which can risk damaging trust. So an example of the strategy has been used by the government of Singapore, Singapore has reported just 29 COVID-19 deaths at the time of writing. And they made communicating uncertainty a key part of the COVID-19 risk communications. So Singaporean officials continually stressed that there were many uncertainties, in particular the means and the extent of virus transmission. And this messaging was kept up even in early March, when it appeared that the new infection numbers were under control. And this philosophy has been termed defensive pessimism. And the aim of this is to stress the severity of the risk, its probable persistence, and the role of the government in getting ready for potentially bad outcomes in an uncertain situation. Therefore, acknowledging uncertainty can not only help to build trust, but can also alert the public to the need to be continuously vigilant, since knowledge about the disease is emerging. It should be noted, of course, that these observations are from the sample that we studied and the mode of communication we chose to study, and we do not rule out that unknowns may have been communicated elsewhere or through another channel. In conclusion, we note that, at least for the time being, television is likely to be one of the most effective risk communication channels in Sri Lanka. And we also propose that in the future, communication strategies focus on finding ways to communicate uncertainties around emerging pathogens while retaining the strong focus on self-efficacy and the resources that people can access. It is known that one of the major challenges of COVID control has been preventing cases from rising again after lifting lockdowns. And if uncertainty is emphasized, this can encourage the public to continue to exercise precautions and may help contain spread. Thank you.
Thank you. Let me invite the next presenter. Nadishani KWN, and I think the team is going to present on impact of COVID-19 on socioeconomic status and food security of tea smallholders in Sri Lanka.
Good day to you. I'm Nimanka Nadishani, Experimental Officer from Tea Research Institute of Sri Lanka. I'm going to talk about the impact of COVID-19 on socio-economic status and food security of tea smallholders in Sri Lanka. First, we talk about tea industry in Sri Lanka. It contributes nearly 12% to total export earnings, and it's important for socio-political environment of the country as 2.5 million people depend on this sector. If we consider the challenges, tea industry facing a drop in tea production and low prices, increasing cost of production, and unstable socio-political environments of importing countries. And now we are facing COVID-19 pandemic situation also, and it affected whole world and the industries at different severity levels. If we talk about COVID and tea supply chain, in Sri Lanka, tea production is mainly dependent on two sectors, that is plantation sector and tea smallholding sector, and then comes plantation or private factories and brokers, local buyers, overseas and overseas consumers. Because of COVID-19, the production may affect because of shortage of labor supply, temporary disturbance of productions, and transport restrictions. And for trade, global logistics, depreciation of exchange rates, and for the demand sector, the price of tea, purchasing power of buyer, and willingness to pay may affect. The impact of social concerns to both parties, I mean production sector and the demand, will be affected the whole supply chain. Therefore, we are conducting a whole study on impact of COVID-19 on tea supply chain, but this particular study aims to assess the socio-economic impact of COVID-19 on tea smallholders in Sri Lanka. And sampling procedures, we took more than 300 tea smallholders as our sample, and it representing all tea growing areas of the Sri Lanka, and it is proportionate to the number of smallholders in those sectors, those areas also. This is the conceptual framework. We conduct an island-wide survey by using a pre-tested questionnaire to study on these main 5 areas, that is production, income, health, education, and food security. To assess production, income, health, and education impacts, we used descriptive statistics, but for food security analysis, we used CSI, that means Coping Strategies Index technique was used. Results and discussion. The Presidential Task Force on Corona Disaster Relief, they took some actions to minimize the negative impact of COVID-19 on smallholder livelihoods by handing over green leaf payment at the tea smallholders' doorsteps, and curfew relief for transporting leaf as well as labor, and curfew relief for traveling to fields that beyond boundaries, and special allowance was given for smallholder families, that is 5,000 rupees. If we talk about impact on production, actually Sri Lanka faced a drop in tea production because of a severe drought condition, and nationally it was nearly 28% from March to May, and the highest crop loss was recorded in low country, but as our observations, we didn't see any significant impact of COVID-19 on tea production in tea smallholder sector. The impact on economic status of smallholders, the majority sample holders, more than 65%, reported crop loss due to drought, and this income loss aggravates the negative impact of COVID-19 on their livelihood. And tea is not the primary income source, and tea is a secondary income source for tea holders, and they have faced some family members job loss of family members, nearly 70%. Because of these reasons, we observed there was severe income loss for smallholder family, nearly 75%. Impact on food security. As I mentioned earlier, we used CSI technique to study food security, and it consists of 4 steps. The first one is identify the locally relevant coping strategies in the study area by talking to focus group people like that and listing. And secondly, we have to find the frequency, that means number of days adapted. Third, severity categorizing and weighting the strategies. And fourth one is scoring, that means combining the frequency and the severity of the strategy. And this is the calculation we used to identify the coping strategies scores. This is the list we built up from focus group discussions. And here I want to say that rather than mild behaviors, they have shown severe strategies also to overcome this food shortage. That means limiting the portion size and fed only working members, and reduce number of meals, and restricted consumption by adults to feed small children, and skipped entire days without food. And this is the percentage adapted by the smallholders of those strategies. And mainly the smallholder sector showed that relied on food found in the garden, and the estate sector, they purchased food items on credit, but they have gone for severe strategies also. This is the CSI score we obtained from the calculation, and we found that upcountry region smallholders faced more insecurity than other regions in the country. And of course, estate sector is the highest influenced area. CSI score vary between 0 to 52 in sample smallholders, but in estate sector it was 67. And these results show there's an existence of food insecurity among smallholders as well as estate sector also. Most of respondents showed their dietary change in behavior by switching less preferred and less expensive food. And when the pandemic period extended, the percentage adoption of all coping strategies were increased. This is an indicator of more food insecurity in latter stage than initial stage of the pandemic. And this is the most of them showed mild strategies, and later on they have moved to moderate and severe stages also. The impact of children's education, the majority sample stated that online and distance education methods were not effective at this time because of limited access to smartphones, laptops, etc., and as well as limited coverage of network providers. Impact on health. Mostly we observed that there was a suboptimal care to people suffer from chronic diseases. That means because of their whole system focused on prevention and treatment of COVID-19, there was a disruption to medical clinics, and not there was no access to medical centers, and people are reluctant to go to healthcare centers also. And we observed that more than 57% bought medicine by using previously used prescriptions, and because of that most of patients had not had their routine medical checkups at that period. Therefore, we can conclude like this: the COVID-19 pandemic marginally affected on tea cultivation, and effect of COVID-19 was considerable in income, food security, health, and children's education of sample holders, and encouraging smallholders for home gardening, online banking, online ordering of inputs, and would be useful to minimize the negative consequences of shock like COVID-19. And the government should take effective measures should be taken to avoid food insecurity conditions due to these kind of shocks in occurrences. And I would like to acknowledge these people and thank you very much.
Thank you. Let me invite Patberia Eche from Department of Statistics, Faculty of Applied Sciences, and their team is going to present on impact of COVID-19 pandemic on the learning process of undergraduates, current and future implications. Over to you, Patberia.
Hello everyone, I welcome you all to this presentation, which is titled as The Impact of COVID-19 Pandemic on the Learning Process of Undergraduates, Current and Future Implications. I'm Dr. Hasanti Padberia from the Department of Statistics of the University of Sri Java. Within our study, we are focusing on the higher education sector and the impact on that due to COVID-19 pandemic. As we all know, there are sudden changes happened in the teaching learning mechanism in the higher education sector. So I'm exploring the impact of that on the learning process of undergraduates. And I hope I can provide some, these findings would be useful in making positive changes and improvements in the current teaching learning platform, and the authorities can make successful decisions with the use of these findings from this study. So here are my objectives. I'm trying to explore the effect of the sudden shifting of face-to-face lectures to online platform, effect on the learning process of undergraduates, and how effectively these undergraduates have used their study from home time, and about the attitudes of undergraduates for these changes. And finally, I tried to, I wanted to identify future implications, focusing to improve the current teaching learning platform. And here is a brief methodology. First, I tried to give the background regarding the study, and then the data gathering phase, which comprised of defining the sample, designing online questionnaire, and distributing it among science faculties of all the state universities in Sri Lanka. And then the analysis, and finally to identify implications. I quickly move to the findings. Here are some special findings that I could observe from my study. This is about the satisfaction of undergraduates regarding different aspects. They are actually satisfied with the way that they have to learn from the recorded video lessons, and about having more time on self-studying, and about evaluating their performance using assignments, and also about the responses from lecturers during this university closure time, and also especially the information provided by the institutes on freely available courses and webinars. However, there are some dissatisfaction about some other aspects, such as not having face-to-face lectures, postponed lab practicals and exams, and about participating online examinations. And I want to emphasize the last one, which is the financial support from the government on online studies. They are not satisfied on that, maybe because of the issues that they had to face due to these changes in the learning process. And this is about the opportunities that the students had during this university closure time to improve their skills. So they think that majority of them think that they could improve their abilities in using computers, mobile phones, and the internet, and also the online teaching resources. Not only that, they think that they could improve their self-learning abilities and participating on online discussions and forums. And also, they think they could improve their abilities in using study-related computer packages. However, they think they didn't have any chances to improve their abilities or their skills in sports or these physical activities. That is obvious because we have to maintain social distancing. So we have to, the authorities should think about the ways that they can help students to, in this situation, how to help them to improve their physical fitness. I'll move to another special finding from my study, that is about the time that they have allocated on different activities during the university closure time. Here you can see the majority of them have allocated a higher proportion of time on completing assignments, online lectures, and self-learning on university courses. Other than that, the remaining higher proportion from the remaining time is allocated on self-learning on new subject areas and new technologies and tools. Then the next priority is on improving soft skills and research work. However, you can see here they have allocated very less time, comparatively low time on freelance jobs and webinars and online courses related to industry. Which means these things are out of the things that they had to learn from the university, but they have free time now compared to the time that they had when they are having face-to-face lectures. So it's good and it's better if the universities can help students to get use of this their free time productively and effectively in such a way that they can participate in some online webinars and courses, which would be helpful to them when they are searching for employment. And this is another thing that is about their attitude towards participating face-to-face lectures and online lectures. Majority of them are thinking that face-to-face lectures provide more clarifications. And also, I explored about their willingness to continue lectures in online mode after the university after university reopening. Surprisingly, most of them are saying that some of the courses can be continued in online mode when the university reopens for face-to-face lectures. But we cannot ignore the proportion of 39 students who strictly say that they are not willing to continue lectures in online mode. We had to think about this proportion of students, why they are saying that they don't like to continue lectures in online mode, even though some proportion of students are saying that it is possible to continue some of the lectures in online mode. And this is about the effectiveness. It is a good thing that we can see here, because most of them are saying that they are somewhat effective, not fully ineffective. And this is about the attitudes and the issues that they had faced. I compared the issues during their first few days of online lectures and the current situation. So here you can see that they are feeling, they are situation in feeling stress and depression and not having enough time to completing assignments. They are worsened now compared to the initial few days of online lectures. That may be due to the higher workload compared to the initial few days. And also, they are saying that their situation in not having necessary materials and problems related to the internet connectivity remains the same compared to the initial few days. They are still facing these problems. They don't have enough materials to join lectures and they are facing problems with the internet connectivity. So this is something that the authorities should think why why we are improving the online platform, teaching platform. Are they help students to participating in those things successfully without interruptions from internet and without interruptions due to lack of material. Finally, I have outlined some conclusions from the study, and you can see it is about the stress levels that their students are saying that their stress levels have been increased during the university closure time. So this implies that the proper formulation of formative assessments and active student support system, which can assist students to maintain their mental well-being during this kind of crisis situation, is really needed to help them regarding controlling their stress levels. And this is this is something I extracted from their comments. So they are saying that they are suffering from some illnesses due to the increased stress levels. And also, they didn't experience any improvement in their English language skills and their skills in sports. So this implies we should think about some methods to help them in improving these skills. And then about the less attention on webinars and online courses related to the industry. If we can help them to, by organizing some webinars that would be helpful for them to become more employable in future. And then about the issues that they had faced during connecting these online lectures. So this implies the active intervention from the government is really needed to help students to continue their studies in online mode without any interruptions. So this is again another extraction from student feedback. So they think that they really needed to improve the IT infrastructure facilities in the island overall. And finally, I'm ending this presentation with something that I observed from the feedback from the students. So they are saying that they have become a hopeless generation and they are filling Google Forms, but the authorities are doing something that they want to do without thinking the feedback, even though they are gathering feedback from students. So there are many opportunities to perform better. So it is essential for the higher educational sector to seize this opportunity for their survival, efficient functioning, and also for the benefit of future Sri Lankan graduates. So that's the end of my presentation. Thank you very much for joining. And this is time for your questions.
Thank you. So we'll take up all the questions at the end of all presentations, depending on how much time we have. The next presentation is on state response to COVID-19 in Sri Lanka and uncovering social distancing experience in socio-cultural context by Professor Chandani Liyanage, Department of Sociology, University of Colombo. Over to you, madam.
Good morning. I'm Chandani Liyanage, attached to Department of Sociology, University of Colombo. Today I'm going to talk about state response to COVID-19 in Sri Lanka and uncovering social distancing experience in socio-cultural context. In responding towards the global pandemic of COVID-19, a long-standing public health measures such as social distancing, isolation, and quarantine have been implemented all over the world to control the novel disease which often used in disease containment. Each country adopts quite specific strategies to implement such interventions depending on relevant socio-cultural context, level of threat perception, available science communication strategies, capacity of healthcare delivery system, and the leadership qualities of particular country. However, the compliance behavior determines by the ways in which how lay people conceptualize the illness, modifying and enabling factors. Present paper examines the novel experience of social distancing interventions by the state in Sri Lanka to respond the global pandemic of COVID-19. Main objective of the present study is to critically review the state response to COVID-19 pandemic in the local social context and learn from best practices, limitations, and challenge that would contribute in shaping future interventions targeting epidemics control. Specific objectives of the study are to explore culture competency of social distancing strategies with special attention to the nature of the state-led top-down public health interventions in terms of their socio-cultural sensitivity, strategies used in science communication, public compliance, and behavioral change that followed. And also to identify the strengths and gaps in state interventions and emerging challenges towards a new normal situation. Let me briefly explain about our methodology. The present paper is based on part of an ongoing exploratory study on social determinants of COVID-19 pandemic, social distancing experience, and associated socio-cultural implications. Both primary and secondary data sources were used in the analysis. Primary data collected from a purposive sample of 60 respondents that included 30 university students and 30 respondents from diverse socioeconomic backgrounds who were contacted through social network of the investigator. Data collection techniques include a systematic observation of the phenomenon from its beginning up to date, qualitative interviews, and focus group discussions. The interviews were expected to elicit data on lay perceptions and meaning attached to social distancing and lived experience with regard to social distancing interventions. Let me summarize the findings of the study. Sri Lankan experience revealed that threat perception with regard to pandemic by the state was quite high, and urgent actions were taken in order to implement social distancing strategies as public health measures by adopting top-down approach. This approach, rather forcing the general public to fit into compliance behavior, assuming that people would rely on social distancing measures positively. The process has been operated by the state as a collaborative effort by healthcare providers, the Triforces, police, intelligence section, under the guidance of the political leadership. Modeling the impact of COVID-19, a dominant attention has been given to maintain effective social or physical distancing while increasing health sector capacity, isolation of people with virus, and quarantine arrangements for close connections of patients and persons who suspected as having a risk of carrying virus. Healthcare delivery system plays a crucial role in this regard. The following figure shows the internal structure of local healthcare delivery system, which has three overlapping and interconnected sectors of healthcare. So this is the internal structure of local healthcare systems developed by Arthur Kleinman, who is one of the best prominent anthropologists. Talk about popular sector, the folk sector, and the professional sector. So among those three sectors, the popular sector is the largest sector that included individuals, family-based, social nexus-based, and community-based. Also, community beliefs and activities involved in this sector. So here the popular sector, each sector has its own ways of explaining and treating ill health and specifying how healer and patient should interact in their therapeutic encounter. Popular sector is the largest part of healthcare system, but in this context, less attention was given. Lay, non-professional, non-specialist, popular cultural arena, which illness is first defined and the healthcare activities initiated. So that is why the popular sector is very crucial in this context. As Amartya Sen pointed out, tackling a social calamity requires cooperative efforts, participatory governance, and alert public discussions. However, in the Sri Lankan context, biomedical system as the professional sector plays a dominant role in pandemic control rather neglecting popular and folk sectors of local healthcare structure. The public healthcare delivery system has a mechanism to reach the grassroots level through its MOH networks. Most of the interventions have been designed by the healthcare professionals and implemented with the assistance of law enforcement authorities from top to bottom, assuming that the general public would rely on compliance behavior as passive recipients. The findings reveal that number of gaps in vertical structure of healthcare system at delivery point, and also number of shortcomings as those strategies fail to incorporate knowledge about the local social structures, behavioral patterns, and the mentality of lay people. The lived experience of respondents revealed that a number of socio-cultural and psychological issues have been emerging in the local context, not merely due to adverse effects of the pandemic, but also due to drawbacks in intervention process by the state. Threat perception of respondents were fairly high, and they have a strong sense of fear with regard to the illness. It is not simply because of the sensitivity of the pandemic, but also due to stressful situation created by intervention process itself. In this process, patients, family members, and the communities identified as high prevalence experiencing a lot of difficulties due to stigma and discrimination associated with the illness. Negative consequences further increased due to unethical media operations. Awareness raising campaign was operated predominantly by using formal media sources, which hardly touch the marginalized social sections who have no access to those media coverage. The evidence also shows that minimal attention was given on psychosocial issues emerging during pandemic and failed to provide essential support services. Evidence also suggests that negligence of short-term or long-term interventions targeting emerging social issues in pandemic situation. Social determinants of COVID-19 have not adequately been encountered in interventions, and pandemic reinforces existing social inequalities. Very minimum effort given to empower lay people sufficiently to protect themselves. And also interested to note that the lay people have paid more attention on complementary medicine and efficacy of traditional medicine during pandemic situation. Let me conclude the presentation. In conclusion, this exploratory study has analyzed how public health interventions are conceptualized in the relevant socio-cultural context and identified strengths and gaps in state response to COVID-19 in Sri Lanka. Findings highlight the significance of taking into account the local socio-cultural context in implementing universal public health measures in pandemics that determine the specific outcomes. The paper also concludes that priority should be given to strengthening the pre-healthcare delivery system of country while enhancing the capacity of healthcare providers to collaborate with communities and multidisciplinary groups to achieve better public health outcomes. The pandemic situation requires innovative interventions to support the marginalized social sections and also to address behavioral issues where social sciences have a greater competency to contribute. It is recommended to adopt a biopsychosocial approach for epidemics control, where social scientists or behavioral scientists could collaborate with healthcare providers to address the gaps highlighted from the findings of present paper. Thank you very much.
Thank you. Next presentation is on COVID-19 and the pandemic of hate speech in Sri Lanka by Professor Kalingutiu de Silva, Department of Sociology, University of Peradeniya. Over to you, sir.
Thank you very much. Can you all hear me?
We can, sir. Yes, sir.
Okay, thank you very much. I will go to share screen. Can you see my screen as well?
Yes.
Okay, thank you very much. So this paper examines COVID-19 triggered pandemic of hate in Sri Lanka as reflected in social media. In the previous presentations, we heard quite a bit about mainstream media, but this paper actually primarily focuses on social media, which I think has big impact, particularly on youth in the Sri Lankan context. The first scientific citation of the term pandemic of hate appears in an editorial of the American Journal of Tropical Medicine in early 2020. It claims that there is a hate campaign targeting Chinese and Chinese-looking people in Europe and North America following the onset of the pandemic. Subsequent research showed that the hate campaign targeted different categories of people in different countries, depending on internal social dynamics and the epidemic history in each country. Turning, I think we are missing one slide. Okay. Actually, one question we are looking at is in what sense hate is pandemic. And I have 4 points here. Hate also has an infective character, just like the COVID-19 virus. It infects from person to person and from one group to another. And it has a damaging effect on the social body and the body politics in a country. It promotes mistrust among communities. COVID-19 related hate campaigns in Sri Lanka have targeted several communities. I have listed some of them here: minorities, the Muslims in particular, prisoners, addicts, garment workers, and fish mongers, to list a few. In this presentation, I will primarily focus on anti-Muslim hate campaign because it also is connected with the previous political history in Sri Lanka. The infective character of hate pandemic has several aspects. Firstly, it is anchored in a kind of burgeoning nationalist mindset. It breeds in a particular mindset, which unfortunately seems to be very widespread in Sri Lanka right now. In fact, it spreads from previous episodes of ethnic violence. So actually, hate pandemic that I'm referring to predates the COVID pandemic. It's infected from electronic media to print media and vice versa, and from mass media to social media. And also it's infected from one social media post to another. So it has a kind of infective character. But there are two special features of the pandemic spread when it comes to the hate pandemic, which is different from COVID-19 pandemic. One feature of the COVID-19 pandemic is that person-to-person infection requires physical proximity, as we discovered in previous presentations. But the hate virus does not need that. In fact, with the ICT revolution, it can spread from one group to another, long distance, virtually, and it can spread much faster than the COVID-19 virus. And also another important difference is we know that elderly with health complications are perhaps more susceptible to corona-related complications. But in the case of hate pandemic, it's a different category of people. It's actually IT savvy youth and some political actors appear to be more vulnerable to the hate virus. There is also a receptive character in society, to absorb hate and to react to hate. There's no contestation or challenges, there's obviously misinformation disseminated through some social media posts and nobody actually challenges them. Very few people challenge them. And in fact, there is active support for some of the hate content as reflected in sharing of posts and likes and so on and so forth. And in line with a particular mindset, mindset shaped by a particular nationalist reading of the pandemic, adding to both infectivity and receptivity of hate speech. And there's a clientele and a demand for such messages as reflected in hits and shares. And targeting Muslim politicians by law enforcement machinery and media has also added to this hate pandemic. I'm just showing you a few Facebook posts selected on a purposive basis. Now, this one is, it's actually, this did not originate in Sri Lanka, originated in India. And it shows that actually in this post, Muslims are blamed for both Easter attack as well as the pandemic. And obviously, this is kind of wrong blaming. But nevertheless, this social media post actually went viral. And if you look at this social media post, which was invented in Sri Lanka, it says, Haduwe China, Nama Corona, Paturanne Nana. Made in China, brand name Corona, wholesale distribution in Sri Lanka by none other than Nana. As you know, Nana is a kind of slang word for Muslim in Sri Lanka. And this post has really gone viral. If you look at likes, 422 likes, comments 42, and there was a lot of shares, 9,700, quite big considering the Sri Lankan context. And this is another post actually which blames a particular individual from a certain suburb in Kandy for spreading the virus in the area. Actually, the name of the person is made and the face is shown. It says this person went to India and came back with corona and spread to several, neighborhoods and bazaars in and around Kandy. And then I also discovered that there are some pro-Muslim Facebook posts, and this is one which was triggered by cremation of that infant, 20 days old. There was a lot of backlash, against this. What I want to highlight in this presentation is that this hate campaign actually can derail disease control efforts because it creates fear of getting infected, fear of dying of COVID infections, people not coming forward for PCR or antigen tests, as reported in some locations. And this may also lead to possible underreporting of disease and patients running away from health services have also been reported, at least in a few instances. Several largely Muslim clusters of disease have been reported in a number of places. So actually there is a greater chance of enhancing the epidemic outbreak due to such fallout, actually from fallout of cremation or like mandatory cremation. So basically this paper argues for mandatory cremation as well as burial, because I feel that there is a kind of almost consensus within the Muslim community that they need burial, because that is the only method approved by their religion, and obviously they have a right to say that. So in my personal opinion, actually this should have been addressed, and this actually has contributed to considerable kind of resentment within the community. I will skip this in the interest of time. But actually, the main point I want to highlight is that apart from the possible public health impact of this mandatory cremation, it can also have serious social consequences in respect of polarization of communities, and create obstacles for long-term peace and stability and resilience, which is obviously one of the key themes of this conference. It can add to tensions, and also it can even trigger violent extremism. And we have to take this seriously, particularly in the aftermath of Easter Sunday attack. So these are some social issues that require attention. Finally, I will touch on several policy issues which actually comes from this.
We don't have time, sir. I think better.
Okay, I will skip that. Okay. Yeah. Anyway, my presentation is there.
Yeah, thank you, sir. Thank you. The final presentation is on the social impact of COVID-19 pandemic in Sri Lanka and its implication for achieving SDGs by Professor Siri Hettige from Department of Sociology, University of Colombo. Over to you, sir.
Okay, this is going to be the last presentation as the Professor Pinnavela is not going to make his presentation. As you can see, the title of my presentation is the social impact of COVID-19 pandemic and its implications for achieving social sustainable development goals in Sri Lanka. As you can see, both the data coming from field studies that have been conducted, as well as secondary data coming from various institutions, point to very significant economic, social, and psychological impacts coming from this pandemic. Now, when you look at these social, economic, and cultural impacts, it is very important for us to recognize the nexus between the health implications on the one hand and these other as important, if not more important, implications of the pandemic. I'm not going to really, I don't know who is going to control the, do I have to control the, okay. I'm not going to really give any preamble to this presentation because it is already there in the abstract, which you can see here, but let me move on to the next slide. Now, the disruption of economic and social life of individuals and families. I think the macroeconomic impact is very clear, that has been widely discussed, and there are presentations made by different presenters during the course of the present conference. The government revenue, public investments, foreign trade, remittances, tourism, employment, income distribution, and so on. So I don't think I need to really expand on any of those. But when you also look at social and cultural impacts, we also know livelihoods have been affected very much, not just in one sector, but in almost all sectors. And the food security has been a major issue, poverty and inequality. Then, of course, the impact on education from primary school right up to the universities. And then, of course, access to healthcare has been very much affected. Then mobility has been a major impact, and impact on mobility. And then, of course, that has very significant implications, including the impact on leisure, because people naturally move around a lot, and I think that has been very much. And then vulnerable population groups have been even more affected by the pandemic because of their pre-existing vulnerabilities. And the social and cultural impact, I think, of course, is very, very important. And as you can see, how hate, inter-community, uh, you know, uh, relations have been very much altered by the pandemic, both directly and indirectly. Then moving on to the next area, that is the SDGs. As you know, Sri Lanka had achieved some SDGs already in line with the time frame. For instance, poverty in Sri Lanka has been reduced over the years, and then of course unemployment, as you know, has also been quite low. So the point is that there are some areas where Sri Lanka had done fairly well over time, but then of course we have a long way to go in achieving so many other SDGs. I will not go very much into these areas in terms of data, but I will run through the most significant SDGs that we have to really look at in terms of the impact of COVID on achieving these. Now, of course, human development area, I think, is very, very important, where we have achieved a great deal over time. In fact, Sri Lanka had improved on human development indicators over the last 20 years. But on the other hand, the pandemic is going to have a major impact on our human development situation in the country. But moving on, hunger, I think, is a major issue that we have to look at, because certainly food security has been affected, and this situation is not going to be easily overcome under the present conditions. And then, of course, undernutrition was a problem already, particularly among children, and the situation can be very much affected by the prevailing situation, and of course it can even get worse. And then poverty, Sri Lanka had reduced absolute poverty to a very low level, but of course we had relative poverty, and also we had other aspects of poverty that have not been addressed through existing policies and interventions. Now, when you look at the macro data on income and expenditure at household level, Sri Lanka already had a big issue, because when you look at the households, 50% of the households in fact had an income deficit, in spite of the fact that we had a head count index of around 6% at a national level. But of course, we also already had noted significant regional disparities and sectoral disparities in terms of poverty rates and so on and so forth. Now, this situation can really get worse over the time. Therefore, really achieving the issue of achieving poverty reduction in the next 10 years, that is the period when we should really achieve the sustainable development target, we have major challenges. And the inequality, of course, is a major issue, particularly regional and sectoral disparities. Now the question is whether we would be able to reduce inequality. I think that is a major issue that we need to really focus attention on. Moving on to other sustainable development goals that we have to focus attention on in the present context, healthcare, quality healthcare. I think that is something that we have to address, because the situation that has emerged is not going to be very helpful to achieve quality healthcare for all by 2030. Education sector, I think there are, as you know, huge disparities, and I think the gap between rural and urban educational facilities has really come out very clearly during this pandemic. I think in this case, we certainly have to look at the digital divide and how it has impacted on lower segments of society in accessing educational facilities, particularly the education delivered through remote means. Then the area of gender equality, I think, as you know, in the area of employment, we have a major issue with respect to gender. The participation rate, labor force participation rate among females in this country has been quite low. And now this is not going to be helped because, as you all know, the foreign employment that has been very much made use of by females in this country to find alternative means of livelihood outside Sri Lanka has been very much affected by the pandemic, and we do not expect this situation to improve. And then, of course, labor-intensive industries have been affected, and there we can see that female labor force participation could go further down. So the point is that the socioeconomic status of female population can be adversely affected by the present conditions and the conditions that have been generated by the pandemic. Moving on to water and sanitation, I think certainly the issues connected with water and sanitation are very much related to the present adverse conditions that you observe in the country. I want to move on to the next three areas. One is decent work, and that is a major sustainable development goal. Now the question is whether we would be able to make much headway in creating decent work, particularly when we have a situation where even the informal sector has been very much affected by the pandemic, and then there are major problems with respect to unemployment. So the question is whether we would be able to really, reach the goal of achieving decent work in Sri Lanka as part of our effort to achieve sustainable development goals. Now, safe cities, I think that is another sustainable development goal. Now, of course, cities have not been the safest places when it comes to the pandemic. As you know, the congested urban areas have been a major issue. And I think we certainly have to figure out how we could address the issues in urban areas in terms of not only social and economic conditions, but also making them safer for people to live in. And finally, the Sustainable Development Goal of peaceful intercommunity relations. I think the presentation that was made by Tu Silla before me very much highlighted the situation with respect to intercommunity relations. I think this is one of the major problems that we have to tackle, not only to create a peaceful environment in the country, but also creating the conditions that are conducive for sustainable development in general. So I think overall, we have to now look at where we are in terms of sustainable development goals and how do we really move forward. And I think there are very, very major challenges in almost all the sustainable development goals that I have listed here. So this is really not something that we can discuss in brief. It's something that we certainly have to discuss in relation to policies and state intervention, and also, of course, other sectors that are very much involved in pushing national goals forward. Let me see, is this the last slide? I think there's another slide. Yes. Now, now the point is that the pandemic has made it harder for Sri Lanka to achieve sustainable development goals. That's the main point that I wanted to highlight. And then the main reasons are quite obvious. The macroeconomic conditions, have to be conducive. But on the other hand, we know that the macroeconomic conditions that have emerged over the last year are not going to be very, very helpful unless we address them quite effectively. And then increased poverty and inequality, I think that can be a major problem that we should try and avoid, but it is easier said than done. And then the regional and sectoral disparities have to be looked into, because they have really shown how difficult it has been for us to cope with the pandemic because of these regional and sectoral disparities. And then the problem is that whether we have the capacity for increasing social investment, because that is the way to address a lot of the social and even psychological issues, whether we would be able to really increase social investment under the macroeconomic constraints that we are operating under right now. And then the most important thing, I think, is whether we could achieve economic growth under these conditions to create better employment, generate a surplus that would be invested in various social sectors, and so on and so forth. So these are all big challenges, and I think that we certainly have to figure out how we could manage these challenges, through evidence-based policies, as well as, of course, various interventions that are tailor-made to address these very specific issues. And okay, I think the last slide, is that the last slide? Okay. The availability of data, I have already mentioned that institutional sources are very, very important. Whether the institutions are really updating their databases, I think that's a big issue, because we still don't have up-to-date data coming out of the institutions. And then the primary data generation has become very difficult under present circumstances. Of course, it is not impossible, because there are various other ways to collect data, even when you can't go out and collect data in person. And then, of course, there are challenges, but at the same time, there are opportunities we should explore and see how best we could make use of these opportunities. And the need for new research, I think, has become very, very critical, because we are really in the dark when it comes to data on some of these issues, particularly in assessing the very, very rapidly changing circumstances in the country. Can we have the next? Okay. Conclusion, I think, I don't know, I think probably have taken too much time, but anyway, let me take a minute and run through these conclusions. Pandemic has made the pre-existing social and economic conditions, economic issues more acute. I think that is a very, very, obvious implication, obvious outcome. A persisting pandemic makes it harder for the state and other actors to address social, economic, and psychological issues faced by the population, in particular more vulnerable groups. I think that is another very important conclusion. Understanding the issues and their trends based on data is critical for formulating strategies to address them. So that's the point that I made, that we need really new data, and I think the new data has to be generated by institutions as well as by social scientists. I think that is the only way that we could, create a policy-friendly environment in the country, because if you don't have the data, you won't be able to really provide the necessary, necessary guidance to policy making. And finally, the state and other stakeholders need to pay equal attention to both social and economic issues and health issues, because it is really a balancing act that we always have to make, and that is to save lives on the one hand, on the other hand, to make sure that the people also lead their lives in the way that they have been quite used to. So the point is how to really ensure both. That is to create a safe environment for people to live, but at the same time ensure that people also have opportunities to access the things that they require, and that I think is really a huge challenge. And I think we certainly have to contribute from our side, from the social scientist side, to not only make people aware, but also to provide the necessary inputs that are critically important for decision making, particularly policy making and formulating state interventions. Thank you very much.
Thank you, sir. I don't think we have time for questions. So I think I would like to thank all the paper presenters and participants, also technical team for managing the session. And we try to, with that, we will conclude the session. Thank you.
Thank you very much, Emeritus Professor Siri Hettige and Dr. Nishara Fernando, for sharing this session. We are now commencing plenary session 5 on building a resilient community and economy. I would like to cordially invite Executive Director of the Institute of Policy Studies, Sri Lanka, and Head of its Macroeconomic Policy Research, Dr. Dushni Weerakon, to chair the plenary session.
Let me first of all welcome all those who are watching online to this fifth plenary session that is going to look at building a resilient community and economy. It's a pleasure to chair this session. Two very eminent panelists that need no introduction to a Sri Lankan audience, and I'm sure even to any global audience that's tuned in. So I have great pleasure in inviting Dr. Aryaratna, President of the Sarvodaya Shramadana Movement and former senior lecturer in community medicine at the Faculty of Medical Sciences, University of Sri Jayawardena, put it to the podium. And I believe Dr. Vijay Wardena, former Deputy Governor of the Central Bank of Sri Lanka, will be joining online. Dr. Aryaratna will kick off this session speaking on community engagement in COVID-19. Dr. Aryaratna, just a kind reminder that 20 minutes is the allotted time. Thank you.
Thank you, Dr. Veerakon. Good afternoon to all of you who are present here, physically present here, and good evening and good morning to those of you who are watching this presentation from other countries. Let me first thank the National Science Foundation for inviting me to share my experience and views on this important topic of community engagement in combating COVID-19. So I like to reflect on the concept of community participation as an introduction and really to understand what it means, and then would like to share my own experience in getting community engagement or community involvement in COVID-19 related activities from a civil society perspective, because I was not involved very much from the state control program of COVID. So what I'm sharing is the actual experience working with the communities with whom we have been working for a very long time as a development organization, and then also share some of the lessons learned and also the challenges as I see and how we move forward. So community engagement, if you look at the definition without looking at it from a very technical or academic definition, is a process of developing relationships that enable stakeholders to work together to address health-related issues and promote well-being to achieve positive health impact and outcomes. And it can also be seen as an important intervention or important element in during public health emergencies. Community engagement involves those who are affected in understanding the risks they face and involves them in the response actions that are acceptable. This is very important, how we involve them and what influences their thinking in their actions. So when you look at also who is really involved in this process, I would like to broaden the scope of the stakeholders. Multiple communities are there that could include religious leaders, community members, patients, health professionals, policymakers, and other sectors. So community engagement, I define not just involving people at the grassroots level or for that matter, urban communities who are subjected to all kinds of health interventions, but thinking as a community, as a whole, community of professionals. But of course, I would like to particularly touch on the grassroots. And then, which is very important right now, is also about relationships, the relationships that we are having as citizens with health authorities, relationships that we are having as professionals with decision makers. So there is an element of respect and trust and a sense of purpose that involves community engagement. I like to make my presentation based on three sections of the dividing the timeline into three sections. Of course, we know the first wave was there from late March up until the end of May, when there was a lockdown period. Then the second wave started around early October, and it still continues, although the increasing trend has started to decline. So in terms of analyzing the community engagement during this period of 10 months, I divided it into three phases. The first phase is the emergency phase, when we had the first wave, and then The second phase is the phase in between the first and the second wave, where there was relaxation of lockdowns, and also where there was more attempt to recover from the socio-economic impact that had taken place. And also the people were really trying to understand what was going on. And then probably during that phase, we have seen a sense of complacency also setting in. So I think how we behaved, how the citizens behaved during this second phase from June to September influence the different dynamics we are seeing today. So probably we have a lot to learn. So this is also a learning experience for us as we start the year 2021. Still the disease is spreading, and how we position ourselves in control measures. So when you look at the phase one, the emergency phase, we could see that it was, of course, a new experience for everyone, even for doctors, health experts, as well as those of us who are also involved in humanitarian work. This is a new experience. Although we have been involved in assisting in disasters, both man-made disasters or human-induced disasters, as well as natural disasters, every time that had happened during the last, probably at least in my life, my professional life, 30 years. So, but this time it was different, because even though at community level and at national level, we are first responders, this time we couldn't be first responders in the same way that we used to do, for obvious reasons. It's a very highly infectious disease, and we didn't also know the behavior of the disease itself at the time that we had the lockdown. However, what we could see was the first initial community response was, of course, compliance. The government introduced certain regulations and people 100% complied, even though it had a terrible impact, negative impact on the grassroots communities in Sri Lanka. Daily wage earners, urban low-income groups, free trade zone employees, particularly women. Up to now, we are having the impact. Even yesterday, I was getting requests from the hostels where these women are residing, asking for various kinds of help to address some of the needs that they are having. Then what we saw during the first phase was a organic community response. We never, even though the civil society organizations have been working with these communities and preparing them for disasters, trying to build their resilience, it was a very organic, natural, unorganized, and voluntary response. This was followed by a more formal response when then we were able to grasp the situation well and then have more organized action. It has been a challenge for humanitarian agencies, development agencies. Now, emergency relief was there. Many people started to contribute in different forms to alleviate what I call the suffering, the unseen suffering, which was not reported in the mass media. And it was a huge contribution. It's not just the 5,000 rupee donation given by the government, on the allowance given by the government to the families, but it was a tremendous community response. A compassion that was there really came out. Then I would like to cite one specific example of community response in reaching the vulnerable groups. As you know, in Sri Lanka, there are about more than 800 care homes, residential care homes in Sri Lanka. Children's homes, elders' homes, homes for women, women safe homes are there, then safe houses, then children with special needs are also cared in some homes, then rehabilitation centers and probation centers. So there's about probably over 20,000 individuals who are in these care centers, and generally they receive a lot of support from the community. Food is donated, dry rations are given. Then they faced an immediate crisis, and we were able to organize the community to really share whatever they have. And I could say that we were able to meet the basic survival needs of more than 15,000 out of these over 20,000 individuals, including children and women who were residing. So that was really true community engagement, and even people who didn't have a lot of money contributed. So I would say that was a great um, uh, achievement as a country in a time of crisis. Then there was also, as I referred to earlier, organized response, particularly youth groups, the women's groups. They organized and directed their support to targeted groups around the country. Then the community response also included risk communication, although there were messages designed centrally and then given to the public. Sometimes the last mile was not there in terms of delivery of the message. So what we did was to create, based on the scientific messages that were designed by the health promotion bureau and other experts, and we also designed our own messages and delivered them to targeted audiences. For example, how to use the messaging through a religious perspective. There are teachings in any religion that can be related to a pandemic situation or an epidemic situation. So we filtered them, we designed very effective visuals, and then we disseminated them. Then also, going beyond the health communication, we were preparing also the communities to address some of the other needs that were there. Food insecurity and how to save resources. These kinds of messagings were also done. So the community engagement was a two-way process where we tried to identify what were the real needs of the communities, and then linking with the best of scientific knowledge that was there at that time in relation to the spread of the COVID-19. So the success factors in the initial phase of responding to the needs of the communities was the fact that there were determined volunteer groups, mainly youth. And I'm very proud, and I feel that the future of this country is really in the hands of the youth. Probably we have failed in our duty in really addressing some of the key fundamental issues of our society. Then there was a key element of trust. I'm coming back to this because this is probably the most important element in COVID-19 control in Sri Lanka from a sociological perspective, and identifying the needy through an inclusive approach, because we can't leave anyone behind. Those who are those who are marginalized are the ones that we should try to somehow reach to and then provide protection. Then the use of information communication technology, real-time information. I think we haven't really used the fullest potential that is there of information communication technology. Then the partnerships and coordination was also another success factor. It was not because a donor was having a project and pushing you to partner. It was very organic, coming from within the individual's desire to come together and be part of the control process. Then in ensuring non-dependency, this was it is very important even now. We have seen during earlier disasters like the war, our own response made the communities dependent on outsiders. I think we were very conscious from the beginning, and it was time bound. And even these care homes, we said that we will only support you until the curfew is lifted. After that, you have to revert back to the existing mechanisms, but we will support you in other means by providing you support to protect the centers, particularly the elders' homes. Right now, fortunately or unfortunately, we have only had, I think, less than 20 elders living in elders' homes who were positive with COVID-19. We were able to contain, and we did a very comprehensive plan with organizations like HelpAge to have protocols. There are protocols, but they are not being practiced. So how to really operationalize them. Then the second phase, I like to go into the second phase very quickly. We assessed what we did and what were the deficiencies. There was low level of active community involvement, but they were engaged in the response. Risk communication was one way. We were not really measuring whether the messages reached and whether the messaging really got translated into action. Social stigma and discrimination. I don't want to elaborate on that because earlier sessions, this was very much discussed. And then the changed context in the health services provision, which is, I was really reluctant to put this point, but I'm sure Professor Atula Sumatipal also knows this. I think as a whole, the health sector, human resources, they did an outstanding job. But there was also concerns regarding some practices and attitudes within the health professionals which were unscientific, to say the least, and also not in line with standard ethical practices. I think ethics got tested this time of all professions, and we have to bring this back, science and ethics together. We can't have science without ethics. Then gender issues, right? The issues faced by women. So based on this only, we designed the next phase. That is when we had these relaxations, and then the strategic actions were really looking at mobilizing the communities by first giving them information and training them and building their capacity. Because it's easy to select one or two communities and show success. But if you are to do in scale, that is what's required now to have an impact on the transmission. Then strengthening the leadership and meaningful participation of women. We have to bring the women planners, women activists at the center stage. That has not happened. So then mobilizing religious leaders and strengthening partnerships, and also have much more tailored messaging to communities. So we learned these lessons, and based on these lessons, we also looked at how we can mobilize religious leaders. We did a survey, and I'll not present the findings here, but just to say that the religious leaders acted in various ways to contain, and they helped to contain the epidemic in their own local communities, and more potential is there. Now comes the third stage, where we all know that the disease again started to spread very fast. So then we were focusing at what we call building community resilience through COVID-ready village concept, and then selected villages who are willing to part of this. And we already had outreach through our main organization and other partner organizations. And we developed a model where we were giving basic messages along 5 points, and really trying to see whether we could have a local control so that each village can minimize the number of COVID positive cases. That was the idea. But what was the impact? Did we have an impact? These maps say it all. Though we have done so much, it's spreading. You can see the number of MOH divisions which have reported a positive case during the last 2 weeks. So within a span of 4-5 weeks, we are seeing this situation. So the strategy needs to be changed. This is the situation today. We have passed the 60,000 mark with 290 cases, but I don't think it's the numbers that matter that much. But the question mark is the strategy. So the current challenges, as I see, there is definitely community transmission, even though the definition is somewhat vague. Then there is also reluctance of the people to seek treatment for other disease conditions, which is also a concern. There is still capacity in the healthcare delivery system. It has not been exceeded, but there is pressure on the healthcare system. Serious socioeconomic impact, and also disinformation, misinformation, stigma, and discrimination are very, very strong still, and we need to counter. Then this lack of social science and behavioral science inputs for COVID-19 response in Sri Lanka. This is unacceptable. There were presentations earlier, and it was very clear. They also gave with evidence this shortcoming in our response. So building trust in the public mind is of utmost importance. Reliability of information and transparency. I think most of us don't know what will happen if we become COVID positive. So the quarantine and referral mechanisms to COVID-19 treatment centers must be made more transparent. Random testing procedures in highways is also putting people under a lot of pressure. Vaccine rollout needs to be also very clearly understood by the people. And some negative examples set by key influencers from, I will not name, but you know, bad optics, what they see on television screen, that influence their behavior, not the messaging by the doctors or the health promotion bureau. Question of equity, social justice. Now we are seeing these disparities. We already had disparities even though we have good health indicators in Sri Lanka. Now they are getting worse. Quality of care at intermediary centers, and effective coordination at different levels, starting from the grassroots level up. So my recommendations are: learn from countries first year experience. We have had 1 year's experience. We have now 12 months of solid experience at all levels. And the papers presented in this conference shows how much knowledge we have harnessed from medical sciences to social sciences to technology and so on. Let's look at all these and then mount a whole of society approach. Every citizen should feel that I'm part of the COVID control program in Sri Lanka. Based on this, revisit the national strategy. There is we have to modify. It's also the way we manage patients. Here we manage a community. If the treatment is not working, we change. So same way, we have to really have a relook at the national strategy where community engagement and coordinated resource mobilization, not expecting foreign countries to help us, but there's a lot of resources in our own community and addressing the critical issues identified above. Then finally, give priority to building community resilience based on science, not on myths or hearsay or emotions. Thank you very much.
Thank you, Dr. Aryaratna. And I must say that you were just 15 seconds within your time limit, and that's exceptional, as was your presentation, given the very significant experience you have had in dealing with community engagement in the various roles that you have played. So some very important recommendations came out of Dr. Aryaratna's presentation. And now we will turn our attention to the economic impact of COVID-19 and resilient economic recovery. And I don't think there's anyone better qualified to speak on this topic than Dr. Vijayawardena, who is a prolific writer, analyst, and I must personally say a very strong supporter of the ideas, which I always very much appreciate. Dr. Vijayawardena, the floor is yours.
Okay. Thank you very much, Dusni, for inviting me. And in fact, I thank the organizers for inviting me to share my thoughts on this particular subject. I will share some of the things that I want to say. In fact, Professor Hettige as well as Dr. Aryaratna, who spoke before me, they referred to the problem of economic downturn that has been caused by COVID-19 pandemic. I would like to say that Sri Lanka's present economic problems are not necessarily due to the COVID-19 pandemic, but they had started long time before. Long time before Sri Lanka had the COVID pandemic, and we were in fact having a kind of time bombs. There are several time bombs that had actually affected the economy, and Professor Hettige had referred to them, and one is this economic growth has been slowing down. The budget has been in a very critical situation. Then our external sector has been again very fragile, and then the country had been trapped in what is known as this inescapable debt trap. And these time bombs are actually clicking now, and at one point of time they could have exploded, and the Sri Lanka's present situation, in fact, has been worsened as a result of the economic slowdown. So I don't want to go through these things, very in detail, because these have been very odd. The economic growth has been slowing down from around say year 2013, and then our budget has been in fragile situation in almost every respect of the budgetary standards. And the external sector had been very fragile because we had a very high trade deficit and high current account deficit, and the exchange rate had the pressure to deficit. And also the foreign debt had been overhanging on Sri Lanka's economy. And if we specifically look at the exchange rate has been moving against Sri Lanka rupee in the last maybe 10-year time period, mainly because Sri Lanka's inflation rate had been higher than the inflation rate in the United States. where the currency of United States has been used by Sri Lanka for its benchmark. Because of this, higher inflation in Sri Lanka than the inflation rate in the United States, our exchange rate has been depreciated continuously, and it is depreciating even today. And the external debt has been also rising as a percentage of GDP. What matters to us is at the particular point of time is not necessarily the external debt of the Sri Lanka government, external debt of the whole country, the whole nation, which includes the debt contracted by the private sector as well. That is rising. And also part of the debt has to be repaid by us. And when it comes to the government debt, we will find that next 5-year time period, we have to have at least a minimum of $4.5 billion US every year in order to pay interest and repay the principal of the government debt. So these are the things that we are facing, and these time bombs can explode. But on top of that, we had been now affected by the COVID-19 pandemic, which had worsened our situation. And the immediate strategy should be to support the individuals and also businesses to carry on their business and come back to what they had been prior to COVID-19 pandemic. In fact, we have to come back to the level of end of 2019, and then we restart building up the economy. When it comes to the medium and long-term measures, I will like to highlight some of the measures that we have to take. And every country will need investments of higher percentage of their income in order to increase the output. And that investment ratio and also the ratio of using capital efficiently, which we call the incremental capital output ratio, will determine the future economic growth of the country. In Sri Lanka, our efficiency of our capital use has been very low. So as a result, if we want to get 1 unit of output in Sri Lanka, we will have to invest at least 5 units of capital. So what it means is, if we want to bring the economy back to its former economic growth target of say 6.5%, we need to invest at least 30% of our income. So that is where we are having problem. And but of course this has been complicated. But because of the reason, we have a very low total factor productivity. Now, what we mean by total factor productivity is when we combine the human resources with physical capital, the combination of both will enhance the ability of the economy to produce more than what the aggregation of the individual individual inputs might contribute. For example, if capital can contribute 2% and the human beings can contribute under 2%, the economy will grow more than 4% because of this total factor productivity. In Sri Lanka, the total factor productivity is low, but that is a concern, and that concern can be addressed by using technology. Because if we want to increase the total factor productivity, what matters to us is to use the advanced technology in order to increase the total factor productivity, which would in fact increase the total output in the country. Now, Sri Lanka's economic growth has been negative in 2020, and most probably in the next 2 to 3 year time period, we will have either negative or very low economic growth. But that can be changed if we can increase the total factor productivity through technology. So what we must do is we must have an economic system where the inventions and innovations should go together. The researchers and the scientists and also engineers should come up with inventions. They will create a new thing, new product or new service or new management system, but they have to be used commercially in business. That has to be done by entrepreneurs through a process known as innovation. Now, this is the difference between invention and innovation identified by the Austrian-American economist Joseph Schumpeter in a book he published in 1942. But he had said there are 2 other things that has to accompany these things. One is the diffusion of knowledge, the spread of the knowledge about the invention and innovation, and then the imitation of this knowledge by all other people in the system. So without the invention, innovation, diffusion, and imitation, Sri Lanka has great difficulty in bringing the economic growth back to this 6.5% growth target of the present government. So these are four factors that we have to keep in our mind. But in the present economies, we have the, therefore we call the present economies innovation economies. And the innovation economies differ from industrial economies, which we had earlier. Because in the case of industrial economies, the raw materials are the natural resources, labor and capital. But in the innovation economy, the raw materials are simply ideas, the knowledge of the people. Then the customer focus, in the case of the industrial economy, they want to mass produce goods like, producing apparel for the world. But the innovation economy, they customize the production based on the information and technology, and also they decide the product design also to meet that particular requirement. Organization is by large corporations with and also using the ability of those corporations to produce at a lower cost, which we call economies of scale. And then but in the innovation economy, the main organization are by entrepreneurs, small scale and free agents. And therefore, we have a large number of people, businessmen, who are small businessmen, but who would operate in the economy to raise the total output of the country. The success factor is in the industrial economy, the labor quality, quantity, labor and the quantity, low cost, stability, and also control. But in the innovation economy, success factors are talent, speed, innovation, and flexibility, and so forth. So these are the two things that we have to keep in our mind. And if you want to increase the rate of economic growth in Sri Lanka, we will have to move into this innovation economy type economics planning and economic strategy. And that will help Sri Lanka to come out of the present economic downturn. And there are three partners in the invention and innovation nexus. These three partners are academia, we have the universities, and we have the research institutions, and we have the National Science Foundation. Then we have the industry on one side, then the government. These three parties will have to get together and they will have to come up with the final requirement for the economy, which we call the dynamics for competitiveness and regional development. And it will increase the ability of Sri Lanka to move back to its long-term economic growth path, where we anticipate to have an economic growth on an annual basis at about, say, 6.5% in the next 25-year time period. So three big sectors will have to get together and they will come up with the main thing. Then the country are interested in sustainable long-term development, because the Professor Tige had spoken very in detail about the sustainable development goals. But the most important requirement for Sri Lanka to have a sustained economic growth is to have new inventions and innovations. And also that inventions and innovations will have to be completed, and they should be made available to the other people to replicate. For example, if we have only one or two people who will invent and innovate, it is not sufficient for an economy to move upward. We need a critical pool of inventors and innovators, and that is the minimum number of inventors and innovators necessary for an economy to have a major influence. So that number has to be created. That should come from the reform on the education, reform and research facilities. The new things are created there. Then entrepreneurs will use that knowledge automatically in commercial use, and as a result, we will have a better economic growth. And in an organized economy, the new challenge is therefore created by the universities and research institutions, staffed with dedicated researchers. Their job is to do new research. And then the facilities afforded by such institutions to research on both fundamental and also applied research. We must have both these together, because the fundamental will come up with new ideas and the applied will come up with the application of those ideas into a new product or new service or even a new management system. Then we have to reward this creativity, but with sufficient incentives. And therefore, they should actually benefit the individual researchers, because that is what ultimately any human being would expect. He needs some kind of recognition, some kind of a benefit as arising from the new inventions and innovation that he has made. So the market will actually assign the values to each of these people if you allow the market system to categorize them. Then we have the research. Research should be done by all the three major areas of economic activities, that is agriculture, industry and services, because all the three areas of these activities in Sri Lanka today, our research and the scientific application have been far from what we actually expect. So they must, agriculture has to come up with new research activities, the industry has to come, and the services have to come. Then there should be a connection between these three areas, which we call intra relationship. Then within the area, and also then with the three areas which we call the interrelationships, and they must be promoted in order to build up sustainable research activity. Then if we have this type of intra and also interconnections among the or the research activities, we call it integrated approach to research and innovation, and that's the job that we have to do today. Then we have the new model. In the new model, the universities and research institutions, industrial towns are created so that the input provider, that is the researcher, and the output producer, entrepreneur, they are in the close proximity to each other. We have such industry town at Pitipana, the tech city, where the universities of Jijajanapura, Moratu and Colombo are to set up their faculties of technology there. And at the same time, private sector firms have been invited to come and set up their businesses there, so that both will get together, and the researchers will actually do research and come up with new inventions which are needed by industry, and industry will simply apply them. So we have to promote this type of a tech city program in order to get the best for Sri Lanka. So new industrial zone is created, and around selected university, this is how we done, and on a research institute with entrepreneurs of different sectors being present, allows industry to fund research, and universities and research institutions to sell their services to industry. It also creates a new local economy that supplies logistical services to both researchers and the entrepreneurs. So what would happen is both the industry and as well as the research institution, they should get together, and they should help Sri Lanka to come out of this present economic downturn on a sustained basis, because COVID-19 has crippled Sri Lanka's economy, and it has that crippling part has to be removed by the researchers and scientists who would come up with new inventions which have to be used by the entrepreneurs in commercial applications. And what we have to do is the new role for the institutions like National Science Foundation and also universities to promote inventions and connect them to industry. Then have affiliations with foreign research institutions and universities do collaborative research, because this is what Singapore and South Korea did in the initial phase of economic development. That was very successful because they got connected to universities like Oxford, Cambridge, MIT, Harvard, Chicago, and got the knowledge that had been developed in those institutions to their domestic economies, and that's how they became industrial powerhouses within a matter of, say, one generation. So introduce technology roadmap. Most important thing is to, with time-bound milestones, and be an active partner of the roadmap implementation process. That is the job of the National Science Foundation here. And a similar roadmap had been created by Vietnam and introduced in 2019, which would enable Vietnam to join the fourth industrial revolution by year 2030. Now, Sri Lanka is still in the second industrial revolution. And if we want to join the fourth industrial revolution, we have to leapfrog over the third industrial revolution. But it's difficult, but not impossible, if we have a proper roadmap implemented consistently by these institutions together with the government. That's the end of my presentation, and thank you very much for inviting me to share my thoughts on how Sri Lanka should revive its economy after the post-COVID pandemic. Thank you very much.
Thank you very much, Dr. Vijayawardhan, again, for staying well within the time allocated. I think the program is running a little short over time, so I will not take more than a minute or two to wrap up. I think has been a very well thought through session where Dr. Ari Ratna focused on the immediate challenges that Sri Lanka faces in terms of dealing with the third wave of COVID infections that we've seen. And he emphasized the 5 key factors, the need to build trust, to have reliable information and transparency, to try and mitigate the negative examples that people can pick up on, to address the quality of care, as well as to ensure that there is effective coordination. And of course, cross-cutting all of that is to ensure that there is equity and social justice in the recovery process, and to engage the community at large in ensuring that there is a more resilient response in this unexpected wave of infections that we are seeing. And from that on, Dr. Vijayawardhan touched on the economic priorities for Sri Lanka. As he very correctly mentioned, problems preceded the COVID-19 crisis, but to ensure that we build back better, we have to look to medium and long-term measures where productivity is what will drive growth. And again, the importance of technology and particularly introducing innovation into our systems, and the role of the universities and academia in driving that. I think that's a very good point at which to leave this session, because I believe the next session picks up on these issues in addressing education-related issues in Sri Lanka's response to COVID-19. So I will pass on to the organizers, and once again thank the two very eminent speakers, Dr. Ari Ratna and Dr. Vijayawardhan, for their very interesting presentations. Thank you very much.
Ladies and gentlemen, we are now ready to begin the panel discussion titled Education During the Pandemic. This discussion will be moderated by Dr. Chandra Ambuldenia, who will join us online. And there are 3 panelists in this discussion: Dr. Upali M. Sedara, who will also be joining online, and Mr. Janaka Jayalak and Professor Sampath Amaratunga. And I would like to cordially invite Mr. Jayalak and Professor Amaratunga to join us on stage for this discussion. To begin, I would like to call upon Professor Ranjit Senaratne, Chairman of NSF, to deliver the opening remarks.
Yeah, please. Good afternoon. We are going to have a plenary discussion on education, how education should be repositioned and reformed in order to build back better and to leverage this opportunity to leapfrog to development. To moderate this session, we have invited founder vice chancellor of UOLS University, Dr. Chandra Abuldenia. We can't find a better person to moderate this session than him, and he would be joining online. And we have really identified three eminent resource persons in the country who could do justice to this subject. To start with general education, Dr. Upali Sedar, Secretary to the State Ministry of Education Reforms, Open Universities and Distance Learning. He would be joining online. Then we get next the tertiary and vocational education during pandemic. This Mr. Janaka Jayalat, who has been also working with Dr. T.A.P. Siri, former Vice Chancellor, UNOSEC Tech. This Mr. Janaka is Acting Director General of the Tertiary Vocational Education Commission. And to do justice to higher education, none other than the chairman of University Grants Commission. He's a giant also, not only physically, but also in academic and intellectual terms. So we most cordially welcome Dr. Chandra Abuldenia to moderate this and invite Dr. Sedar, followed by Mr. Jayalat, and finally Professor Sampath Amaratunga to make their presentations and observations. And each person is given around 20 minutes. And I'm sure they are veterans, they are very experienced presenters, so they are very good time managers as well. So I did not say anything more about it. Thank you very much.
And now I would like to invite Dr. Abuldenia to give a brief introduction and thereafter moderate the discussion.
Thank you very much. It gives me a great pleasure to be with you today, and I welcome all the participants, including my great panelists who are real leaders in their own areas of work. I first want to thank Professor Ranjit Senaratne for inviting me today. And actually, today being a poet day, I would not have been on this if not for Professor Ranjit, who really made a special request for me to join this. I'm very happy to be with you, and I listened to a lot of the good work that has been done by many people in our country to sustain themselves during the COVID period. Now, this is the National Conference on COVID-19, Impact, Mitigation, Opportunities, and Building Resilience. Our panel discussion is about the education during pandemic. Now, in my opening remarks, I thought I will connect up with Professor Malik Piris, who made a very important erudition in his address to us on the first day, that was yesterday. And he talked a lot about viruses and also gave us a brilliant ideas about the future that we are going to experience. What he said is that we are living in an ever-changing world that, gives us a very uncertain future with the advent of new viruses that will be facing us. And he highlighted the damage we continue to inflict upon the environment. For example, ozone depletion, climate change, ocean acidification, chemical pollution, plastic pollution, hazardous waste, air pollution, biodiversity loss, land degradation, freshwater contamination, nitrogen and phosphorus loading. All this is destroying our environment, threatening our lives. Actually, these are severely disrupting, he said, the social foundation based on water, food, health, incomes, work, peace and justice, political voice, social equity, gender equity, housing, networks, energy, and our theme today, education. These are matters that are tugging between social foundation and the ecological ceiling that we have. The balancing of the safe and just space for humanity. I think Professor Malik Piris, made this point at his keynote speech. I think it connects very well with our discussion, panel discussion today. Why? Because I think what I want to draw your attention is not the obsolescence of our people in destroying nature, but how we have prepared ourselves for the future. Actually, a couple of years back, there was the Vistas of Prosperity and Splendor that gave us 10 key policies to achieving fourfold outcomes. Productive citizenry, a contented family, a disciplined and just society, and a prosperous nation. Now, these 10 key policies are also actually very important for us to know because they have solutions for all the fears that were expressed by Professor Malik Piris. And actually, our education is the solution for most of these things because really, if we bring up a generation of young youth who are ready to take up the country to the next level of innovation and technology development, as Professor Vijayawardhan just a little while ago mentioned that we have to jump from second industrial revolution to the fourth industrial revolution, which I totally endorse. It's a huge jump. And all this then can come from our education revolution. And today we have three giants in that area. I think Dr. Upali Sedara, who is really heading the discussion and the development of the strategies for general education in our country. He is the secretary to the State Ministry of Education Reforms, Open Universities and Distance Learning Promotion. And he will be speaking to us today on these policies, strategies, and other interventions to build a resilient general education system in the country. I don't want to take more time. I want to hand over stage to Dr. Sedara to continue with this presentation. Thank you.
Thank you very much, Ranjit. Let me share the presentation. We all know actually the topic given to us is going to me is actually policies and other interventions to build a resilient general education system in the country. As we all know, what is resilient means actually we need high level of performance despite the presence of stressful events and conditions. That is how resilience is spelled out. In other words, if you look at our present education system, not only in Sri Lanka, in general, across the country, across the world, has not demonstrated its resilience to face the COVID-19 unexpected pandemic. We all know that currently there are 1.8 billion children out of school due to this situation. So the UNESCO has been asking all countries, all human beings, educated, to look into the future of education, to look for new alternatives, because the UNESCO itself has no alternative to give anyone. The danger of spreading through schooling children due to general and usual normal child's way of life. We all know a child is a playful age In school, children, though we request them to maintain social distance, wear a mask, do the hand washing, all that, they are not accustomed to these kind of things. For a long years, they enjoyed their childhood by playing, running around, and all that. So we all know there's a potential danger that and difficulty of curtailing the student population to behave in that manner. This has been not only the case in Sri Lanka; it is the case. The so the this has made all countries to close the schools actually, because although Sri Lanka has managed to open up some schools at this stage, nearly 6,000 schools are now open, and we hear that time to time schools get closed here and there, and not all children are in school. So these problems have to be understood by us before we talk of any possible solutions. We know the first thing that damages is that we were heading to Sri Lanka as well as many other countries were heading to meet Sustainable Development Goal, particularly goal number 4, education, which has a cross-cutting topic actually that intervenes with many other things, poverty relation, poverty issues, health issues, all rest on educational achievement. So these are all becoming more difficult for us to achieve. There are several real challenges because when these kind of things happen, when children do not go to school regularly, the danger is actually who will drop out is the children of the marginal population. The other affluent classes will somehow manage to educate their children in one way or the other. But whereas in the marginal impoverished communities, it's very difficult for them to provide any means of to continue education. As a result, danger is there that world achieved high rate of literacy, particularly Sri Lanka had been one of the countries which has achieved very high rate of literacy. But we are now at the threshold that if this continues for a couple of years, the way that education now goes, we know that our literacy rates can fall. This is one of the very dangerous reasons why COVID-19 is so important to us, how we handle that. Why the marginal population face this problem? Because there is so much of social inequity in the system. School system itself has so much of disparity. Economic disparities are so wide. The regional disparities are very wide. All these things are reasons for marginal populations not to have access to the type of education that we try to offer now. So what has happened is the formal schooling, where people used to enroll and follow a timetable, get instructions from the teachers, use textbooks, sit for examinations. All these have become very difficult to put to practice. These are the real challenges. Then the lack of learning opportunities. If you look at again the affluent homes in Sri Lanka or anywhere else, they have all the necessary things to go for other types of alternative education. Say, for instance, the online education, which all universities and schools are now offering. Whereas in Sri Lanka, that is not reached. Every home does not reach online. We have about less than 40% participating in online learning. Even at university level, that is the case. But at least the university child can go somewhere else seeking that. Then also the illiterate parents. Most of the marginal population has illiterate parents. Parents who cannot really help a child at home to learn. But fortunately, in Sri Lankan situation, a little bit better because nowadays, out of our young parents who are bringing children to primary schools, particularly, we find that over 90% of our parents have had some amount of secondary education. So that we are lucky, Sri Lanka is lucky, at least, educated parent will know the value of education. But in general, most of the developing countries are faced with the threat of, uh, child falling to illiteracy, because many of those those countries, many of the parents are illiterate. Now, for instance, if you take our neighboring countries, India, Bangladesh, Pakistan, Nepal, that's the case. Sri Lanka is lucky because our parents, 90% of our parents have had some form of secondary education, and many of them have even at least passed GCO level. The other biggest constraint that we don't see is not the schooling, lack of socialization opportunities for the child. Education doesn't mean just learning content. Education offers a lot of socialization. We are talking about generic skills, soft skills for the industry, for the fourth industrial revolution, as well as for the 21st century. But under these present conditions under COVID-19, it is impossible for children, even in developed countries, to socialize. I know this situation very well in US. Now, United States have offered education, given a child either a choice to go to school or have register online. Many parents have opted to take online education, but children are really suffering of not having the opportunity to socialize with their friends. I know this very well. It is reported in recent literature in many places. So the socialization has become a serious threat to us in education. We may be able to teach, we may be able to give some knowledge, but that doesn't mean education. Education means not just giving knowledge and passing an exam. The particularly general education is a grooming process of grooming the child to be a good human being. That opportunity is totally lost under the present situation due to COVID-19. So these challenges are there. The Sri Lanka has taken several steps now, opening schools with limitations, imposing various conditions. Come to school one day or one day a week. Only grade 10 and 11 children come to school. Still, we have not been able to open the full school anywhere, other than small schools where less than 100 children, less than 200 children are there. Those places, except for grade 1 and 2, other classes are functioning. This is the new development in Sri Lanka, that small schools have the privilege of running the school, and particularly the big schools in the city are unable to open for general operations. Then we also have now the cabinet the other day approved e-Taksalam as the national platform for general education, which is very good. Nearly 3 million people use e-Taksalam one way or the other, but not necessarily different individuals. Loggings show about 3 million people log into the e-Taksalam, repeated logging by the same student maybe. But the thing is, we have only connectivity, internet connectivity to 40% of the homes. And all these homes are mostly in the urban settings. The lack of internet connectivity is a huge issue for any child to log in. Even though we have given whitelisting for certain things for e-Taksalam, still internet connectivity is very slow, not available in many places. So similarly, even internet connection is available, still learning cannot be done if you don't have the appropriate equipment or instrument for it. The laptop is the best, at least a tab or a smartphone, but the smartphones are not the ideal equipment for a child to do their studies, but at least something can be done. So then learning material for this online learning has not been properly designed. There are no standards set by any even at university level for the designing of learning material for this kind of situations. Each lecturer uses some kind of way of communicating with the children, and there is no standard methods and material produced for online learning other than e-Taksalam. Taxala, of course, has a professional class of designers. They had been working for a long time, and it has actually good material from grade 1 to grade 13 is covered on the Taxala. Yet accessibility is the issue. Then many schools use other alternatives like WhatsApp groups and other various types of virtual classrooms, but there is no one standard procedure, or there is no training given to any of these teachers or instructors how to design this material. So there is very poor learning, just some communication is there in the name of education. At the same time, many private tutors also offer online education for money. All these things are there. Then what we found is only about 30% to 40% gets online education in whichever the form that I described earlier. As a result, we decided that let's go for TV lessons, because TV is available at least nearly 90% of the homes in Sri Lanka. So the Guru Kedar program was something that we really organized in a hurry. Of course, finding adequate TV time to telecast lessons for all grades regularly was not possible. In March, we got 2 channels with the help of the Rupahini Corporation. All other private channels could not extend that support. And currently, we have only 1 channel left because even Rupahini Corporation was unable to give us 2 channels. Then to produce all the lessons for the grades, we wanted 6 studios to do a daily operation. Finding six studios was difficult for us. We found 2 studios with the one at NIE, one at Open University were the only thing available to us. Somehow we managed to get 6 studios done and 36 lesson minimum telecast every day. So this was done. But again, doing things in a rush without giving sufficient time to develop TV scripts, train the teachers to deliver online education or TV education, there were certain shortcomings. We know the shortcomings, but that was the best we could do at that time. Similarly, we tried with the radio lessons, as radio can reach many, but we failed in this exercise because radio time cannot be found anywhere. SLBC cannot spare any free time for this kind of thing because their radio time is fully booked for the whole year in many cases. So now we are negotiating with the provincial radio channels, who were Rajarata and all that, they have other radio channels. We are negotiating with them, but these are all just attempts that we are making. But however, it is necessary for us to develop a resilient system. The curriculum reforms that now we are formulating, we have taken serious note of this issue for the future, because as our previous spokesman also mentioned, there are serious environmental threats, and COVID is just maybe one result of that. All those deteriorations happen in the environment. So the curriculum reforms this time places heavy emphasis on these issues, the global phenomena, to combat these negative situations in the environment, all kinds of pollutions and things like that, to give more education than what we have given in the past to mitigate these situations. But now how to deliver education is the issue. Serious issue that general education faces is when the formal system has collapsed, what can we do? But we all know the most powerful system of learning in the world is the informal system, because that is how people learn in the past. So we have again come into a situation where these informal systems have to be strengthened in whichever the way possible to deliver more reasonable level of education to all. The good old systems, as well as now emerging system, is the home-based learning system where child is at home most of the time and there is without adults. How to motivate that child to be a learner, effective learner, being at home. So we are seriously looking at home-based learning systems anywhere where we can pick up some positive things to cultivate and prepare the new curriculum. The new curriculum has now concentrated more of developing self-learning curriculum because the child can learn a module without the help of the teacher if we produce it in such a way. But when we say that, even an institution like National Institute of Education, NIE, at Maharagama, there is no training for them to produce self-learning curriculum. So we have taken a lot of trouble to train them. And now we are in the process of producing self-learning material as much as possible in place of regular teacher taught textbooks. So the self-learning curricula will help children to learn at home with limited support from teachers, bringing teacher to school or bringing the child to school once a week or maybe twice a week as it permits, and provide feedback to the child, assign more work for the child, do some assessment of the child's work. That kind of new learning modality we are seriously evaluating and actually facilitating. This kind of curriculum is in the preparation, where teacher will be a facilitator, teacher will be a mentor to the child. The traditional role of the teacher to teach in the classroom will not happen if COVID persists for another few years. Rather than allowing a child to lapse to illiteracy, we rather prepare learning situations, enabling any child to read a small booklet, do certain things, work at home, and be able to maintain literacy and develop the cognitive skills as we usually expect. The self-assessment, we are trying to bring self-assessment, continuous assessment, and various forms of tests into this self-learning curriculum. We are already doing that. The many modules, even today, I came for this session while having one workshop on this new thinking. Then also we are exploring the possibility of giving one TV channel for each grade, which is impossible because in Sri Lanka, even getting one channel to deliver education is difficult. But there are certain new developments. If it works, we have some hope that we will be able to have maybe 20 dedicated channels for education. This is a possibility. But I cannot say when, but we are discussing these possibilities at the highest possible level to get this open up. Then similarly, we are working with the Telecommunication Authority and all other important players to provide internet connectivity to all schools as well as to all areas in Sri Lanka. Telecommunication Regulatory Authority is quite confident that by end of year 2023, entire Sri Lanka will have access to either fiber optic or G4 internet connectivity. If that happens, then of course that will give us a new hope that at least Itaksalawa can be extended to all homes, to all children, to a large extent than what we have now. We have Itaksalawa as well as NIE YouTube channel, which has many of these lessons from grade 1 to grade 13 available, but making it available to children at home or at school is the issue. Now, very soon this year, we have also decided to give smart televisions to small schools. This last budget has given us the provision to provide one smart TV to a school with less than 100 children and 2 smart TVs to schools from 100 to 200 students. If these things work, plus the solar energy panel funds have been allocated for solar energy panels to schools where there is no electricity to facilitate them. So we are making all these efforts to come up with some resilient system of education to offer uh, formal education to children. But you see, these are all only uh, efforts made by with good heart, with good intentions, but there is no one set example anywhere demonstrated in the world that that we can follow this model and it works. Even with these things, again I say that the socialization of the child will not be a major will be a major issue for all of us to address unless we are made home-based learning systems little bit broader to bring children of 2-3 homes together, as it is done right now in US. I know it is happening. And nearby 2-3 homes, children of the same grade meet once a week. That kind of models are emerging in the world. So Sri Lanka will also have to think about it because mobility, social mobility is there's a huge constraint on socialization. So this is where the education system right now stands, and our efforts in reforms also is taking stock. So I will not take more time since allocated time is up. So I will end here. Thank you very much.
Thank you very much, Upali. I think you made very valuable points about your resilience to COVID in this pandemic situation. Really, I can sum up what you mentioned. The actually you mentioned the key point that only 40% of the homes have online access, so there is a great difficulty about taking it on the internet. So you have to find alternative means to get through to the public with the learning for children. So what you have found alternatives are actually the TV. You have found Guru Gedara, and also you got the e-Taksala going, and you are also exploring the possibility of introducing a channel per grade of the of education. And then you also mentioned that currently you are running 36 lessons on the TV for the children. And also you are making, because I know that the radios are all packed up with all time, and which because they are all now running at sustainable levels, they don't get support very much. So basically, you are trying to make use of the regional channels to get the message across to the children. Then, of course, informal education is also another very important area where you are really trying to make use of. But I don't know how you're going to prepare curricula for informal education, because informal means informal, and it's a thing that you cannot really condition or prescribe. Probably we can discuss that as we go on. Then also we have the original concept of self-learning and also the student-centered learning coming into the picture. So you are now developing curricula for the student-centered curricula development, and a whole lot of things that what you mentioned right now are really it's a very challenging situation. I totally agree. Yesterday, Professor G.L. Pires really gave us some idea about what they have done, what you have done in the department, actually by adjusting the schools to taking the children to first the young children, giving them the education opportunity first. So school-based systems still continues in a controlled way, and classroom face-to-face is continuing in a very controlled way. I think that's where a lot of the answers happen. So let me now switch over to tertiary vocational education, which is actually my friend Mr. Janaka Jayalat, the acting director of the Tertiary Vocational Education Commission, is now prepared to give us the picture on TVEC. When I was chairman of TVEC, I think he was the director who was performing very well. And now he's acting director. I hope that he will give us a very good outline of the tertiary vocational education. Over to you, Janaka.
Thank you, Dr. Chandra Muldinia, our former chairman, and other panelists and participants who are joined here as well as virtually. And you all have seen sometimes this picture. This is a popular picture, global monitoring of school closure caused COVID-19. This is very updated one. This says some schools are partially open, some are completely closed due to COVID-19, and some are fully open, and some are on academic breaks. So in Sri Lanka also in the range of partially open situation. This the UNESCO statistics yesterday, and we have seen a lot of disturbances, interferences into the education, mostly the general education and entire education. And when we consider the vocational education, now we have in the first hit, we have tried to come up with some remedial situations, how to cope with the continuation of the studies. And we have explored the different opportunities. And we used social media, learning management systems, even YouTube. And we were able to come up only 50% of the coverage. So rest of the 50% left out from the system. It's the situation here due to various factors like access issues, technology, device, and know-how. All these factors were involved. And TVT is not like the academic or the general education. It is completely hands-on work. Mostly the lower levels, 80% hands-on the practical and 20% only the theory. And when when the industry changes, we have to change our curriculums, the learning methods, and all these things. And also TVT sector needs larger investment than other sectors. And for that, even a small change will cost heavy investment. So it's basically it's very difficult to transform this completely into an online system. And there we have come up with reskilling of workforce, maybe because the demand has changed. And if you see some of the initiatives at center level, so they have displayed some boards in their respective training institutions to take care of precautionary measures. And these are some kind of measures, but I know these are not fully functioning because the know-how is very less as well as in the society. And we have taken some local initiatives. As Dr. Seda said, we also started the TV lesson series with the Tertiary Vocational Education Commission and National Apprenticeship Industrial Training Authority and NIE. We were able to complete some lessons there. And we were trying to build the complementary e-material. So using the social media, websites, and some LMSs or learning management systems. And as the next step, we were trying to use the e-learning platforms to create a virtual learning environment to deliver the knowledge component. And thirdly, we are trying to use the blended learning model, which is a combination of online learning, face-to-face learning, maybe other kind of learning, all the learnings. And that is the model that is going to fit in technical vocational education training. And there we have faced a challenge of the trainer's capacity to develop the content and so on. And we were trying to get the lower groupings, like 1/3 of the practical sessions contained only 1/3 of the particular session, and we have to increase the number of sessions for practical work. And the blended learning, we were a little bit of success where they can refer their textbooks, some e-learning material, and doing some exercises, or maybe they can go for some models, and on-the-job training also kind of blended ingredient. And because of technology issues, the virtual reality is not heavily used here, but other countries, they are trying to use virtual reality. And we have come up with a roadmap for development of distance education in the Tibet sector. So as I said, we have been trying to develop blended learning, e-learning strategy with some leadership and planning. And we need to develop e-learning culture in TVT institutions, because they have never exposed to online learning systems. And we need to develop ICT facilities, access and connectivity, and trainer training, the capacity building, and some of the quality assurance of online learning and distance learning programs, which we have come up with the e-learning standard. And assessment, especially how to do the online assessment. We also trying to build online assessment system with the item banking, with maybe 10,000 questions with item bank already completed, and implement some supporting online courses for apprenticeship training, especially using the mobile phones. And when we saw the global, the regional initiative, the ILO has come up with 3 pillars to fight COVID-19, especially how to protect their workplaces and stimulating the economy and labor demand and supporting employment and incomes, how to keep the industry going. So it is very important to TVT sector, because we are totally depending on the industry. If there's no industry, we cannot get our students trained. And therefore, we have to go with industry. How resilient in the industry is also an important factor here. And some of the main challenges in TVT continuity we faced, because TVT systems fail responding quickly and adequately changing skills demand, because when industry or the services sector drops, there's a heavy disruption in TVT sector as well. And demand responsive training provision is also an important area, because now the demand is shifted and we have to adjust our demand, how to reimagine, reset and rework our entire Tibet system. And we had the difficulty of putting on the job placements for practical training, and accommodate previous number of students for practical sessions was a challenge. And due to transfer facilities and other access facilities, students were facing difficulties. And sector focus and the sector sets, skill sets for safety and health was changed, because every center we had to take special effort how to cope up with the safety or precautionary measures for the COVID-19. And that has risen the cost of training as well. And not only the challenges, but we have to see the opportunities when this, with this COVID-19. This has put us how to go for paperless situation. And we were able to put all our training packages online free of charge, get anybody to download. It's like 500 training packages online now. Anybody can download and see whether it's open to public, trainees and teachers. And training and use of digital platforms. And that is also, we were trying to deliver some courses on e-learning development and implementation for the trainers and develop how to develop some video-based materials in their training centers. Now some of the institutions are now doing developing training material. And we started YouTube channel, Facebook, different Facebook pages for different institutes. Even we managed to maintain one and using of some other social media. And also we try to encourage the peer learning, which is very important during this time. And especially the teaching and learning has moved because to classroom to the individual learning. So we had to change our learning paradigm, how to go with the individual learning. And also attractiveness increased due to the improved access and use of technology, because youth like to go with the technology. They got a chance to go through the technology-based material using devices. And in the way forward, we need to innovate the TVET sector, because TVET sector is I think the first technical college is something like 150 years old, Mardana Technical College. From that, it's changing according to the industry needs and kind of responsive. And we have to cover the social safety nets, because there are people who are extremely poor and cannot have the access to any of these devices or methods. And we have to take care of that segment as well. And online digital content is the huge challenge that will cost a lot to us. And we have to take a special initiative for content development. And also distance learning we have started, but it is not sufficient. You have to start virtual libraries and all other virtual resources to go with. And we have to give some incentives for online resources for vulnerable groups. There are persons with disabilities, marginalized groups, various other who don't have access and the methods to go with the education. And also we need to bring returning migrants, because there are our migrants who are returning. We have a special program to cater for those returning migrants. We are trying to give special training for them and show the skills passport. This is a very recent initiative from TVEC with the support of Employers Federation of Ceylon and International Labour Organization. This is a digital card which provides the online profile of a person, which contains qualification, experience, and other data. This is a digital card, can be scanned through the QR code. And now we started this skills passport from last year, July. And we have been issuing this and we can provide little bit of training, and with the experience they have gained through prior learning, we are issuing this skills passport thing. And recently we heard that some sectors like tourism sector, they came to a standstill, and for those employees, we were trying to give training to switch their jobs to different fields. For example, in tourism sector, we were trying to give a training for caregiver and other health-related occupations. So they will be employed with these new skill sets. That project we are working with Tourism Sector Skills Council, which is an initiative by the government to get the sector skills into the TVT sector. That also give rise for the better employment for the returning migrants, and as well as people who are locally working in the tourism, hotel and tourism sector. These are like a few initiatives we have taken to cope up with the pandemic situation. Thank you very much.
Thank you very much, Janaka, for giving us an outline of all the initiatives that you have taken on vocational education or vocational training in this pandemic situation, which is a very tough challenge because 70% of your work has to be done or training has to be done on at practical level, which is impossible in virtual reality or in in a factory flow because it's huge restrictions now. I totally understand your situation. Actually, you made a few very important points. Actually, you are working on. You have found the same difficulties that Upali found in the general education, and in your case, also the same factors really affected your development of the vocational education sector. So basically, you are also trying the TVs, blended learning. Then you mentioned about the OJT, that is on the job training difficulties actually. Also, you mentioned about the absence of virtual reality in our country to give the experience to the vocational learners. Then also the e-learning culture is very important. You have recognized that. And of course, that's for the 20%. And then the online assessments, you are making an item bank of thousands of items that will be very, very useful for the country. And then you are making use of the ILO regional opportunities that they are giving you. Also, you recognize very importantly the shift in demand, which is due to the technology shift in the country, and that you need to really now take your efforts into the areas, new areas that are opening up in technology for developing skills. So thank you very much and for giving us those important points. And of course, you know, you mentioned about the vulnerable groups and the returnees and the skills passport that you are using. These are all very good initiatives. And thank you very much for giving us all that thing. Now we have a giant in the system of education, that is our Professor Sampath Amartunga, a senior professor, heading the apex body, University Grants Commission, to talk to us about. He is at the real receiving end of all the higher educational troubles that he is facing because of the closure of universities and things like that. But I know he is making a giant effort to sustain higher education. So let me hand over you to the stage to talk about higher education. Thank you very much. Professor Sampath Amartunga, the floor is yours now.
Yes, thank you very much. Thank you, Dr. Ambuldeniya, Chairman, National Science Foundation, Chairman, Institute of Fundamental Studies, ladies and gentlemen. thank you so much inviting UGC to come and showcase how we are functioning today. So I have brought all data for the past. So the pandemic situation is not new for all of us. We are suffering, but at the same time, our performance are very much important. I will go to the first slide. This is all data from end of March to January 10th. So you can see we were at the stage of 0 before the pandemic. You can see the first dot comes from 0. This shows that how many classes, not only one place, in our system of higher education conducted online, it is 0. So technology usage at higher education, I would say when it is come to teaching, learning and examination, it was 0. So because of the pandemic only, now we are par with anybody. Because at the moment, after nearly 10 months' time, we have achieved a lot. Almost all the universities are conducting lessons, teaching, learning. Not only that, even examinations online today. So we have 16 national universities, 10 postgraduate institutes, 9 institutes, altogether 108 faculties. So more than 105 faculties are conducting exams today. 1 or 2 only want to have exams physically. So if I go back to 13th of March, His Excellency, the President, wanted to close down all universities within 24 hours. So I have asked everybody to go home. And especially, we have issued a notice to all students to vacate from hostels. So everybody went home within 24 hours. That is the way how we normally close universities. We all know 87, 88, 89, we have closed for 3 years. I was in the final year, just about to start final exams. We were waiting more than 3 years to come to the university to sit for 5 papers. So still in our biodata, so we mentioned 7 years starting date and the graduation 7 years. But His Excellency wanted somehow to take everybody online. The massive difficulty was the data problem for poor undergraduates. So we have 125,000 undergraduates, and this time we have increased more than 10,000. This will come around 11,000 very soon. The increase, a massive increase, not just 10%. It is more than 33% increase this time. From this 125,000, nearly 70,000 receive Mahapola or bursary. The ceiling of income of the family to receive this Mahapola or bursary is 500,000 rupees per annum. So monthly income is 44,000 simply. The ceiling is that, but the average is less than 20,000. So how can we expect poorest of poor to come online from morning to night to study their degrees? So I said, we can't do this with this problem. So His Excellency the President arranged all service providers in our country through TRC to provide data for free of charge for higher education. That is why we are running this program to this extent. Even today, it is free. If you come to UGC website, you don't need to pay for that. You can study, you can learn, you can get information. Like that, you can go to any university of our country for free of charge. So data is free whether you use Dialog or Mobitel or any other service, it is free. Then we started teaching. Then Jaffna University conducted a study. They are the first university to conduct a field study and told me nothing to worry. Only 47% are having computers, laptops or desktops at home, but 99% come online and listening for classes. So I asked again, how? Without laptops, without computers, how can they come online? They come by using their smartphones. So these are unbelievable changes as a country. No ragging, no rallies, no problem at all in the area of higher education today. So we have learned. Learn is the networking giant connecting all universities together, giving us a wonderful service. So you can see the blue part is the first wave. This pink color is the in-between first and the second wave. There is a declining trend in the pink color. The reason we have reopened universities, asked people to come. We conducted few lessons, but immediately the UGC have issued a circular that every subject must at least teach online 30%. 30% of the subject you have to teach online. It's a must. You have to do that. That is the minimum. Not because of anything, to be ready for the future. So now we can bring small groups to universities, but everybody requests the UGC, don't open for little period. Let us experience conducting examinations. So this change is happening all over the country. Everywhere, from Jaffna to Ruhuna, this is now happening. You can see in the green part, the peak is, if if you take participation, 1.2 million people. That is the weekly average, not the monthly. That is the 34th or 35th week, the average. You can see everybody come online, everybody. Now all classes are on YouTube. So they can listen from home, while traveling, from anywhere. So they listen to everything. And now we are conducting classes. The biggest thing is the instruments. So 9th of February, His Excellency the President is going to open a forum providing laptops for all. Do you believe this? We were waiting for this moment, and without giving the burden to the General Treasury, we had lot of discussions with People's Bank of Sri Lanka. They said they are going to invest for the whole project. So students need to pay nearly 500 to 600 rupees per month, only the interest. After the graduation, they can pay the capital. After the graduation. This is going to be a huge development. Then we are giving the guarantee for the computer for 4 years. So they don't need to worry. Then we can have lessons, classes, and examinations as well. Everything done. And already we have invested nearly 400 million rupees to top up learn the network. This is from World Bank funding. Of course, as a country, we have to return that money. So I have got this 400 million through a head project and distributed among all the universities, but we don't allow universities to freely purchase computers, anything. So we have a standing committee. The standing committee, they are going to study and invest infrastructure development on computer-based teaching and learning. That is the name of the standing committee. So they suggest all VCs to what to do, to purchase servers, increase bandwidth, like that. So that standing committee is taking care of that, because this is going to be the future of our higher education. So we can increase more because we don't need hostels. We don't need, any other classrooms, facilities. Increasing, actually, with this scenario, it's actually nothing. Now look at this. This is averages. Every week, Learn provide me this information. Every week, Learn, they provide me all information. And also they provide me 108 faculties, how they conduct their classes. 108. If anything is zero, I directly contact the dean of the faculty and I used to ask why. Why? And students, now they know there is something happening, so they also contact sometimes. And if the university asks students to come, they oppose today. They send emails and everybody online. I don't receive any petitions today from the postal mode. Now everything online. That is also good. Yes, I don't receive 10, 15 pages. So you can see developments. See, January, February, you can see. Before COVID, we were poor. Zero. No classes, no teaching, nothing. So it is real development. This is what week 2 and week 35 you can see. So look at this. Remote learning in higher education institutions, published by Asian Development Bank. Actually, we have helped ADB to do this survey. You can find this information. This is a publication. I have directly involved with collection of information. You can see remote learning by discipline, preference in higher education. Dental science, 96% they come online. Medicine, 95. Forget about medicine and engineering. Look at the last one. Arts and performing arts, 74%. 74%. So ADB told me after this study, Sri Lanka is the only country to ask ADB to publish this information. All other countries in the region requested ADB to not to publish their information online, teaching, education, and examinations. Everybody, I don't want to mention countries, giants are there. So we are now 100% online with various difficulties, especially our students, poor students, does not have proper instruments, but they come online. They never ever complain. No devices, no data, but they come online. They use simply a very cheap smartphones for education. Internet access, faculty and students, faculty internet connections at home. We have done everything. We have conducted in all universities more than 25 field studies. So I have requested all VCs to send their ground level data. They have developed documents and sent to me. All information now on UGC website in a separate button. Just clicking the button, you can access to all information. Everywhere the information is now freely available, what is happening. So you can see affordability of mobile data plan, quality of mobile network, student internet connection at home. You can see here, devices owned by faculty, devices provided to faculty, devices owned by students, smartphone, 91%. We are running our higher education with this poor instrument. We are doing now examinations. Since we don't have any technology to check whether the correct person is sending the answer script, most of the places what we do, we ask students to send the answer script, and for the every subject we are now conducting a small Viva voice meeting. That is simple, it's free data. We check whether really the person can handle questions. Then we verify marks. That's all. No technology, no big computers, no data, but things are smoothly running. So this is what I want to mention. I didn't take much time as you requested. But Thank you so much.
Thank you very much, Professor Amatunga. I think, you have given us a very bright picture of higher education that is really taking us to a different level of thinking about higher education, the things that we need to look at from a curriculum development point, curriculum change point, transforming of the pedagogical things and all that. I think will be very successful with the adoption of technology in the higher education system. In fact, you have impressed us with very salient information. How how you tried during the initial period and then transformed all the universities without an exception to adopt technology, and you're proving it with statistics which is publicly available, which the ADB has now accepted and published internationally. That gives us a huge recognition. I would believe that this brings us in the rankings in the internet, among the international rankings, that our university should our university system should find climbing the ladder as a in the ranks. So with all that, I think one of the other things is about the His Excellency's President's decision to give free data and also free laptops. You are getting from the, not free laptops actually, basically People's Bank investing in laptops so that the students can pay back after their learning period in the universities. I think that's a great thing, because that also gives the students the value of money that goes into their learning process and the investment that goes into the learning. All this time, everything was free. Nobody felt what was happening. I think that's very good. The other thing that really impressed me, Professor Sampath, is that you mentioned that there is no ragging and also there is no marchers, because of course marchers are prevented from the situation in the country, I think due to COVID. But I'm very happy to hear that students are learning from homes and wherever they are, and so there is no room for them to start ragging themselves. And so basically that will really help them in learning much more effectively than what the situation is in the universities if they really get back to start learning in the classroom situation. With the classroom situation, enable them to, resort to various kinds of ragging. But the point is, I think you take the credit for the changes that you have made effectively and focusing on the technology mode of learning instead of the classroom mode of learning, and taking and showing good results. I'm sure that you will be able to show the outcomes of the learning in terms of the results that the students are producing, plus when the students pass out, how the corporate sector really respond to the new students who are coming with the learning from the university system, because we have a huge challenge to fit into the new roles in the new workplace. And there are many new jobs that are waiting for new students to come in. And these are all challenges. I think, these are some of the huge challenges that we are facing in time to come, both in terms of vocational education and also the higher education. We have a clear tendency to adopt the right technologies to go in for the results that we are really looking for. As for the as for the general education, Dr. Pali Sedara, he's striving very hard from what he said. Actually, he has his efforts, I hope, will bring results. But definitely taking, unless we have television or radio to access the people right across the country, it will be very hard to get the students into the learning mode. I have been speaking to a lot of parents during this past couple of days in preparation for this panel discussion, how they are feeling, how they are taking up, how they are changing their attitudes towards the learning from home. I had different comments. There are good comments, there are bad comments. I think there is a mix of comments that we cannot either say online is good or online is bad. Whether the students are taking it well or students are taking it not so well. But one of the couple of things that really came out was that the teachers need training, teachers need planning, and then also the teachers really have to pass the information rapidly to the parents so that the parents can get the students organized well. But this doesn't apply in the case of higher education because those students are looking after their own situation by themselves, and mostly they now resort to a lot of self-learning as well. And that system is working pretty well. So, and the other thing is about the tertiary vocational education. How do we really get the hands-on, on-the-job experience to more people? Because the university system, as Professor Sampath mentioned, is maybe, I think Professor Sampath may correct me if I'm wrong, from 125,000 students right now, it may increase by about another 30%, right? But then that is only about maybe about 20% of the students. Then there are really about another 80% for us to account for, which has to come from the other learning sources. So are we really having the infrastructure, the strengths to really take education to those students, particularly in the vocational side? So I think the Tertiary Vocational Education Commission, in that respect, has a very, very challenging, very big job. And one of the things that I was expecting from all three really to present how they have connected with the policy of the country in terms of higher education, general education, as well as in tertiary vocational education. So leaving that aside, now let me actually thank all the speakers, our panelists, for spending their time with us. And also let's hand over the microphone to the National Science Foundation to continue with the next plenary sessions. Thank you very much, my panelists, for being here today and spending your time. Thank you.
Thank you very much, Dr. Chandra Buldenia, the moderator, and the speakers. As you know, education is one of the worst affected sectors of the economy, with far-reaching implications across practically all sectors of the economy, and also to build back better and to leverage the pandemic to leapfrog to development. Again, we need education. So we cannot really exaggerate the importance of education. And I request these resource persons to help us with their recommendations for policy intervention required in this connection, and we'll be cooperating with you in this regard. And thank you very much.
Thank you, sir. Thank you, sir. And thank you again, Dr. Ambuldenia, for chairing the previous panel discussion. Since we are behind the schedule, I would invite the participants to collect their tea and refreshments from the lobby area and join with us for the policy dialogue in another 5 minutes' time. Thank you. Dear ladies and gentlemen, welcome to the final session of the National Conference on COVID-19. I'm pleased to announce the opening of the policy dialogue on building a robust and resilient community and economy. May I please invite the following distinguished panelists on stage. Former Deputy Governor of the Central Bank of Sri Lanka and Adjunct Faculty of Asian Institute of Technology, Thailand, Dr. W.A. Wijewardena. He will be joining with us online. Deputy Director General, PHS2, Ministry of Health, Sri Lanka, Dr. Susi Pereira. Executive Director of the Institute of Policy Studies and the Head of its Macroeconomic Research, Dr. Dushni Virakon. Chief Economist, Ceylon Chamber of Commerce, Mr. Shiran Fernando. And Director, Preparedness Planning, Disaster Management Center, Sri Lanka, Mr. Sunil Jayavira. He too will be joining with us online. The policy dialogue will host theme chair presentations by our following valued session chairs and members of the conference steering committee. representative of Southeast Asia to the WHO's Special Envoy to coordinate COVID-19 responses, Dr. Palitha Bekon, Professor Emeritus of Sociology, University of Colombo, Emeritus Professor Siri Hettige, Professor Emeritus and former head of Department of Zoology, University of Colombo, Emeritus Professor Sarat Kotagama, Chair and Professor of Disaster Risk Management, University of Huddersfield, UK, Professor Dilanthi Amaratunga, whom shall be joining us online. Professor of Psychiatry, School of Medicine, Keele University, United Kingdom, Professor Atula Sumatipala. Senior Professor, University of Moratuwa, Professor Ajit Dialvis. Director and Chairman of the Postgraduate Institute of Management, University of Sri Jayawardenepura, Professor Ajanta S. Dharmasiri. And Executive Director and Head of Research, Verite Research Sri Lanka, Dr. Nishan Dimel. He too will be joining with us online. The policy dialogue will be moderated by Chairman of NSF, Professor Ranjit Senaratne, and Chair and Professor of Disaster Risk Management, University of Huddersfield, United Kingdom, Professor Dilanthi Amaratunga. I would now like to invite Professor Ranjit Senaratne to deliver the welcome address and officially commence the policy dialogue.
Good afternoon. We have come to the most crucially important session of our two-day program that's on policy dialogue. As we stated at the outset, we are going to produce a policy brief based on recommendations emanating from the deliberations of the sessions we had in the last 2 days. And this policy brief will be handed over to the relevant authorities for necessary action, and we would, as a team, extend our full support and cooperation in its process of implementation. My task was eased by Ms. Sanduni, so I would not mention the names, but we have really galaxy of distinguished panelists and also members of a steering committee who have been providing direction and a great deal of intellectual inputs to this event in the past 5 to 6 months. So on behalf of the National Science Foundation, I wish to extend a most warm and cordial welcome to our distinguished panelists and my friends and colleagues, distinguished steering committee members who are also the team leaders of these sessions. Could I have my presentation? I prepared a brief. Now, just first slide, please, first one. Move forward. Yes. The objective of this session is to produce, as I mentioned, a policy brief, including actionable and pragmatic, short-term, including low-hanging fruits, and medium-term interventions to build back better and to leverage the current pandemic to leapfrog to robust and resilient development. The approach, as stressed by several speakers, including Professor Malik, keynote speaker, it will be a transdisciplinary approach in a holistic manner, cutting across disciplinary and sectoral boundaries. So it will be a truly holistic approach through a transdisciplinary response. Next one. So the key elements, but not exclusive, obviously health will top the agenda, including
mental health and nutrition, because we know health is very closely associated with nutrition and also mental health. You cannot talk about health without reference to mental health and nutrition. Then education, the preceding session, general, vocational, and higher education, the one of the most impacted sectors of the economy due to COVID. Then economy, business and finance, environment, digital infrastructure, connectivity. We saw the difficulties, the inequalities in access to digital infrastructure. And then to leapfrog to development, obviously we need, this was stressed by also Dr. Vijayawardena during his presentation. But our goal, the research, innovation, and ethics, we see some serious erosion in ethical values, so this is very important. And then governance, the leadership at national level, institutional level, regional level, even at village level, governance. So next one. So the tagline, this is what Professor Shanti Mendis also underlined. Nobody is safe until and unless everybody is safe. Therefore, interventions are needed to address economic and social inequalities for building a safe community and a country in a hyper-connected world, in a globalized environment which is hyper-connected. So the ground rules of this have been already communicated members. Just to refresh, the competent distinguished panelists will be given 5 minutes each to present their ideas, thoughts by way of policy interventions, how we could really build back better and build a robust and resilient economy. So Professor Dr. Vijayawardena, Dr. Susi Pereira, Dr. Dushni Veerakorn, Mr. Siran Fernando, and Mr. Sunil Jayavira. And then next one, our steering committee chairpersons. I don't need to mention them. So they will each make 3-minute presentation. And our panelists and also steering committee members, I think, have been provided with the reports of rapporteurs and feedback from these sessions that may also help them to include what emanated in the past 2 days, yesterday and today, in the course of discussions. With these brief introductory observations, I call upon Dr. W. Vijayawardena, former Deputy Governor of Central Bank, to make his verbal intervention.
Thanks, Ranjit Senaratne. I was actually assigned to look at the credit picture that has emerged as a result of this COVID-19 pandemic in Sri Lanka. Because of the underperformance of all the economic activities, all types of economic enterprises in Sri Lanka, from big to small, are now undergoing a huge liquidity crisis where they don't have enough cash to make the payments. Some of the big companies actually started the operations by voluntarily cutting down their salaries and unnecessary expenditure programs. And as a result, they were able to save some of the money with them in order to make the essential payments. But of course, the largely affected sectors in this particular scenario had been the micro, small, medium, and enterprises. And these enterprises, because they don't have enough cash base with them, they were dependent on daily intake of their cash through their sales. And as a result, once the economic system did not perform well, they didn't receive any of the cash payments, but of course their payments had to be made. This has been specifically relevant to these small and medium enterprises in Sri Lanka, because those enterprises had actually employed 1 to 10 people in their employment, and they were not able to pay salaries. And there are certain sections in the country where they didn't have enough money, because I have collected some information about the hardships that these people started undergoing. Some of the small enterprises, they are actually in between the small and micro enterprises, which is known as this MESA businesses, like the sideway fish stall traders, then the people who are running these tailoring shops, vegetable shops, and so forth. And they had a huge problem because they didn't get money, because the sales were down, and as a result, they didn't get money. But they had to make the payments by way of rent, by way of other payment they had to make. And the banking sector didn't come to their rescue. And whenever, because they went to banks to get money, because of the absence of a track record in past borrowing, and also the necessity for providing the necessary collateral to the banks, they were rejected. And they were supported by the informal money lenders in the country. And I can just give some examples which I have collected. There was a fish trader in my area. He had got the he has to buy fish from the Paliagoda fish market, and he has to pay cash, because he is not given fish on credit. But of course, when he supplies fish to hospitals and hotels in the area, he has to supply them on credit, and he gets money at the end of the month. And when he tried to get a bank loan to cover up his cash flow, he was not rejected, and he didn't have any money. But he was supported by the informal money lenders, and their system is very efficient and very speedy. And there was no any application to be filled, and there was no any necessity for him to provide any collateral, and he was simply given money, and he had been given the ₹500,000 by one of these informal money lenders. But he has to repay it within 100 days, and interest rate per month is 10%. And when you compound it, it comes to 120% per annum, and every day he has to repay. And at the end of the period, if he hasn't repaid any of the amount, that will be compounded and he will be added to a new one. And there was no any other alternative for these people. Therefore, they borrowed from the village, the informal money lenders at these high interest rates. And finally, what happened was these people got into huge debt. The fish trader who had started with ₹500,000, when I spoke to him about 2 months after he had got his first loan, he had been indebted to this informal money lender to the extent of ₹1.5 million. And finally, he had to close down his business, and now he's out of business now. Now, these are a huge problem, because if when the system tries to save the big corporations and ignores the small people, those people will simply go out of business. And we'll have to be mindful of the fact that in Sri Lanka, out of our total GDP, about 70% is produced by these micro, small, and medium type of enterprises. And what happens is, when they leave the place, we don't have any other thing. So this is my intervention here, and we'll have to have a system of supporting these people. So thank you very much.
Thank you very much, Dr. Vijayawardhan. Then the Dr. Susi Pereira. You could use the mic there. Well, if you like, you can come here.
Yeah, okay. What I'd like to mention is that when it comes to the health system, in Sri Lanka, we have a unified health system largely provided by the government sector. And the health policies are actually spelled out by the Ministry of Health, and it is uh, uh, implemented through the provincial so forth system, but it is a partially decentralized system, and therefore we have the benefit of reaching out across the country the health policies that we can, and it was useful in this situation when it comes to the COVID response. The whole country had to respond in a kind of a unified way. And this also means that the preventive and the public health system, which is strong, was able to respond in this situation. And in this situation, we must recognize the community health services, which has been developed over a long period. But if you take the recent past, in the last 15 to 20 years, gradually the emphasis on the preventive health system has been taken over by the efforts that we have put into the specialized services. So you can see in this situation, when we had to respond in the pandemic, and especially when we are wanting to reach out to the sensitivities of the people who had health concerns and the differential behaviors that were happening in health seeking behaviors, where people were actually meant to go to the large hospitals, we actually did not have the primary care system that well, which could respond in a situation like this. Although we had a public health, community health system, the primary frontline curative care system, which we had planned before the epidemic for a longer time, could not really properly take off the ground. And in fact, even the hotlines that were established and so forth, really, I mean, we can understand the importance of hotlines. Even now, we are trying to shape up a different hotline where we can respond better to the people closer to home, especially when we are thinking of different strategies where we want quarantine and isolation more to be at home, but can it be supervised? Who will be there for them to address their concerns? So these are the things, because more and more patients are being accommodated and the hospital curative system is being overwhelmed and it is becoming difficult. So actually in our system, we have a strong public health system, but in this pandemic response, what we see is a kind of a medical model which has been kind of superseded. So we would like in this situation see a more public health oriented system, the strong system that we have being able to encompass all the curative sector, a family doctor system such as system, which would be something more attuned to addressing the needs of today. Now, when it comes to working women, we must understand that the general systems things also apply, but in especially the working women, the large amount who have been working abroad, who are having to come back, and their concerns, the repatriation, the reintegration into the health system, these are things that we need to be more concerned with, how we do it, and then they will, once the borders are open, they will have to go back, or do they want to go back? All these things, whether there can be employment found, these are all going to be social and health concerns which cannot be dissociated and only encountered only through a health system. So the well-founded public health system, some of the lessons that we have need to also trickle into the curative system, like more performance-based data, which would really, we can identify whether we have actually not looked at essential other non-COVID requirements of our community. So these are areas that we need to focus on.
Thank you very much, Dr. Sujibera. Then Dr. Dusne Virakon.
Thank you, Chair. I was asked to touch on the equity issues of providing online education as well as the impacts of COVID that might disproportionately impact women and the elderly. These are not areas of research that I engage in, so I'll be drawing on what my colleagues have done at the IPS. And it was interesting to listen to the last panel discussion on the provision of online education, because I think the equity impacts are obvious when we look at the statistics. And Sri Lanka's labor force survey tells us that only 23% of Sri Lankan households have a laptop computer or a desktop computer, that only about 30% of Sri Lankan households actually use internet. So when the provision of education is provided online, clearly there's going to be disadvantages. And some of the policy solutions to that, the immediate solutions that can be provided is to look at using the TV channels. 88% of Sri Lankan households have access to a television. I think we have started on it, but perhaps a little late. But these are successful methods that countries like Brazil have used by providing dedicated education channels, TV channels that students can tune into. So that is a short-term solution, but in the more medium to long term, I think the equity gaps, Sri Lanka has done well in bridging some of these education equity gaps. But for us to be able to latch on to the technology and the innovation, the kinds of things that Dr. Vijayawardena spoke in the previous session, we need to not only roll out IT infrastructure throughout the country, but also enable our students to be able to use that technology. Again, coming back to low levels of science, technology, maths, and IT education in this country. On the second question of the impacts on women, I think COVID is simply sharpening pre-existing conditions that were there. Sri Lanka's gender parity with regards to health outcomes and education, I think is reasonably good, but we do dismally when it comes to encouraging women into the labor force at 35% and less than half of male labor force participation rates. There's something seriously wrong, because equity issues for women will not really work out unless women are empowered through productive employment. So to me, there are no quick fixes. I think we need to focus on the long term, and that a lot of research and a lot of policy work has been going on about how women should be encouraged to enter the labor market, provision of better childcare facilities, provision of better transport facilities, better jobs, better pay, etc. So I think that COVID-19 has perhaps overburdened women with regards to household duties, etc. But no short-term, I don't see short-term solutions. I can only see long-term solutions. And the same is true of the elderly. Again, we are doing poorly on providing social protection. Only about 30% of the Sri Lankan population is covered by any form of social protection. And that too, mostly public sector employees and those formal sector employees in the private sector. And that leaves a whole chunk of people who are in the informal sector without any kind of social safety nets. And as an aging population, again, concerns are that we are not providing adequate protection for that segment of elderly who are vulnerable to these kinds of shocks. And COVID-19 is not a one-off. I think there will be recurrent episodes of similar pandemics in the future. So upscaling social protection programs and expanding them, I think that again is a critical policy measure that we need to focus on. Thank you.
Thank you very much, Dr. Dusni Virapon. Mr. Siran Fernando.
Thank you, Chair, and thank you for this invitation to talk a bit about the private sector and on this policy dialogue as well. So I think what the private sector and I will also talk about, I guess, reforms, trade, and tech and innovation as well. So what the private sector generally looks for in policy and in government is a few things, largely around stability and I think policy continuity and opportunities for really growth and investment. COVID sort of, I think, puts a lot of these under the microscope as well. But if you look at a lot of aspects on the policy side, especially when it comes to taxation and things like that, we really did see continuity, at least from the government's point of view. Not too much tinkering with the recent budget, even though there could have been, inclinations to do that to simply recover some of the revenue shortfalls that have been there because of COVID. So that foundation is sort of there for the private sector to really now look forward, plan ahead, maybe 3 to 5 years as well, make use of the low interest rate environment. There's a lot of, as Dr. Vijayavardhan was mentioning, a lot of liquidity in the market as well. Really absorbing some of this liquidity and fueling it for productive investments, because that's how we're really going to sustain and manage some of our debt dynamics as well. And also some of the growth opportunities that are being created through COVID and really getting now growth back on track. Last year, maybe we would have contracted about 4 to 5%. This year, we might, show a V-shaped recovery, but almost get back to what maybe about 4 or 5% this year. But really, how can we sustain that 5 to 6%? And really, how can the private sector be that driver of growth? I think those are some of the critical areas that really need to be looked at, and can policy really facilitate that? COVID has also, I think, really reshaped some of the way we've looked at traditional models. So if you look at something that was traditionally held, which was a tea auction, which was an outcry system overnight, and this has been a proposal that the chamber and so many others have been putting for years to really go into an e-auction. But overnight, this had to move ahead, and it was done. Despite all the obstacles, still there is a lot of teething issues around it, but it's working and people have adopted to it. We've also seen another on the trade side, especially on the customs. A lot of it has to be, a lot of things done manually. WAF clerks having to go. You have to go from, from one counter to the other to clear some of the goods. Some of these processes have now gone online. Can we really now, and that's something that the private sector has been really talking about for so long and requesting government, but can we really continue some of these measures without going back once, the pandemic sort of gets a bit more manageable? And business models, we talked about, salary cuts and things like that, but also really post-cutting the fat, as it were. How can we really look at innovation in a different way? Especially the apparel industry, which was catering to, is very much dependent on a niche segment, very much dependent on 5, 6 global brands always doing well, really augmenting themselves to be able to cater to the personal protective equipment environment. Over 800 million exports in 2020 alone, just catering to that, reorienting the existing business models. Maybe that won't really continue into the next year, depending on how the outbreaks and global outbreaks go. But it shows the resilience and the ability, especially from some of the organizations who are world class, to really change around as well. And of course, adopting to some of the import restrictions. I think that was a key aspect for the private sector to also come across, because a lot of the, I mean, from April onwards, you've had every month almost a gazette coming out, some items, going to a ban list, some going into credit list. So private sector really responded to that, and this overall trend towards manufacturing things locally. I think that's a debate in itself, but really, focusing private sector really meeting that demand. So what are some of the low-hanging fruits in this environment? I think some, especially on the tech and innovation, one thing is on the digital ID, really being able to implement it in the next 12 months, getting that across, because that will really transform the way we pay taxes to the way even welfare payments are made. Let me just limit those comments to that, and maybe we can take it in the Q&A.
Thank you very much, Mr. Fernando. Mr. Sunil Jayavira joining online. Sunil Jayavira?
Yes. I'm online. Ah.
Please, it's your turn.
Yeah. Greetings to everyone who is joining this conference from all over the world. At the onset, I wish to thank NSF and the organizing committee for inviting me for join this interdisciplinary policy dialogue panel discussion, which is conducted at a time when the entire world is fighting to survive from the deadly global pandemic COVID-19. I was asked to the brief discussion on pandemic and epidemics preparedness and currently embedded with the existing disaster risk reduction plan. I would say that epidemic and pandemic preparedness is not new to Sri Lanka as a country. Sri Lanka has been exposed to various kind of disasters, and biological hazard have been given due consideration. The Sri Lanka Disaster Management Act number 13 of 2005, section 25, specifically refers to the pandemic, and it is considered as a disaster. So all legal provisions made in the Act for disaster in general are applicable for epidemics and pandemic as well. As the responsible authority, the Disaster Management Center is focused in coordinating disaster risk management activities based on decentralized mechanism. So even during biological hazard, similar to other disasters, the 25 District Disaster Management Coordination Unit get actively involved in DRM at subnational level in any type of disaster, be it natural, man-made, or biological. Disaster Management Center objective is reach to the last mile and last man. Furthermore, with the help of the Health Ministry officials, DMC had set out the operating procedure to be followed by relevant institutions and stakeholders before and after pandemic and epidemics, and especially at safety center, which are set up during disasters. I should mention at this moment that during the first outbreak of the COVID-19 in Sri Lanka last year, it was the call center of DMC which was converted as the National COVID-19 Center, and the hotline number 117 was used as the emergency hotline or helpline. Also, to prepare for the northeast monsoon and threats imposed by cyclones such as Amphan and Gori, and also the northeast monsoon, DMC worked very closely with senior officers of the Health Ministry and had several online discussions built in advance. Jointly, we developed awareness materials and safety centers guidelines, which was distributed among the general public in disaster-prone areas with the help of the disaster management coordinating units. COVID-19 pandemic outbreaks has become an eye-opener for all of us in different sectors and institutions. From DMC point of view, I wish to say as an organization, we have done considerable amount of preparedness work at ground level to face challenges posed by epidemic and pandemics. However, with the lesson learned from the COVID-19 pandemic, I feel further improvement could be done with national disaster risk reduction level preparedness planning. Thinking about the future, as a nation, we need to be more equipped in terms of facing disaster of this nature. As we all know, COVID-19 will not be the only deadly and devastating pandemic to affect the entire world, but there will be similar biological hazards that could emerge in the future. Pandemic hazard, unlike certain other natural and man-made disasters, does not have a limitation in creating the impact. These cause severe social and economic implications, which have a long-lasting impact. So Sri Lanka need to be more focused on certain key aspects in facing this biological hazard in the future. Some of them are to be well equipped with advanced technology and reach in the ground level. Continue to closely work with the health authority to improve the technical knowledge of officers involved in managing biological hazard. Create continuous awareness among the public using public media such as TV, social media, press and radio. I'd like to say that a commonly known fact is that the Sri Lanka public tend to easily forget about past disasters and challenges faced. So it is important to keep the public reminded about the importance of following health guidelines at all times, even during disaster, which help in being prepared for future epidemic and pandemic. To have clearly defined SOP in handling biological, to be jointly prepared with the health authority and based on the decentralized disaster risk management approach. Consideration to be given in the revised in the legal provisions in specific acts to exactly identify the responsibility of relevant government authority, relevant prevention, mitigation, preparedness, and for biological hazard. Thank you very much.
Okay, thank you very much. During this first round, our panelists responded to the questions that we have directed to them. Now the Professor Dilanti Amaratunga joining from Huddersfield. Now she would take over, and Professor Dilanti, yes, now they responded to our questions. Now they must be having their own ideas what interventions should be made. I would invite you to really continue this discussion with the panelists before we invite the steering committee chairpersons to make the observations. Over to Professor Dilanti.
Yeah, thank you very much, Ranjit. I think good afternoon, everybody. And I'm joining, as Ranjit said, online. And I think I really need to congratulate NSF for pulling this really important event together and bringing in all these distinguished speakers and panelists representing various disciplines around the same table, which is actually remarkable. So I suppose, as Ranjit said, thank you very much for the panelists for shedding light on the key questions that were posted to them, covering important aspects. So I just want to sort of summarize some key points, or to sort of give the floor back to you in terms of actually maybe saying a few words about how do you see actually the interconnectivity between economy, the social justice, equity, the disasters, and so on and so forth. So the floor is yours, actually. So perhaps if I sort of go back to Shiran for his brief comments on having these, the importance of having these links. Shiran, over to you. Is that okay?
Thanks, Professor Dilanti. So yeah, as you mentioned, I think everything in that aspect is really connected together. So one of the things I was referring to just as my time was coming to an end is if you have systems in place, things like, for example, a digital ID in place as well, that really connects all the citizens together in one thing. We've seen that in India as well through the Aadhaar system, connecting people who don't really have bank accounts, who might not really get access to finance as well. And through that system, really be able to even do welfare transfers. So we saw how quickly they were able to mobilize and send across funds, cash transfers, things like that. Whereas in Sri Lanka, it took a bit more while. It had to go through the provincial systems, and there was a lot of those issues as well. So putting those foundations in place, if we had already done that, we would have been able to really uplift the social systems and also ensure that the right people got the right level of funding, or the right level of support at the end. So I think those are some of the crucial parts, and that also then goes into the equity side of it, ensuring people who really are in need really would be able to get it. And yeah. Across the board as well, if you look at some of the other few game changers or a few things that we really need, it's not too grand. On the agricultural side, we of course know a lot about the post-harvest loss and things like that, and how from the farmer to the retail side, how much of the produce is lost simply because there is not enough, storage facilities. So there it lies an opportunity for cold chain storage. Some of the bigger players have it, some of the others don't. But in the end, the farmer loses out as well because a lot of their produce is lost. So how can there be real, good investment? There are a lot of interested parties who are interested in investing, partnering with the private sector, but that really hasn't really taken off. And right now, even with the vaccine and things like that, there might be even opportunities on that aspect as well with the cold chain storage. So even those can be really game changers where we increase the value add simply through the infrastructure really being put in place. So those are just two my interventions.
Yeah, I think that is actually really, really important point, Shiran. I suppose I think, it is really, Dushni actually provided, just to sort of summarize the key points, Dushni actually provided a really good summary about the social and economic inequalities around online education and so on and so forth. Again, a really, really important point. And then getting back to Dr. Susi Pereira, she actually sort of talked about the health sector, the informal sector, the role of women, and so on and so forth. So it is really good to see this entirely kind of a interdisciplinary view. And also, I shouldn't forget about the intervention from the Disaster Management Center. I think this is actually quite new in the Sri Lankan context, because until the COVID, I think we saw the health sector and the disaster sector working, I suppose, with so much of links, rather than me saying with no links. Maybe there was a distance between the two systems. So I think it is really good to see that everybody is actually coming together, and there's and Disaster Management Center is actually taking efforts to link up with the health sector and see this as a kind of a very much a kind of a integrated disaster situation rather than natural hazards or biological hazards. So I think everything needs to be very much linked, and I really appreciate what Mr. Jaivira provided as input to this discussion, because they have a kind of a major role to play in transferring the national level initiatives to the local level. So Mr. Jaivira, I suppose, I'm aware that you are actually trying to take these messages to the local level, aren't you, in terms of promoting local level preparedness planning. Do you want to say a few words about that, Mr. Jaivira?
Yes, Professor, thank you. Presently, we are national level preparedness plan we are done in the district level, and this thing now we are preparing disaster risk reduction, the integrated approach in the local level. This year, we are planning, according to the Sendai framework, we are planning to local level preparedness planning, integrating the epidemic and climate change included.
Yeah, I think that is really good to see that, because that joint thinking is very important when we actually go forward, because again, these risks are very much joint, systematic, and also it creates cascading impacts. I think those are the key terms that I want to emphasize. Then again, but as my co-moderator Ranjit said, you all have actually the opportunity to provide more input in terms of your written submissions. Please get them in as input towards the final policy paper. So I think thank you very much for the panelists and for your time and effort and all your very valuable contributions. Over to you, Ranjit.
Thank you very much, Tilanti. Before I return to our session chairs, could I just could you give you a couple of minutes, because you responded to our questions. Now, Dr. Vijayawardena and the other distinguished panelists may have their own perceptions. They may have certain ideas by way of policy interventions. Would you like to capture this opportunity and share your thoughts quickly about which you are not discussed, but you may be having their ideas, suggestions, thoughts as to the way forward? Could I speak to Dr. Vijayawardena? Dr. Vijayawardena?
Yeah, thanks, Professor Ranjit Senaratna. What I would like to say at this point is that the COVID-19 pandemic is not typical to Sri Lanka. It's a global pandemic. And as a result, we will have to find solutions, economic, social, and all these solutions in collaboration with the global community. And if we try to do it in isolation in Sri Lanka, that would not be a success. It was proven when the Sri Lanka was short of these vaccines. India and China had now come forward to donate some of the vaccines that they have produced to Sri Lanka, but that's not sufficient. What it means is that not only in the area of vaccine administration, the all other areas, economic integrity and also the market integrity, market access, we have to have a collaborative team effort to rescue the entire world out of this COVID-19 pandemic. So this is something which in our policy making we'll have to keep in our mind. We should not try to do it in isolation within this island of Sri Lanka. We have to do it with global community, taking every advantage that is being offered to us and the opportunity that is offered to us by the global community. And in that respect, I think we may be able to come out of this particular pandemic globally as a team. So thank you very much.
Okay, thank you. Is Dr. Dusni, any additional observations you would like to make by way of policy interventions?
Just very broadly, Professor Senathan, I think one issue continuing on the economic recovery plus the equity, how do we arrive at that balance? I think we've had several rounds of conversations with similar policy communities in the region as well, and there are concerns that countries will be in such a rush to record positive growth that the sustainability of that growth or the equity of that growth process might get pushed back. And I think for Sri Lanka also we need to be watchful that I mean, while we understand that growth needs to revive, and that's the first signal that investors will look for as an indicator of recovery. If we push ahead too much with, let's say, public infrastructure sort of driven growth as we did a decade or two ago, then the equity outcomes of that growth process can be problematic. When you look at the Sri Lanka's poverty indicators during 2006 to 2013, for instance, you see inequality picking up, and then that is because you have a very capital intensive growth process coming in. So at the critical time like COVID, when there have been significant socioeconomic impacts on the poor, on the vulnerable, we must ensure that we don't lose sight of that as we try to push economic recovery process through. Thank you.
Thank you very much, Dr. Dusni. Dr. Susi, any further observations by way of policy intervention?
Yeah, I think when we say policy, the politics and power go hand in hand with policy. So we've had a strong leadership into this, into the health response, and that's at the highest level. Now, what we want is, because there will be waves of experiencing in this number of cases going up and down and the transmission being controlled. There, the relaxation that we allowed, I think Dr. Vijayawardhan also mentioned about the different categories of people who need to be involved in, engaged in their economic activities. So actually, the health sector responded in a way to give the necessary guidelines and so forth in how economic activities could take place. This had to be balanced out in the amount of relaxation that is given. So there were sometimes challenging situations where this relaxation, the guidelines that we give, did not harmonize that well with certain other relaxations that are wanted by the society. More social functions, more gatherings. It could be due to education, tuition classes, so forth, like that. So there are sometimes these balances that need to be considered, the proper timing of these relaxations. So it's the harmonizing the public health, the technical part with the other the economic engagements are also important. So this is something that will be a challenge, and we need to see how this kind of policy decisions can be made in a timely way.
Okay, thank you very much, Dr. C. Okay, we will wind up with our panelists. And as
Ranjit, can I just say that's one online question? Can I just raise that, Ranjit? Is that okay?
Yeah, please go ahead.
Yeah, okay. So the question is actually for any of the panelists. I think any of you can actually respond. The question is all about to say that it was highlighted that the importance of different organizations and institutions working together to overcome the social, economical, and other challenges. So in this context, this delegate want to know what do you think is the role of science, technology, and research to bring them together? Can one of you respond, if you don't mind?
Dr. Vijayawardhan?
Yeah, if I just mentioned, my own view on this, this National Science Foundation in Sri Lanka, if we confine it to Sri Lanka's case, is the apex body in scientific research in the country, which is responsible for the research being done by all other organizations connected to research. So what I have suggested to Professor Ranjit Senaratne is that NSF should come up with a roadmap of coordinating the science work within Sri Lanka as well as with other institutions outside the country, and bring about a desirable result for Sri Lanka to build up its scientific knowledge base, because presently without the support of some outside good organization, it has become very difficult for us to do it on our own. Now, one good example is this University of Sri Jawadanapura, which has been supported by Oxford University in its work on the dengue as well as on the CKD research. And it is this team of researchers who are now supporting the healthcare service in the country in testing these various types of viruses and coronaviruses and coming up with various new strains of viruses. So it wouldn't have been difficult for USJ to do it had it not got this support from Oxford University. So my suggestion to Dr. Professor Ranjit Senaratne is that NSF should take the leadership in Sri Lanka. It has to build up the a coherent scientific team working in all the universities, all the research institutions, and also have affiliations with other scientists in other organizations, and come up with a roadmap to take Sri Lanka out of the present economic as well as social downturn.
Thank you very much, Dr. Jwadar, and also thanks, Dilanti, for that very important question. So now we NSF has added responsibility, and we will meet with relevant scientists and take that idea forward. Okay, now we will, for the opportunity for our steering committee members, we'll start with this health track, and is 3 minutes slot available, Professor Jai Singh.
Thank you very much, sir. So over the next 3 to 4 minutes, I'll try to summarize. During the past 2 days, we've covered a lot of ground, and just to put things in context, globally, it's just 1 year since COVID hit us. Globally, we've got about 2 million deaths. So USA has 25 million cases with 429,000. Sri Lanka also, it's gone up during the past few weeks, and it's 60,000 with 290 deaths. So if you look at the global scene, we see how this epidemic spreads very fast, affecting mainly the elderly and also those with other diseases to result in death. But we heard the importance of asymptomatic carriers or asymptomatic patients, and the fact that the infection spreads even before you get the symptoms. And that's something which is unusual for an infection, a viral infection, which is spreading so fast. The impact has been, is seen in different sectors. We know of that it affects the poor globally as well as locally. And there is direct impact due to the illness, plus a lot of indirect impact. So you have domestic violence, suicides, disruption to education, and so on. We heard experiences from other countries on all these, the range of effects it has. So each country has its own unique pattern. Sri Lanka has performed very well in this, and partly because the health system was prepared for disasters. We heard how the disaster management unit had been prepared for disasters of this nature. And also, as Dr. Susi Perra mentioned, the strength of the preventive sector, which was able to respond rapidly. And yesterday we heard of the report, the Lowy report from Australia, ranking Sri Lanka as in number 10 globally on the rate, on the success of responding to the pandemic. But we know that the second wave has hit us, and that's affecting us. It has affected our regular services. Surgeries and management of chronic diseases have got affected, and mental health issues have come up. I'm sure Prof. Subutpala will describe that. Then in relation to education, school closures, disruption to education, even though we've had the O-level as well as the A-level exams, those are remarkable success stories. The economy has had a severe impact, and we heard Dr. Vijayawardena describing how it has affected especially the informal sector, and also we heard about the medium and micro businesses being affected to a large extent. So the responses from Sri Lanka also, we've seen the health sector changing over to telemedicine, but there were a lot of disruption of services. We had schools shifting to IT-based classes, and we had social support to complement the issues related to loss of income, nothing compared to $2,000 per month in Canada per person. But anyway, we've tried our best. We curtailed the spread by lockdowns, quarantine, masks, distancing, and institutional care for all, initially including for contacts. And these have stark differences with some of the countries which have failed. So we have been able to curtail or crush the first wave by these measures. Now we are hoping for the vaccine, but remember there is vaccine nationalism, and we heard how the affluent countries who often preach to us on human rights, they're hoarding the vaccine. Nevertheless, the ministry has worked out the distribution, and today it was circulated, or yesterday I think it was circulated, on how they are going to implement the vaccination program. But we heard the dangers of relying on the vaccine because it's mutating at a rate. And very soon it's going to mutate and start spreading despite the vaccine. And we don't know the effectiveness of the vaccine because we are giving it in an injection form, but the infection is spreading on the mucosa. We also discussed about the recovery from COVID-19, and I think this is the area which was touched on by Dr. Vijayawardhan, and it's crucial for us. The 5 pillars enunciated by the UN: health, social protection, economic recovery, macroeconomic policies, and social cohesion. So we've got to think of all these 5 pillars in our recovery. This is the opportunity for transformative change because there's no option. This is the opportunity we have. And we should use this as an opportunity for a more equitable, resilient, and sustainable future. And we also heard about the International Science Council and the UN system, which has identified 25 priority areas and 5 science strategies for recovery. And that should be the goal for how NSF should align its policies. Because if we align to those strategies as well as those goals, NSF, I think, would be able to secure funding so that NSF can really fund projects which will enable science to get into our policies. Thank you very much.
Thank you, Professor Saroj Jaisingh. Professor Siri Hettige.
I was chairing the section entitled Society. We had about 8 papers, but finally only 7 papers were presented. And these papers dealt with various issues connected to the social situation in the country. I'm not going to summarize these papers, but I'm going to make key points that came out of these presentations from a policy point of view. Now, I will start with the first paper that was presented, and I'll discuss in the order that these papers were presented. The first one dealt with much discussed issue about education, access to education, in particular, within the school system. Now, as you all know, the closing down of the schools made it really very difficult for people who did not have access to online education, particularly within the public system. And of course, we listened to various presentations on this outside this particular session as well. Now, the point is that how do you respond? because many people say that, well, there can be a similar situation in the future, and then of course we should be ready with an approach that is really workable. So the point that this particular paper presenter made was that we need to really make the transition from teacher-centric learning to student-centric learning. In other words, we have to move away from spoon feeding to, let's say, self-learning. In other words, how do you equip the children, certainly not primary school children, but certainly children who are in higher grades, to engage in self-learning, have access to material and so on and so forth. So some kind of a shift in the way that we conduct teaching in the schools, and of course it applies also to university education, and of course it is far easier probably to do that kind of thing of course, communication, is in the hands of communicators, the media institutions, and various other opinion makers, and so on. So the point is that how do you really communicate the risk involved? Now, of course, there had been difficulties, and I think I'm not going to really discuss all aspects of this problem, but the main point that is coming out of this presentation is that there is an important element of risk that has to be communicated in order to even have a positive impact of communication on the public health efforts that are aiming at certain objectives, like, for instance, reduce infections, and then of course reduce fatalities. Now, the point that this particular paper makes is that if you make the whole problem of vulnerability, whole problem of let's say, what this paper says is about the risk to life. How risky is it to be exposed to COVID? The danger. Now, I think if you communicate that effectively and forcefully, people become more responsive to the threat, because people really don't want to run that kind of a risk to their lives, you see. And so that's an important thing, and people become more cautious in their behavior, and so on and so forth. And then the pandemic and related social and economic conditions have impacted very, very differently across society. As we all know that certain groups are far more affected than the others, and so on. And of course, in this particular paper that deals with one particular sector in the economy, that is the smallholder sector. Now, so the point there is that these people who are self-employed, who have a stable income because they are engaged in these small holding related activities. So the point is that even there, because they are dependent on monetary income, because they have not been able to really engage in their activities, like not only produce but also to sell and transport and so on and so forth, their income has been either lost or have been drastically reduced, exposing them to another problem, and that is starvation. I mean, not starvation, actually food security. Food security has been threatened because these are people who produce for the market a commodity which is really not something like producing food, and so on. So, and then of course, loss of income has been a major problem in terms of having access to vital services, like, for instance, their children's education, healthcare, transport, and so on and so forth. So the point is that they have become vulnerable, not necessarily due to the pandemic, because in these rural areas, they didn't have a direct threat from the COVID pandemic at that time, but nevertheless, they have been indirectly affected by the pandemic because of this. And then moving on to another paper about the digital divide. I think that basically argues that the people who did not have access to, let's say, ICT facilities not just in rural areas, but in other parts of the country as well. They didn't have really access to education. And therefore their children have been, somehow deprived of education. And I mean, this is really talking about the period when the schools were, not functioning, and that they didn't have any other, way of accessing other forms of education. And then, of course, there were other issues connected to that as well. I mean, some of these issues were discussed by other presenters during the course of this particular conference. And then moving into, university education, how did undergraduates, cope with the problem of having access to, classroom teaching, not having access to classroom teaching? I think we had this presentation by the UGC chairman also, but I think here the paper presenter brings out, certain other issues which are not necessarily related to access to, teaching, university teaching. The point is that, that this extra stress that has been generated in the minds of young people, because they were not used to, getting education through this kind of remote, means. And then, of course, increased workload, and so forth. And then the language issue, because much of the material might not necessarily be available in the language that they are familiar with, and therefore, they have not been able to really have easy access to the education and so on. Of course, on top of that, of course, ICT facilities were not so, commonly available at the beginning. As you know, this paper was done based on work done in the first few months, of the pandemic. And the next paper dealt with another issue, which is, I think, as important, and that is, how does it affect, wider society?
Professor, how many minutes do you need?
I need maybe 1 more minute.
Oh, please, please.
Yeah, can I have 1 more minute? Because yeah, sure. So the point is that, society is not monolithic. Society has so many divisions. And of course, as you know, in Sri Lanka, we have these ethnic and religious divisions, which is not new and it's long-standing, and it just continues. Now, this pandemic really made these problems, far more acute. And I don't have to explain that to you. And this, of course, has, is a kind of a double-edged sword. On the one hand, it really makes public health interventions much less effective. It goes very, very, very well into the problem. And then the other thing is that then, of course, you also have the problem, impacting on, the whole society, creating so much tension, creating so much uncertainty, creating so much hatred, and so on and so forth. So the point is that, it has become, so complex, as a result. And I think this should have been addressed, from the day one. And finally, I come to what I presented, and it's basically the nexus between the pandemic and the sustainable development goals. I mean, the point is that it is again, relationship is symbiotic. You see, the pandemic itself is a product of, so many things that are not related to health. It's very much related to so many other issues. I don't have to explain this to this particular audience. So you have on the one hand, the larger context, creating this problem. Larger context creating this problem. It did not fall from the heavens. And then, of course, the solution also has to be found within the nexus between these two. In other words, sustainable development is the path towards creating a socio-economic and, an ecological context that would really prevent, such calamities in the future. So in other words, the public health issue and that is this pandemic and sustainable development, they are two sides of the same coin. So if you cannot address one without really addressing the others. So therefore, the UN recently, not recently, many months ago, basically said, look, this is the path, not only out of this pandemic, but also out of the larger problem that we are confronted with as a world community. So I think that's the issue that I discussed in my presentation. Thank you very much. I just took one point from each presentation, and I might probably have done justice to a lot of the complexities involved, but nevertheless, I think I basically wanted to flag these very critical points that came out of these 7 presentations. Thank you very much.
Thank you very much, Professor Siri Hettige. Now, as Professor Dilanti mentioned, now we would be writing to you, communicating with you, the panelists, as well as chairpersons of those tracks to send us in writing. So during this time given, if you could really give us the salient points and then follow up with your written submission, then we would be able to capture your ideas and to be incorporated the policy brief. So if you could give your salient points, especially bio policy intervention, which could be supplemented and complemented with your written submission, for which we will give you a few days. Okay. Then Emeritus Professor Sarath Kotagawa.
Thank you, Professor Anjit. I will take your cue and not waste your time. We had only 6 papers, despite the fact that the environment causes all these problems. And that itself is a good response to realize that we are far away from where we should be going. The first one was really to clearly demonstrate that we were living in a polluted world. And we should now realize that we don't want to live in that polluted world, which was to do with the air quality. Kandy and Colombo very clearly had shown that as immediately everything ceased to work, the air cleared up and we had a very healthy environment and a good air quality, which apparently has gone back to AITs. So I think we are happy living in an unhealthy environment, so we shouldn't be talking about SDGs and all of these things. The next was even more contentious, bit of a crucial subject on water and virus. The conclusion policy is that adopting a precautionary principle is the way to go forward and no irrational decisions to be taken. I will leave you to think about what it is. We had a third paper which was looking at a new direction because of what we are doing related to something else, which is the CKD and the chemical use for productions. Biofertilizers were very clearly demonstrated in the last year's research by the Institute of Fundamental Studies to be better fertilizer than the chemical fertilizer that we are using. So, though it is not directly related to the pandemic, but we are all looking for higher production, I think that might be a good way to go forward. The other 3 were to do with the built environment, and all of them were very interesting because they were all somewhat theoretical, but looking into response and reflections of what we are doing now and how we can change it for the future. One was to do directly with decentralized open areas against centralized open areas. Should we have big parks or many small parks? So it's like my own discipline, many small or one large. That is how we look at in wildlife all the time. So now wildlife has crept into the city. So many small parks or one big park was the consensus in that. It didn't conclude, but that was the idea. The second on the built environment was another new name, green cleaning requirements for buildings and structures. The structure should either have 90-degree corners, that was what I posed to that child and she responded rightly, or should have a curvature end. So when you next build, be green corners. So it was all about the problems with the railings, with steps, and almost 18 issues of safety and green cleaning. That is the new term now. And the last one was, again, a completely new future city based on the COVID impacts and what it does in a city in the different areas. So it was a very innovative and very interesting document, which is very much looked forward for when it comes in the large paper format. Again, the city of tomorrow is not the city of what we have today, despite the fact that we are going to have more than 70% of the people living in cities by 2030, 2050. So that was a very innovative paper. I think a good paper to be incorporated into policies for the future. So thank you very much.
Thank you very much, Professor Sarat Kodagama. Now he dealt with both natural and built environment. Professor Ajit Ali, have you got anything to supplement? No, he did justice to both natural and built. Okay, right. Then we have Professor Diranti. Yes, now as the track chair resilience, any observations to be made or have you already made? I'm sure you have a few points.
Yes, Ranjit, I have already actually shared the written submission with the NSF colleagues. But just to sort of very briefly to summarize without taking much of the time, there were actually 13 submissions in this area, which is quite a good response, we thought. And again, a lot of papers were actually built around some of the joint research initiatives that are going on at the moment between various universities, especially ourselves, University of Maratua, University of Colombo, and Ministry of Health also, for example. So some of the key points that I can highlight from the papers that were presented actually include, I suppose, the importance to extend the preparedness for pandemics and epidemics beyond the health sector. That was actually highlighted very, very strongly. For example, there's a need to pave the way for unified legal framework that allows for a multi-sectoral approach in this regard. And also, again, that was supplemented by Shiran at the panel, the promoting of the private sector participation in preparedness for biological hazards. I think that is vital. So the emphasis of multi-stakeholder approach was highlighted. And also the other point that I want to emphasize is as a policy point is the need to strengthen the early warning systems for pandemics and epidemics, and also which actually requires a very successful integration of biological hazards into disaster risk reduction efforts in the country. Again, I think Mr. Jaivira highlighted the point that the sole responsibility of disaster management in the country is rested within the Disaster Management Council, which is actually headed by the president, but is implemented by the Disaster Management Center. So in that sense, incorporating health elements into the country's disaster management strategies are really important, and it was highlighted through the presentations. And also another point that was emphasized very strongly during this session is to take COVID-19 as a kind of a hazard that is creating systematic risk. We know it is there are sort of integrated approaches, and also it actually create an impact beyond the health sector. It can dismantle and dismantle the functioning of other sectors and causing disruption to the entire system. We know how it has worked, not only in Sri Lanka, in across the globe. So in that sense, it is really important to take into consideration the cascading socioeconomic impacts of pandemics such as COVID. So that was highlighted through one of the papers. And then the other point is all about the systematic governance. It was highlighted that the systematic governance is really important in managing pandemics such as COVID-19. For example, it was highlighted that there are sort of perhaps policy challenges to overcome such a systematic nature of pandemic risk. So in that sense, I think there need to be efforts on maybe restructuring the governance arrangements. And also, again, linking with what Professor Sarath Gottagama also said about the environment, there was a really good presentation which looked into the waste management associated with the COVID pandemic in Sri Lanka. So it identified, based on primary research, the use of improper waste management practices, such as burning, for example. So and also that paper calls for assessing the effectiveness of the guidelines issued by the Sri Lankan government in waste management. So without actually taking much time, and the final point that came out from this session is the role of the local government. As we know, local government is the facing authority for public. So in that sense, I think it is fair to say that the presenter emphasized that the local governments have played a crucial role during COVID pandemic in Sri Lanka, particularly in areas such as coordination of provision of essential food, and disinfecting public areas and so on and so forth. So, but having said that, they highlighted that they have actually faced several challenges. Particularly, one important point, again linking with the governance, is that the conflict that there can be conflicts between their role and the other administrative systems which are in operation at the local level. So there's a very clear guidance there as a policy intervention to make it very clear what the roles of different stakeholders are at the local level. Otherwise, it is very, very easy for very important tasks to be sort of going through the net, to slip through the net and not to get the attention. So in that sense, I think that is the other key point that I want to emphasize. Having said that, this is actually a very brief summary that came through the resilience team. And of course, the written feedback has already been sent to NSF. So I'm hoping that we will be able to capture some of these key points via the policy paper. And also, several of these papers have been invited to be updated as chapters in the monograph that you're planning to do, Ranjit. So the future is bright in that sense. Thank you very much.
Okay, thank you very much, Chiranti. Then Professor Atula Subutipala.
Ranjit, although I have been sort of the chair of mental health and well-being, I have been asked to talk about research and ethics. So I'm going to make my reflections concentrating on both these aspects. And starting with the mental health and well-being, and we saw, we heard about particularly highlighting the issues of mental health, stigma, burnout, particularly the frontline staff, and also there was reference to suicidal ideations among university students. There, I picked up one ethical issue because we didn't hear what happened to these people when they were having suicidal ideations, whether they had the service provision. But I'm happy to tell you that I'm wearing another hat as the director of Institute of Research and Development. And we just heard yesterday that we received some WHO funding to follow up a large cohort of people from this affected 60%. So we will be in a position to tell you in 1 year's time about the long-standing neuropsychological as well as mental health consequences. After hearing the session on education, my usual malignant optimism actually reached sky high, Ranjit, because hearing what sort of achievements we have had. So therefore, may I propose to take up as a policy to talk beyond health, talking about PCRs, number of tests, but talk about the aspects of economic, social, education sectors, what they have achieved, taking on the impact of COVID-19, and how we mitigated and grabbed the opportunity for a truly new normal era, building on the resilience of Sri Lankan nation, inherited through 30 years of war, civil war, armed uprisings, and adversities such as tsunami. Specifically commenting on and focusing on the research and ethics, I want to talk about one or two things. In terms of research volume and the spread, which we saw during the conference was really encouraging because it had a wide spread of social, economic, in all domains. The quality of the presentations, of course, can be improved. Research should not be here and now, and as I mentioned, it has to carry on, continue, particularly as a longitudinal data collection. It is also encouraging to hear that now people are talking more about research, ordinary public, I mean. That's encouraging facility, encouraging development. I just want to comment on one of the questions Dr. Vijayawardhan also highlighted. And the ironical fact is 90% of research arise from 10% of the world population. We have quantified it and published particularly the medical research. And when it came to COVID, even that research knowledge was not there. And that's why we need more and more research. And as again highlighted by the Oxford collaboration, we have to have international collaborations, and all the research I am involved is actually credit goes to King's College London and Keele. And again, we saw through this conference how the expatriates could be engaged and international collaborations are harnessed through this. So Ranjit, I was talking about for many years, again, through the loss integrating expatriates. You have taken it and launched. And this conference is a classic local demonstration how these collaborations, particularly the expatriates who are in top positions. We heard from Professor Malik Piris, we heard from Dirante, we heard from many people, how that active collaboration should be harnessed for enhancing the research. Finally, when it comes to ethics, I think I notice a huge gap in terms of ethical issues being discussed, cross-cutting. I'm talking about the broad ethical issues, not just research ethics, including media ethics and everything. And to me, ethics is the other side of the coin of research, and particularly when it comes to intervention research, therapeutic misconception and philanthropic misconceptions are two major issues, particularly considering parachute research. So my strong recommendation to propagate the idea that ethics is an integral part of research. Finally, in terms of policy, I think community involvement and engagement has to be as a forerunner, as Dr. Vinyarya Ratna very correctly pointed out. Finally, as a nation, we have not failed. We have done well, but we can do much better. Therefore, we need to seriously reposition our overall communication strategy to combat misinformation and disinformation, and to disseminate how we have done as a nation, how we have grabbed the opportunity, the situation to re-emerge as a strong nation. Thank you, Ranjit.
Thank you very much, Professor Sudipala. Then Professor Ajanta Dharmasuri, please.
Thank you very much, Professor Ranjit Senaratne, for the opportunity. Let me confine my thought sharing to two cross-cutting themes. One is governance, second one is supply chain management. In the governance category, there were 3 papers presented, and the first paper was dealing with centralization, decentralization debate. And it recommended that you need to have the centralized decision making, but implementation has to be decentralized. And it echoes very well with what the Minister of Education said yesterday, where you need to decentralize, where the school principals and the regional directors should take the relevant decisions with regard to those regions. And the second paper was more to do with Inland Revenue Department, how the tax response to a pandemic, how the frequency of policy changes might affect the parties who are paying taxes. So the responsiveness from the inland revenue side, how they need to mitigate the impact with regard to the affected community who are paying taxes. So that was beautifully dealt with in that paper. And the third paper was dealing more with the intellectual property rights. Say during a planetary pandemic, there'll be a lot of innovations coming. So what is the policy? How can we make public aware that the process available for them to get the due registration? Particularly, they were talking about trade-related intellectual properties, TRIPS, and so on and so forth. So in summing up, my reflection is that even though I would have happier to see more governance in those papers, there was some element of governance. And my co-chair, Dr. Lloyd Fernando, was a little concerned about it was not real governance, but at least some governance was reflected. But it should have been more dealt with proactiveness, productivity, and proficiency with regard to taking policy-related decisions and moving ahead. And in moving to my second cross-cutting track, which is the supply chain, it was more responsive, where there were 6 papers. They were all really good. So they were talking about variety of aspects with regard to supply chain. So the first one dealt with the delivery of the medicines during a lockdown using the postal service, and the challenges they encountered and how they overcame and how it became a continuous improvement, Kaizen type of an approach, where the feedback of the affected people were useful in order to fine-tune and improve the way they were delivering the medicines. And now they say they are well geared and well oiled in future to have the postal service more effectively utilized to send the medicines to the related patients. And the second paper was dealing with the apparel sector related supply chain, the disruption created by some suppliers not being available, and how they resolved in terms of developing alternate suppliers and shifting from heavy China focus to other market focus in terms of having even local focus, having more emphasis on the local suppliers. That was very well dealt with in that paper. And the third paper was more to do with agriculture-based supply chain, where say, for example, the presenter from Vavuniya, he was referring to the agricultural production in Vavuniya and the needed links to the economic centers and then to the market in Colombo. And that is very pertinent, where we saw a couple of months ago where the farmers in Dambulla were complaining that their harvest is perished without any purpose, where in Colombo the skyrocketing of the prices of the vegetables and fruits. So there's a clear acute need of a food-related supply chain, and which is also dealt with, Chairman, with another paper where some similarity was there, where the need to have solid food-related supply chain in Sri Lanka, that is very comprehensively dealt with. And then the final paper was an overarching thing about the need to have supply chain related issues solved in Sri Lanka, and they were referring to the distribution of the vaccine that is coming, and of course now it came and it will be coming. So the supply chain is going to be a very hot topic in the future, because the management has to deal with supply chain related issues. Otherwise, the centralized decisions will not be enacted, implemented, executed without a robust supply chain in many areas. So these were the interesting thoughts. And then my final recommendation is to NSF chairman is to take management more seriously, because management is a cross-cutting, overarching issue to all disciplines. It is not a profession, but a practice which encompasses all professionals. So being Postgraduate Institute of Management, we are very happy to be part of the process. And then we would look forward to have more emphasis on management, because they say there are no good or bad countries, there are no good or bad institutions, only well-managed institutions and ill-managed institutions, and well-managed countries and ill-managed countries. I hope we will be a well-managed country. Thank you.
Thank you very much, Professor Ajahn Dharmasiri. Now we come to the sector on economy. As you know, this is a sector of great importance. And Dr. Nishant, the male joining online, I think given this outstanding importance, Dr. Nishant, if you need more time, please feel free to take few minutes more, and they look very fresh. They don't look exhausted. We have been looking forward to economics. You know, the chief guest speak last. Here, Dr. Nishan.
Thank you, Professor Ranjit. I have planned to try and finish in 3 minutes. I don't want to take too much time. But thank you for introducing and pointing out the importance of the economics papers. I think we had two sets of 3 excellent papers. So we had 3 papers on macroeconomy and trade, and especially focusing on the trade issues. And we had 3 papers focusing on food and agricultural issues. So let me just go through the main findings and introduce the 6 papers, and I'll try to speak through each one in 30 seconds. The first paper was by Attukorala and Marusuvitana from Australian National University and the Advocata Institute. The study's findings make a strong case for designing Sri Lanka's industrialization and trade policies based on lessons learned from its past. What it found was that current trade protection practices may be ignoring an all-important economic reality about industrialization and manufacturing. That is, in today's global context, manufacturing is a global product-sharing process. It is not a process that is simply limited to what happens within a country. And therefore, the paper argues that a move towards protectionism could be damaging to Sri Lanka's industrial production and economic prospects as we move forward. The second paper by Dunu Singha from Colombo University is a study that attempts to measure the impact of COVID-19 on Sri Lankan exports. It uses the fact that there's a shock to Sri Lanka's GDP as well as a shock in the GDP of trading partners, and uses that in a standard model to estimate the potential impact. The main scenario that it analyzed suggests that Sri Lanka's exports in 2021 may still not catch up to the pre-COVID year of 2019, and that the apparel and fish products will be particularly affected more than other sectors with regard to exports. The third paper in the trade side was by Abesinghe and Arangala from Verite Research. And they set out to measure the precise opportunities that were created for the apparel sector from what is known as US-China decoupling. That is the diversification of US imports away from China, which began from 2015 onwards. First, the paper applies a clear method of measuring decoupling. It looks at 217 product categories and finds that 37 products show signs of decoupling from China and therefore creating opportunities for other countries. And of that, 21 products had real potential for Sri Lanka. It also found that 9 of those products had very high potential and 7 had medium potential. But most of the currently high quantity exports of Sri Lanka are not the high or medium potential products. So Sri Lanka would do well to think of switching more towards the medium and high potential product categories in the apparel sector, especially if it wants to benefit from US-China decoupling. Basically, all 3 papers in this trade section of economics took on the very hard task of measuring the consequences that would result from 3 things. 1, from policies that are enacted in Sri Lanka to protect trade and imports. 2, from the wake of COVID-19 impact all over the world and the consequences to GDP growth locally and globally. And 3, on the opportunities that emerge for Sri Lanka for particular product categories to improve its exports due to US-China decoupling. The second set of papers, and there were also 3, were related in phase to food and agriculture. The first was Nayantara Weeraheva and Roy, 3 authors, from the Postgraduate Institute of Agriculture and Department of Agricultural Economics at the University of Perdenia. It looked at the impact of import taxes imposed on food products, especially in the wake of COVID-19, on 2 factors. One is the higher expenditure incurred on the food basket by ordinary people. and the resulting lower level of nutrition that people actually suffered due to that. And it came up with specific calculations and consequences on expenditure and nutrition, arguing that ultimately these higher taxes on imports had an impact on the cost of living and the health, especially related to nutrition of the population. The second paper was by Saibzda and Verhev, also from the Postgraduate Institute of Agriculture and Department of Agricultural Economics at Perbina University. It looked at the impact on global and South Asian welfare from the impact of food-related taxes on imports and exports, and looked especially at the policy changes in India and Pakistan and how that affected the countries outside and how it affected countries in South Asia, and gave specific ways of understanding the external consequences of policies that were both internal and external. The last paper was by Sharma Hirumuthugoda, Pereira, and Rajapaksa, so 4 authors, Department of Animal Science and Faculty of Agriculture, University of Ruhuna, and also from the National Aquatic Resources Research and Development Agency, NARA. It looked at a specific set of farmers. Ornamental fish was a particular focus through a survey to understand the impact. Now, if the previous papers looked at consumers, this looked at the farmers. What is the impact they suffered from COVID-19 mitigation methods? It looked at the various issues mainly connected to market access that were created and had significant negative consequences on the ability of the farmer to get product out to consumer, and impacted the income and socioeconomic status of the farmers. So the mitigation methods really was the focus of COVID-19. The fact that it didn't solve, I think we heard about supply chain earlier, that the problems that were created in the supply chain weren't adequately solved for the farmers, and the fairly serious consequences that farmers face. So basically, to end, let me say the agriculture section looked at the double impact of COVID-19 restrictions on trade and mitigation policies. So the trade and mitigation policies are the two kind of policies that were looked at. And there were not only 2 sets of policies, but 2 sets of impacts, one on the consumer that had to pay more and got less nutrition, and the other on the farmer who couldn't sell and became poorer and lost income. I think these are very important papers for policymakers to understand better and to draw on when trying to decide what policies to make. And I think what these papers demonstrate is there's a great deal that can be used to inform policy that may not be yet being used before deciding on policy. The research is out there and can inform better policies for Sri Lanka and better consequences for all Sri Lankans consequently. So thank you very much.
Thank you very much, Dr. Nishad. Well, you gave a lot of new insights for policy intervention and our appreciation. Sorry, I forgot our research and innovation. And Dr. Vijayawardene also highlighted that if you want to leapfrog, we have to embrace innovation. So Professor Ajit, the always, he's the one is really driving force at Kosti. So floor is yours, Professor Ajit.
Thank you, Mr. Chairman. I thought this was a session lost, now found. Thank you. We had an interesting session because my co-chair was really actually a bundle of innovation energy, Manju Gunawardena. So there was a lot of interaction while the 13 papers were discussed, and we had a long, lengthy session yesterday and today. As we went from laryngoscopes to QR codes to the metagenomics and so on, we thought we will extract salient points to push for why research and innovation and invention, the process should be moved forward because this is an opportunity. That's what we believe. When you listen to all those presentations of these inventions, the inventors, they were not just, some of them were really serial inventors, and some had very serious professional backgrounds, and they are moved in. It's like this situation has pushed people for either you can flight or you can fight. So they have resorted more to fight, and in that you have come out with new things. One thing that reminded was Dr. Vijayawardene mentioned in one of the presentations,
that Schumpeter's invention, the innovation, the creative destruction aspect, and almost these were stated 90 years ago. And we are in 2020, it's talking about 1920s. And precisely what we need today, again, to go back, I mean, learn from this event and push for this invention, innovation, diffusion, and imitation. That's kind of reminded because most of the discussions, the 13 around that, we had almost all from the first wave time. These presentations didn't come from the second wave or rather the recent. And it's also interesting to see in these time periods, that time we were constantly every day getting ideas, new ideas were in the media. It was full of, okay, somebody's coming out with this gadget, that gadget, and so on. But today we don't really get that information. What has changed? And then what happened in those days, have they moved into some practical application? Where are they now? And some of these papers actually throw some lights on that. That should be understood how these scenarios are created. So inventions are not moving into innovations. That's kind of we felt in the discussion. Especially there was one paper that actually ended with the comment, process has been delayed due to unseen reasons. Not unforeseen, but unseen reasons. And we kind of connected two of the presenters. One presenter was the inventor, the other presenter was the institution that was doing. So we kind of tested, also connected to ask what's it. The message that we get is specifically from a public sector. And in this is you need to liaise or work with the private sector. We may perhaps have to change the ARFR funding and the whole concepts behind in supporting if the research is to deliver. The kind of procedures that we follow probably have to change. And maybe even now, we have been telling this, but it's probably now even try to look at this because research funding, the research management, the invention management to innovation cannot be supported by the same process being applied to all sorts of activities. This needs to be looked at differently and supported. Came across this word, recently heard what is called like the Peter Kotua thinking. That's out of the box thinking, right? It's important to think differently because in our sector, we are applying the same rules and throttling the inventor and the process is actually killed. So it's important to do this. We have to be different. And that's a message from a policy perspective. And also finding that lots of these people acting individually, they are whatever their findings are not being pushed in and they find themselves in trouble. I mean, even for the vaccine, you see this accelerator system in the globally, things are happening very fast. This time the vaccine came in 8 months, when usually it has been the last recorded was 4 years, right? So can't we do something like this platform to route all these findings through one gateway and maybe to support? Because the numbers do matter and when you show, a strength in numbers. And came to my mind, this is a little selfish, but the B2P Sri Lanka platform of COSTE should be looked into this because that was the exact objective of coordinating whatever happening in whatever the school student invention, maybe to the Bomiriya school, and we were identifying there has to be this single platform in this today's technology, it should be done. Because in SLIC paper actually indicated 350 inventions, 59 were selected for further support, and out of that, they expect 50 enterprises, right, or entrepreneurs to be developed. But the point is, our policies, our economic thinking actually is not embedding some of these inventions and inventors to play a very active, supportive role in developing the economy. I mean, we feel they're doing a great job. I mean, it's an interesting thing. We have support them, but we are not looking at them. They, in turn, contributing to the economy that have never been a part of our system, right? They are like, okay, it's interesting to hear, nice to watch, and that's it. Maybe we also add a few rewards to them as they move along, but the economy moves on a different track. And this disconnect is a problem, and so it should not be. And again, when we sometimes bring out ideas and show courses them in advance of intellectual property protection, we stand to lose because the process of intellectual property will not support when somebody has already displayed everything in front of the TV and today it's globalized, it's gone out and you will not be able to secure some of the property rights. So if they are of real value, we should have our processes right. And that was something that also came through in the discussion, whether most of them have kind of not looked at the intellectual property protection. And it's moving on without. And now you are in the open. It's all been recorded, videoed. Some were actually displaying the entire working video, and it should not be so. So there has to be this support mechanism. For in that, we have to have the Sri Lanka Standard Institute's National Intellectual Property Office, and specifically even these medical innovations that we've had in multiple papers in the session, NMRA has to be seriously proactive and supportive to the inventors. It was kind of coming over and over again that process was not there. And it had to happen because if you want to support and if you want to identify even the shortcomings, there has to be this proactive collaboration to support this process. So in that sense, to end up, it's like if you at least embrace this research, invention, innovation, this is the theme of our session. And there were many, but these 13 papers that finally came out. If you embrace them and if the message goes out in this time, that if you are to the decision makers embraces, okay, this can really give us something, and this is what we should be looking at, and it could be a catalyst that can change the kind of the new normal and to move ahead. Probably a virus is a blessing in disguise. And that, in a sense, reminds of, I think the opening day came up yesterday. The Indian industrial icon Ratan Tata's statement was identified. It was mentioned by one speaker, was mentioning that COVID-19 should enable the Indian innovativeness to be factored in for the Indian development. And India, of course, has shown the vaccine capital of the world and so on, that they have advanced. But for Sri Lanka, there's really the time to probably to bring research, invention, and innovation to the forefront to support the economic growth. Let COVID-19 be that opportunity space.
Thank you very much, Prasad Ajitalis, for the very important submission. That brings us to the end of the policy dialogue. Now it's I think almost 6 p.m. But when you look at the face of our participants, it's like 6 a.m. They all look very enthusiastic, quite fresh. I see Dr. Susipera also listening very attentively, right? In spite of a busy schedule at the ministry, the health department. So I will not take time. It's our DG, our former DG, Dr. Tamara. On the first day, I think she moved the vote of thanks, but we had a very interesting policy dialogue, and our panelists really made very valuable contribution. So on behalf of National Science Foundation, I wish to express my profound gratitude to our panelists and our chairperson of the session. Actually, for the last 5 to 6 months, they have been really putting their heart and soul into this and working with great dedication, devotion, and distinction to bring this conference to this level of success. And as informed before, we would be preparing a policy brief. So it is not just a talk shop. This will make a decided impact. We'll lay a foundation for transition, right? We will use this as a launching pad to leapfrog to development. And so we look forward to your interventions by way of the policy response before maybe 25th by Monday. It gives you a Friday, it's about 3-4 days. Now you have already made notes, but you could further reflect and send to us. I am appealing to our panelists and also our session chairs to send their submissions by 25th January. Then we will work together and prepare the first draft and send back to our panelists, chairpersons, and our session, our steering committee members for their feedback. So once we get that, we will have the second draft, and probably we will get feedback from others now, like Mr. Lloyd and others who could really go through, even some of our people like even Professor Malik and other our expert, their Galaxy. We will also copy to them for their feedback. I think Professor Saroj, you made very important submission that for the NSF also to way forward. We have noted that. So our appreciation. We see these young ladies, right? In spite of their family commitment, some are probably mothers with small children, but they have forgotten everything and they are married to COVID today. And I feel a little nostalgic. And we have been married to this for the last couple of months. It is no divorce, but we are going to produce the volume in few months, and we would like to see you engaged on continuous basis until we bring the volume. And many thanks to our NS staff and these young boys also there for NSF. So our profound appreciation. And finally, to BMICH and all who contributed in numerous ways to make a success. Our profound gratitude. And this there now, Doctor, my sister, you see, I think last life she's my sister, right? Professor Dilanti, she has been also a pillar of support and tower of strength. She has been helping out also by way of funding our activity. Our profound gratitude to Dilanti. We will work hand in hand and taking. You also have dream. We have a shared dream. We have shared vision. We'll take it forward hand in hand. Again, many thanks. Take care. All the best, dear. Good night.